Good morning, all. I request you all to please settle down. Our chief guest for today, Member of Parliament, Dr. Kanimori, will arrive in 5 minutes and we'll start the session in 5 minutes. Please settle, and I also request you all to please keep your phone in the silent mode. Our respected chief guest, Dr. Kanimuri Envian Somu, to the dais. I also request the management to please escort our chief guest, Sri Rajesh Agarwal IAS, Secretary of Ministry of Social Justice and Empowerment. Now I request the management, President Dr. Premro Palwa, Vice President Medical Dr. Cecil Ross, Vice President Development Sri Ramu Gadkar, Vice President Finance Sri Jagdish Sharma to please come to the dais. I also welcome Sri Dr. P. Nalini Padma Shri Laureate to please come to the dais. Now we'll start with the invocation and lighting of the lamp to formally inaugurate the ceremony. We will proceed to the welcome address and key requests by our President, Mr. Premrup Alva. Premrup Alva is a person with hemophilia B severe. He is one of the founder members of Hemophilia Society Bangalore chapter and the first youth chairman of HFI. He served as an EC member for 2 terms, which was followed by the role of the chairman of South Regional Council of HFI, and is currently the president of HFI since November 2021. He is a visionary leader and is a very dynamic personality, and we are very happy to have him as a president because of his far-sighted thoughts and his leadership qualities. Mr. Premru Palwa, please come to the dais for the welcome address.
Namaste. Thank you, Anu. Firstly, I would like to welcome our chief guest, Kanimoi, and Rajesh Agarwal ji, and all the management members in the dais. World Hemophilia Day. It's a big and a great honor for me to be presenting our key requests. But more important that for a person living, for people like us who are living with hemophilia, it's of huge significance. We have seen treatment from blood to the best products, which I didn't expect in my lifetime. And thanks to everyone in the audience, you are able to provide us with great care, with a lot of things which we never dreamt about. Our lives, our standard of life and standard of care have gone to a great level thanks to all the program officers and the joint collaboration of the State Ministry of Health and the Central Ministry. Today we have programs and we can take the programs to the next level. So today is a day where we can set focus and spotlight on the transformation of care from where we were and focus on where we are now and look forward for greater innovations and better standard of life. Again, I would like to thank you all for making our lives very much more fruitful. This is the seventh time we are conducting initiative of hemophilia care on World Hemophilia Day with a very nice collaboration with the Ministry of Health. Another proud moment for India today is G20 summit is happening in Goa on health. So our health ministers and the ministry people are very busy. They have supported us with the message. Minister of State has given us a message, and we are very happy that healthcare is being a focus. And on World Hemophilia Day, it's coincidence that there is a summit happening in Delhi, in Goa, focused on hemophilia care. Our work has not ended. We have to continue together to develop hemophilia, and we are. India is such a strong country, developed country, and we have so many committed program officers, doctors. Each year, our hemophilia community, our family has grown consistently. When we started Hemophilia Federation India in the 40 years back, in 83, by Ashok Bahadur Verma, there were only one or two chapters, and there were a group of 10 PWH and family members and very few doctors. Today, thanks to all the chapters and doctors, we have more than 110 chapters, 91 registered with us, few more waiting to be registered, and we have more than 200 HTCs at different levels. This is the commitment and the work which we have seen, and we are growing. Every year we see each state coming up with more and more HTCs, more and more treatments. We have a wide variety of treatments which we are accessible to, and we are thankful for that. And we acknowledge all the support we are getting from the government of India, and we appreciate it greatly. Looking forward, we always look forward. We are in a positive state of mind, and we always look forward. So there are certain areas where we could collaborate more and focus on further development of our cause. We are always looking at improvising our healthcare system in general, especially hemophilia care. We have to. Hemophilia is a disorder. All of us are born with hemophilia. We have to manage to live with hemophilia, and we take hemophilia with us. So it's very important that when the factors and the medicines are procured, that it has to be safety. We have to ensure that the safety and efficacy of the concentrates which have been bought for us is at optimal level. So quality first. Quantity is important. That is extremely important. Access to prophylaxis. Prophylaxis is the standard of care. It's prevention of bleeds. Hemophilia has the best of treatments available, and it's affordable. So there is no reason why we should not have bleeds. We should not be suffering the way we are suffering and missing out school. In fact, I have probably in the growing up days, we didn't have factors. I've spent more time in the hospitals than in schools. So the best way to do it is prevention of bleach is by providing prophylaxis. We can take it a level higher with home treatment. Specialized services and setup of tertiary care units are there, but it's an area where we definitely can improvise on. Inhibitor is a issue, and managing inhibitor has improved over the years, but we have to focus little more on it and allocate enough resources for inhibitor management at the state levels. It's not only hemophilia, is not just factor 8. It is factor 8 and factor 9, and inhibitors happen. So management of hemophilia inhibitors is extremely important. Education and research is an area where we can collaborate very well. Prevention of hemophilia is something again in our reach. It's in our hands. So we can set up CD carrier detection and prenatal diagnosis set up across the country to prevent future generation, which is a mutual choice. The choice of the parent is always there, whether they want to have the child or not. That is something which the government can very easily set up. Finally, we would like to have cure. And we are very, very, very glad that the government of India is collaborating with premium institutes to bring about gene therapy and cures, which is a very much a focus area. If we can do that, and if we can invest more time and resources on that, that is our final vision. So when we are talking about healthcare system, strengthening, especially when it comes to hemophilia care, what do we need? We need to have tertiary care centers or comprehensive hemophilia treatment centers, at least 1 to 5 in every state, which is a reasonable ask. In hemophilia, treatment first is the methodology which we talk about and what we need, which means that treatment has to be given, the earlier the treatment is given and quicker the treatment is given, lesser the suffering. So the treatment should be available in every district, and which is happening in most of the states. There are a lot of states which are providing the treatment in every district, and this should flow on to every place. Procuring medicines is one element, but distribution of them and maintaining the records and outcomes of the treatment is extremely important. So, for example, we have all kinds of treatments from Vonville brand to inhibitor management. We have products which are of different levels, including subcutaneous medicines. So this has to be distributed in a rational way across the state. So if there is no one Willy brand patient, there is no point of that medicines being there in that district. So there should be a systematic distribution process based on data, for which we yes, educating and training of medical persons is an always thing. It's more important at the state level because of the transferring of jobs. We would like to collaborate there, and we are collaborating there. What we need to have is also a national hemophilia registry. So when you have a registry, your distribution and data-based practices will increase, and that will take it to the next level. So you have a proper distribution pattern. You're sending medicines to a district based on the amount of PWH present in that district, and you're maintaining a record of why the treatment is given, which is giving you outcome results. That is a request which we have. And the referral system of the comprehensive centers which have been put up is extremely important. We are very, very thankful, sir, Rajesh Agarwalji, for being with us. Biggest concern is hemophilia leads to disability without treatment, and it does lead to disability. Now, we are very, very thankful to the Government of India for including us in the Disability Act. So we request you, sir, under your leadership and guidance, if we can get uniform disability systems where the other disabilities are getting, we will be greatly obliged. And job reservation is one of the major focus areas, sir. If you can provide it, that will be the best case area, scenario. And we are striving hard to be covered in all insurance coverages. Today, we have identified 28,630 PWH across the state, across the country. So our identification is only 15%. There is expected to be 1,600, 1,60,000 PWH in the country. So we have to focus on awareness through multimedia, through the government channels, through the broadcasting systems. Patient empowerment and self-management is something which Hemophilia Federation India does. With joint collaboration with the government, we can take it to the next level by training in self-infusion, recognizing of bleeds, pain management, and creating, again, I would like to emphasize on the necessity of a national registry. It's extremely important to have a national registry. It's extremely important to have a state registry. Document, it'll help in your procurement and in the distribution and outcome measures. Issuing of ID cards can be very easily taken up by the government of India, and it makes life easier. The people can travel from one place to another. So our primary request today is to have a national policy, at least to have a committee. We have committed in the government setup and in the private sector, hemophilia for over years in India. So at least start by creating a committee to form the guidelines, to form the policy. So that's our main request of the day, and this is what we are striving very hard. Again, me representing the hemophilia family and the hemophilia community, thank each and every one of you for being here today. Thank you so much.
Thank you, Mr. Prem Alva, for welcoming our dignitaries and for the very good summary of our key requests, which include good quality products with good quantity as well, and optimal distribution of the products, comprehensive care centers, genetic testing, and most importantly, a national policy on hemophilia. I would like to call upon to the stage Vice President Medical, Dr. Cecil Ross. Dr. Professor of Medicine and Head of Hematology at College Hospital, Bangalore. He has been volunteering for the cause of hemophilia and has been managing complicated intracranial bleeds, spine bleeds, pseudotumors, and has been an important part of clinical trials and research related to hemophilia, thrombophilia, stem cell research. I welcome Dr. Cecil Ross to speak on the topic, defining what a person with hemophilia needs. A huge round of applause for Dr. Cecil Ross.
Thank you, ma'am. Dignitaries on the dais, friends. Today I'm speaking on defining what a person with hemophilia needs. I'll start off by safe and effective treatment and preventive measures, a bit on understanding what clotting factor concentrates is, and the option of non-clotting factor and use towards normalcy. So defining what a person with hemophilia needs. He needs, normally any hemophilia will need a regular medical care, which is managed properly, either by a hematologist or a physician or a doctor who is aware of it. And he needs regular blood tests and monitoring of bleeding episodes. The next thing is we need to see whether it's possible to prevent inhibitors, and there it's important to find out what is the product of choice which is safe and efficacious, and access to newer and better products like non-clotting factor concentrates. Then there is also an aspect of emotional support, because living with hemophilia is quite challenging. because they are crippled by the time they are in teenagers. Most of the people who don't get access to treatment are crippled, and therefore it's a challenge to have a person with hemophilia in the family, and they will definitely benefit from emotional support both from the government, the family, the friends, and so on. Then, of course, education and advocacy, because hemophilia is not a well-known, not in basic syllabus as a big chapter in medical curriculum. Doctors need to be treated, patients need to be treated. The caregivers will benefit from education about patients with hemophilia, and the advocacy efforts that improve access to care and support, and affirmative action that is necessary from the Department of Social Justice, Disability, Ministry of Health, many other factors. Now, if you look at actually the treatment options that are available, regular medical care, which is managed properly, either you can have a plasma derived or a recombinant product. Plasma derived is something that is got from plasma, and it's made into a lyophilized powder, and that's given to the patient. On the other hand, you have a recombinant process that is made in a culture, mammalian cell lines, and then they produce factor 8, and that's recombinant factor, and that is given to the person with hemophilia. Now, either of these, the World Federation does not advocate one or the other, but whatever it is, the options that are available is normally like what the president was saying, Prem was saying, that you give blood, you give plasma, you give FFP, and so on. But then you have to go to the hospital for that, and the amount of product is very less. So then you have the option of factor 8 concentrate that's available in a bottle, and in which case home therapy is possible. Like I told you, you have the recombinant products, again, very good products that are coming in the bottle. It can be upscaled, so you're not limited by the amount of plasma that's available in the country. And then you have the newer ones, which are extended half-life or long-acting factor 8 or factor 9. And then now you have the subcute forms of various innovative uh, therapies. Now, either you give plasma derived or a recombinant factor, about 15 to 30% of our patients develop inhibitors. That means the normal factor 8 or factor 9 are not useful for them to prevent bleeding. So what happens? There is, when you develop inhibitor, you have difficulty in getting hemostatic support control. You have 70% higher mortality rate. You have risk of uncontrolled bleeding and worse joint outcomes, and then twice or thrice hospitalization, and the annual costs go up horrendously. Now, if you look at the government of Maharashtra, this is data from Dr. Chandrakala. Now, there are 4,500 patients there without inhibitors, normal hemophilics, and there are only 150 persons with inhibitors. But the amount of factor they consume, the cost consumption, is approximately 11 crores versus 1.9 crores for persons with hemophilia. So that is the importance of economic burden once you develop inhibitor. So therefore, you have now, and it's quite good that we have products made in India, make in India, all that sort of thing. But ultimately, what we need to do to prevent such complications is to have products that are meeting international standards, which are safe and efficacious. So, therefore, it's important that all these products should be have a element of product safety, product purity, and viral safety. Now, these are very critical because it's no point having a product and they give them and the person develops HIV or HBV or HCV or various viral infections that you get from the infusion. So, if you actually look at viral inactivation, you can kill the virus in the product or you can remove the product, virus from the product. So either you can have a viral inactivation processes, and many are using many companies use various products like terminal dry heat, vapor heat, and so on. And if you use pasteurization, the product may become immunogenic and cause a lot of inhibitors. On the other hand, if you have nanofiltration, which is the gold standard, then you have, because if you use nanofiltration of your products, and if you use 15 to 20 nm nanometer filters, then you can clean up the product ultimately with hepatitis A, parvovirus B, and there's a big log reduction, and all the worst of the viral inactivation neutralize occurs. So these products are safe. So if you look at the World Federation guidelines, they say that when you evaluate concentrates, solvent detergent treatment of current is a gold standard, and it removes all the infectious envelope virus, and nanofiltration is the option of choice when considering non-analytic viruses. So we should follow this guideline and see that our products meet these international standards. So from plasmid-derived products, you have recombinant products, and you have new mechanism of action products, which makes lives of patients with hemophilia very simple. And then you have, over a period of time, long-acting factor, which makes lives of patients much better. Ultimately, all these patients will have better joint function and near normal quality of life. So the game changer options, what are they? All currently licensed products are given by IV, and it's not easy to give IV. Either parents or patients will have to be trained to give IV at home therapy, or they have to go to the hospital. They have to attend hospital to be taught how to infuse. And when you have recurrent veins, imagine twice or thrice each time you keep giving the product IV, you can have vein damage and sometimes cause excessive bleeding. And if you just use it like insulin, subcute, it's much quicker and less equipment, no training at all. So that is what ultimately we need to do. And of course, gene therapy has now become a reality and evolving and impacting many treatment options again towards the cure. So if you are able to treat a severe hemophilia person by making him either moderate or normal range, then you can remove zero bleed. You can attain to get zero bleeding, uh, uh, zero bleed annually, or you can reduce the treatment burden, that is less frequent dosing, and then you have to aim towards normal life with widely available and accessible products. So what is normal? Normal means being able to take the first steps without much of a problem. Normal means finding a balance without fearing a fall. Normal means writing a 3-hour exam without health concerns. Normal means extraordinary people with hemophilia achieving things. And normal should not be a distant dream. It should be as normal as we can. Thank you very much.
Thank you, Dr. Ross, for sharing the needs, especially the products of international standards, complying with the safety standards and efficacy requirements, and most importantly, helping the hemophilics to have a as near normal life as possible. Now, I would request Sri Ramu Gadkar, Vice President Development of HFI, to share the vision and mission of HFI. Ramu Gadkar is an entrepreneur, safety engineer, and the father of a teen hemophilic boy. He has been volunteering for the cause of hemophilia for the last 18 years and has been the Regional Council Secretary of West for 8 years and Chairman of the Council for 3 years and is the Vice President Development currently. A big round of applause for Ramu Gadkar.
Good morning. Namaskar. Respected President Premji, Dr. Kanimoli Madam, Dr. Rajesh Agarwal Sir, Dr. Nalini Ji Madam, Dr. Cecil Sir, Jagdish Sir, VP Finance, all government officers, with my hemophilia family members here watching online also these hemophilia day to days. Good morning all again. कुछ कर रहे हैं। Hemophilia Federation started 1983 at late Ashok Bahadur Verma sir, who's himself hemophilic. Today there are 91 chapters and around 28,600 registered PWH. with close collaboration with World Health Organization, National AIDS Control, and World Federation of Hemophilia. Our vision, हीमोफीलिया विदाउट डिसेबिलिटी, चिल्ड्रन फ्री ऑफ पेन, हम उस तहत काम कर रहे हैं. हमारा मकसद है हीमोफीलिया विदाउट डिसेबिलिटी के साथ हम काम करना चाहते हैं. साथ में वन कंट्री वन ट्रीटमेंट के साथ हम काम ऑलरेडी कर रहे हैं. हमारा विजन है हीमोफीलिया फेडरेशन ऑफ इंडिया का. Our mission of Hemophilia Federation India, provide adequate and timely treatment. हमें टाइमली एडवोकेट ट्रीटमेंट चाहिए, प्रॉपरली ट्रीटमेंट चाहिए. आइडेंटिफाई न्यू पर्सन विथ हीमोफीलिया, हम आइडेंटिफाई करना चाहते हैं. हमारे पास 28,000 हीमोफिलिक्स है, बट एज नाउ हमें और ज़्यादा हीमोफिलिक्स को डायग्नोसिस करना चाहिए. तो हम आइडेंटिफिकेशन में हमारा मिशन है, हम उसमें काम कर रहे हैं. एजुकेट PWH एंड फैमिलीज ऑन हीमोफीलिया केयर, हमें हीमोफिलिक्स को एजुकेट करना है, उनके फैमिली मेंबर्स को एजुकेट करना है हीमोफीलिया के तहत. हम हेल्थ केयर प्रोफेशनल्स के लिए रेगुलर CMEs कंडक्ट कर रहे हैं. हमारा मिशन में वो है कि हम रेगुलर अगर CMEs कंटिन्यूस मेडिकल एजुकेशन प्रोवाइड करेंगे तो डेफिनेटली हमारा जो गोल है, अचीवमेंट है, वो हम डेफिनेटली अचीव कर पाएंगे. हमारा एक मेन प्रिवेंशन में भी हम ज़्यादा काम कर रहे हैं. साथ में प्रिवेंशन होना भी जरूरी है. प्रिवेंशन का रिजल्ट हमें नेक्स्ट 10 साल के बाद मिलेगा, बट हम उसके ऊपर काम कर रहे हैं. CDPND में हम काम कर रहे हैं. CDPND के तहत हम लैब्स डेवलपमेंट कर रहे हैं अक्रॉस इंडिया. डेवलपिंग स्टेट एडवोकेसी कमेटी, हम वन कंट्री वन ट्रीटमेंट के तहत जा रहे हैं, तो हमें हर कंट्री में एक एडवोकेसी कमेटी फॉर्म की है. उस एडवोकेसी कमेटी के तहत हम लोकल गवर्नमेंट के साथ एडवोकेसी करेंगे. एनरोलिंग इनटू डिसेबिलिटी सर्टिफिकेट इन अवेल. हमारे साथ में राजेश अग्रवाल सर आज आए हुए. हमारा बहुत खुशनसीब है हम कि सर उनके स्पीच में हमारा जो डिसेबिलिटी का इशू है वो कवर कर लेंगे. मैं आशा करूंगा सर से. हमारा NHR एनालिसिस आप देख रहे हैं, 2010 से लेकर 2023 तक हम कैसे हम आगे पेशेंट डायग्नोसिस कर रहे हैं, पेशेंट रजिस्टर कर रहे हैं, आप देख रहे हैं. ये ब्रेकअप है PWH का. हम फैक्टर 8 22,966 है, फैक्टर 9 3,700 है. VWD एंड अदर ब्लीडिंग डिसऑर्डर का ये ब्रेकअप है फैक्टर हीमोफिलिक्स का. हम 36 स्टेट के साथ में 30 स्टेट में हम हमारा गोल अचीव कर चुके हैं. सिर्फ 4 स्टेट है हमारे साथ में जिनके पास में अभी हम फैक्टर नहीं ले पा रहे, बट हम नेक्स्ट आने वाले सालों में ये भी हम अचीव कर पाएंगे. लद्दाख, मिजोरम, नागालैंड और सिक्किम, जो 4 स्टेट है उनमें हीमोफिलिक्स को फैक्टर्स नहीं मिलते. तो हमारा एक गोल है, वहाँ पे हम डेफिनेटली फैक्टर का सपोर्ट उस गवर्नमेंट की तहत हम एडवोकेसी करके वो अचीव कर लेंगे. सेंसिटाइजेशन ऑफ हीमोफीलिया केयर, हम आप देख रहे हैं 2015 से हम ये ISC कंडक्ट कर रहे हैं. 2015 से लेके अभी ये 7वां टुडे वी आर सेलिब्रेट 7th IST सेलिब्रेशन विथ डॉक्टर कन्नीमूली मैडम एंड राजेश अग्रवाल सर. नेक्स्ट थैंक यू. अच्छा, दिस इज द वन बैनर. लास्ट ईयर आप सब जानते होंगे हमने वन कंट्री वन ट्रीटमेंट का एक लोगो निकाल के सब चैप्टर को भेजा था. ये बहुत सक्सेसफुल हो गया था. ये डॉक्टर नलिनी मैम का चैप्टर है, पांडिचेरी महात्मा गांधी जी का लेकर हम ये फोटो लिए थे कि हम वन कंट्री वन ट्रीटमेंट का जो अचीवमेंट है जल्दी हम कर लेंगे. और इसी के साथ में बहुत बहुत धन्यवाद आप सभी का, आपने अच्छा से वॉच किया. थैंक यू.
Thank you very much, Ramoji, for sharing the mission and vision, that is identification of undiagnosed people with hemophilia and bleeding disorders, a national policy for hemophilia and bleeding disorders. Now, I would request our guest, Sri Rajesh Agarwal, IAS, Secretary, Ministry of Social Justice and Empowerment, to speak about Hemophilia in Disability Act its implications. Inclusion of hemophilia in RPWD Act 2016 has been a much awaited milestone for the hemophilia community of India. The policymakers of GOI was immensely helpful in this, and we look forward to the day of inclusion of hemophilia in job reservation as well as rectification of the few lacunae in the Act. We are very privileged to have with us today Sri Rajesh Agarwal, Secretary, to speak on Hemophilia in Disability Act implications. To all of you, please put your hands together for Sri Agarwalji.
Good morning, friends. I have come more to learn from all of you rather than speak about things. I joined this department about 6 months ago. I have done various stints in state and central government in other ministries. And the purpose of society and the governments, which includes health department, our department, and so on, is to ensure that every person gets the best of diagnosis, treatment, and then to lead a comfortable life and to reach their potential, best potential in life. And hemophilia was included as one of the blood disorders in 2016 in 21 disabilities. Earlier we had 7, now we have 21. And I'm told that apart from one constant complaint about getting not included in job reservations, in many fields this has helped. On the diagnosis part, I was talking to some doctors present here, and obviously there's a huge rural-urban divide. Official numbers are about 30,000. Actual numbers could be 1 lakh or even more. So this is like an invisible disease which many times go undetected and can be fatal. If the parents are unaware, if the local doctor is unaware, and it can be fatal at childhood also. So it's very important that governments and private sector invests enough on the treatment part and on the basic elimination part also if possible. So we don't know what future will bring. So many genetic diseases could be eliminated in future, one doesn't know. In COVID, one saw the artificial intelligence and that also being used for mRNA vaccines for the first time. So the diagnostic methods and the treatment methods are evolving quite rapidly. So one obviously is the diagnosis part. Second, I'm happy to note from my interaction with all of you that getting a disability certificate is reasonably okay. It cannot be perfect, but it's not too much of a problem because it's an easily identifiable in medical diagnosis terms. We find it much difficult to get ID kind of certificates. The psychologists are not there across the country and so on. So ID certificates, especially for young kids, are very difficult till the age of 6. I was listening to the talk about registry of people, etc. So we are analyzing the data of UDID of 90 lakh certificates we have issued so far. And probably in April end, we will be putting aggregated anonymized data in the public. So I have data till block level, till below districts we have blocks, about 7,000-8,000 blocks in the country. So age-wise, gender-wise, and 21 disability-wise, anonymized data that we'll be putting in public domain without patient names, obviously. So some of you might find that useful to get the all India perspective and how it is changing with age and gender and so on. So that could be useful for research and diagnostics. Then I'm told that one benefit which getting it into disability has done is that many state governments had started providing budget lines for this. Now, in hemophilia and in general in disability sector, we talk of three factors: the awareness, access, and affordability. And these three apply in this case also. The parents and the doctors in your area have to be aware of the things, aware of diagnosis and aware of treatments. Second is access, because you have to approach hospitals quite repeatedly. The hospitals, treating hospitals, it can't be 500 kilometers away. For example, now we have asked LIMCO to set up at least 100 centers for prosthetics across the country, so that within 50 kilometers one can walk and have artificial limb or whatever. So similarly here, the more and fairly distributed number of treating hospitals is required. That is access. And affordability means the poor should be able to get free treatment at government hospitals or empaneled hospitals. And those who can afford, they should also be able to get it at reasonable price. And one thing we have been finding is that insurance sector sometimes is unfair to people with disabilities. And even if you're willing to pay even 20,000 rupees per annum and you are a taxpayer, and still they will not do insurance if they come to know of your previous history. So those things are also changing. High courts and Supreme Court are aware of it. Many cases are going on. And ILDI has also told all the insurance companies that you have to bring products in next 3 months. And 2-3 companies. So that is one part. Then second is obviously the education is very important. People should be able to go to schools, and I'm told getting into disability has helped in way of लगाते हैं और करते हैं, आप पेपर में तो बैठ गए. So this part needs more sensitization. So there I believe your organization needs to work with school education department especially, that whenever school education through NCRT, NCT, etc. takes teacher training programs, maybe half an hour module on this, so that many teachers become sensitive to this and provide these reasonable accommodations. So reservation is one part, reasonable accommodation is another. Same is with jobs. Frankly, I have not seen the old files. I will go and in my office see the old files, why this decision was taken and at what levels. But now, frankly, more jobs are in the private sector than in the government sector. So again, the reasonable accommodation parts become very important. Whether you are in the government job or the private job, if you have to take 4, 5, 6 days off in a month, in a particular month, then again your colleagues and supervisors have to be sensitized about reasonable accommodation part. And now I talk to a lot of HR managers and CEOs of a lot of companies. And frankly, ESG and diversity part is becoming very important for all big companies and multinational companies. And if properly sensitized, they do provide reasonable accommodations. But again, your organization also has to become proactive on that part. And we will be very willing to work with you to do webinars on this along with the RCI and others, with HR managers of whatever government sector and private sector you tell us. And same thing with the teachers to work on these aspects. On UDID, we are now, I've been lucky to be part of Aadhaar process in the country and UPI. So again, we are now working with a lot of government departments and other private players also, that if you indicate your UDID number, so consent based, that you will get access to a number of employment portals, that you give your consent while applying for UDID, or later on also maybe in 3-4 weeks we'll start sending SMSs and emails to contact numbers in UDID database, that these are the services available, and if you agree to consent based data sharing, that we can open these avenues for you in the, whether it's various employment portals, or whether it's, for example, going to IRCTC website and indicating your UDID number and getting the concession and getting lower berth, etc. So, so at a number of places, quoting UDID number should fetch your data and help in the getting those concessions without providing for any other documentation. So we are working with a lot number of partners on this, and probably mid-May, May end, we'll start rolling out services one by one. So I'm personally supervising all the IT teams working on this. So these are a few points I thought I will share with you. And as I said in the beginning, I have come to basically interact with you and learn from you. And in our department, frankly, hemophilia has come later on. Department is quite old, and separate department is not that old, but it was a part of social justice earlier. And many state governments are now setting up different department of disability, and that will, so you need to again sensitize and work with all government departments, state levels, and even in bigger municipal corporations on this, and we'll be willing to collaborate on that part. So as I was saying, in RCI and in CCPD office and in my own ministry, frankly, the blood disorders and the acid attack and SLDs, special learning disabilities, these are relatively new. Second, the numbers are frankly, luckily smaller than compared to other disabilities. And also, frankly, visually impaired, speech and hearing impaired, and people with intellectual development disorders, they basically consume more of our attention. So then it becomes more important for all your office bearers to be slightly more proactive in interacting with me and my team, so that you keep us sensitized on issues related to hemophilia and other blood disorders. And I'm sure, and I assure you that my ministry, my officers will work along with you wherever we can work together for the benefit of all persons, so that they get better, more affordable treatment at more centers fairly distributed across the country. And apart from the job preservation issue, which is a bit tricky one, so all other matters will be working very closely. Those files I have to see, so I can't commit at the moment. Thank you so much.
Thank you very much, sir, for the insightful speech and sharing with us the services available with UDID number and the importance of sensitization of teachers during teacher training program and sensitization of employers so that leaves and other things can be accommodated for people with hemophilia. Now, as a token of love and appreciation for sharing his valuable time, and for all the services and support that he is providing to the hemophilia community. I would now request our President, Premru Palwa, to kindly present a memo to the guest speaker, Sri Rajesh Agarwalji. Thank you, Prem. It is indeed our great pleasure and honor to have with us our chief guest, Dr. Kanimuri NVN Somu, Member of Parliament, Rajya Sabha from DMK. Dr. Kanimuri completed her MBBS from Kilpakkam Medical College, Chennai in 1988. She completed a PG in Obstetrics and Gynecology from Ramachandra Medical College and Research Institute, Chennai. Dr. Kanimuri NVN Somu is the founder of Thai Mai Maternity Hospital, Chennai, and is a renowned obstetrician and gynecologist and has successfully delivered over 2,000 children. With great concern and care, she focuses on women's health, conception, childbirth, maternity, pre and post maternity care, and these are our areas of expertise. She carries with her the legacy of her grandfather, Sri N.V. Natarajan, and one of the greatest five leaders of DMK and great patron of Tamil language. He was the first secretary of DMK Chennai, first secretary of DMK, and Labor and Backward Community Welfare Minister with Dr. Kalainar Karunanidhi. Her father, Sri N.V.N. Somu, was a lawyer and is known and appreciated for his social service. He served at important designations, including the Joint Mayor of Chennai and as legislative member. Sri NVN Somu also served as the Joint Defense Minister, and we lost him in a helicopter accident while on an inspection on the problems faced by soldiers. Following the footsteps of her grandfather and father, Dr. Kanimuri NVN Somu is also involved in public service by raising questions in the Rajya Sabha on the problems faced by the public. She has been registering the problems faced by public, especially on women's issues, via her questions and holds the record for asking the most number of questions and taking part in debates in the parliamentary sessions. We are happy that she also raised question on rare diseases in December 2022 session and brought to attention that CMA, SMA and hemophilia requires attention of central government. Madam has also held the post of MP, Parliament Group Member, Member of Medical H and FW, DMK State Doctors Group Head, News Pro Head, Member of Parliamentary Standing Committee. Dr. Kanimuri goes with the motto that individuals' growth and welfare is the society's welfare. Societal welfare is the country's welfare, and this is important for well-being of all. I now request and welcome Madam to please address the gathering.
Thank you, ma'am, for the introduction. Respected dignitaries, I first thank all of you on this floor for giving me an opportunity to be part of this World Hemophilia Day, which is being celebrated with a theme of access for all. In continuation of the last year, when I was just going through the last year theme, they had put it as in continuation of the last year theme, access to all, towards which the Hemophilia Federation is also working. Until I spoke in the parliament, I was not aware of this kind of a hemophilia federation which is existing in India, to be very honest, because my subject was obstetrics and gynecology. Though in college days we have read about hemophilia, we don't go into the depth of it once we start the practice, unless we land up in seeing a case. And very rarely a gynecologist land up in seeing a hemophilia. It's more common in males. So we land up only seeing thalassemia traits more in our practice. So only when I was preparing a special mention in the Parliament to be represented. Actually, I got a representation from the Tamil Nadu Hemophilia Association to speak upon this. That is the time I really went into the real depth of this Hemophilia Federation. That's when I understood how this federation has been there for the last 40 years, tremendously tiring work, and having 94 centers all over India, which I really was surprised to see with the tireless and effortless work of all these people have brought to this level. Uh, then I almost went into the depth of all those things, and then I understood this really needs an attention in the society. That's the reason which really took me up to give a representation. I'm just putting forward the representation which I had given to the government, which I think it should be said here. It said protocol of prophylactic care to prevent the bleed instead of on-demand care should be introduced. Support the state in establishing a comprehensive program. The Ashadara, which is currently still under the review for the approval of the Ministry of Health, needs to be taken up faster. To advocate to establish a scoring society, the capacity and capability of building, monitoring patient outcomes, especially the drug which has recently come up. The imizumab is a drug which has with 12% GST, which is currently used. We're asking for a GST waiver and to bring the rates down. So these were the representations given. But now our president, the moment I spoke this in Parliament, immediately I received a mail from the president of the Hemophilia Federation, Mr. Prem, immediately thanking me for bringing me up this. Now he has also put forth a lot of other queries to be put forth in front of the government. He wants a compromised policy. He was telling health was a state subject. No, sir, it's a concurrent subject. Unless it comes from the central government of India, I think all the uniformity in all the states would be better taken up in all the states if it comes from the center. So as represented by the president and the Hemophilic Federation, I would take it up. I've already given a representation to our Minister of State, to Bharati Parveen, and to the Minister of Health, Sri Manshukh Mandia, regarding these representations. I would in future take it up with them, and anything from your side which needs to be added and to be introduced as a policy decision, I welcome, and I would request Mr. Prem to give it to me so that I could take it up and really part of it in to be happy to be part of it in this program. And one is on this floor for giving me an opportunity to take part in this. Thank you, one and all.
Thank you, madam, for the very all the support that you are providing and for the very valuable words. Now, as a token of our love and appreciation, I request our President Prem Palwa to please present Dr. Kanimuri madam with a memento and a bouquet. Government of India. Though Madam couldn't be here today physically with us, Madam has sent a message, and I request Arun Wagji from Nasik chapter to please be present here to share Madam's message with all of us today.
Okay. So Dr. Bhati Praveen Pawar ma'am has sent a message to hemophilia community. I'm requesting Wag sir to read it out.
Good morning, all. Respective dais and respective doctors, and my friends and colleagues. We meet our Minister of State Health and Family Welfare, Government of India, Dr. Bharti Praveen Pawar, and he has sent a message. Dear friends, I am very happy to be a part of the observation of World Hemophilia Day titled as Initiative on Hemophilia Care 7, ISC 7, a sensitization program and the way forward. I am glad to address you today on the occasion of the World Hemophilia Day. The day is dedicated to raising awareness about hemophilia and bleeding disorder community. The Hemophilia Federation India is delightfully working with various departments of the health ministry to address the issue related to hemophilia. Today, we celebrate the strength and resilience of those living with hemophilia and their families. We acknowledge the challenges they face to commit their courage in overcoming them. We also recognize the importance of education, early detection, and timely treatment to ensure that those who with hemophilia can lead healthy and productive lives. I am pleased to know that the Hemophilia Federation India is bringing policymakers, healthcare professionals, hemophilia care providers, and domain experts on one platform through this program. The National Health Mission, NHM, Ministry of Health and Family Welfare, Government of India is committed to improve the lives of those living with hemophilia through treatment support. I am pleased to share that our Honorable Prime Minister Narendra Modi ji also extend his support to noble cause. His commitment to improving the lives of people with hemophilia and other bleeding disorders in India is unwavering, and his backing lends significant momentum to our efforts. The Prime Minister gives importance to hemophilia and immunoglobopathies. A project has been recently announced for the sickle cell anemia. NHM is supporting hemophilia and providing factors free of cost. This includes increasing access to care and treatment, supporting research into new treatments and therapies, and raising awareness about the disorder. Further, we also like to assure you that we also jointly work with the Hemophilia Federation India to form a national committee for formulating national hemophilia guidelines as we mark this day. Let's us reform our dedication to individuals with the hemophilia and other bleeding disorders. Together, let's us strive to ensure they receive the care, support, and resources necessary to lead full, vibrant lives. I am confident that Federation India will continue its selfless service to the hemophilia community in India, availing their pain and suffering, seeking sustainable solutions to address this challenge. I wish the Federation a grand success. Thank you.
Thank you, sir, for reading out the message. Now we would go forward to the next segment, that is felicitation of Padma Shri Dr. P. Nalini by our chief guest, Dr. Kanimuri N.V. and Somu. A few words about our beloved Nalini Madam. Madam did her schooling in Bangalore did a MSc, BSc in Sita Lakshmi Ramaswamy College, and completed a MBBS from JIPMA in 1969. She completed a MD in Pediatrics in 1973 and DCH in 1973 from JIPMA, and has been in various positions from 1970 onwards in JIPMA, and rose to the position of Director, Professor, before taking voluntary retirement in 2003. Madam has been an important member and the heart and soul of Hemophilia Society Pondicherry chapter. Madam worked in Pondicherry Institute of Medical Sciences for 7 years as professor and head of the Department of Pediatrics. She's a resident of Pondicherry for more than 50 years. Her areas of interest include hemophilia care, and she has been involved in hemophilia care for the past 35 years. Madam is the founder of Hemophilia Society Pondicherry chapter and has been instrumental in establishing the treatment and care in the Union Territory of Pondicherry. She managed to get a building for the society from government donated by Indian Oil Corporation. And because of her continuous efforts, treatment for PWH is available in JIPMA, Indira Gandhi Government Hospital, Pondicherry, and Government General Hospital, Karakai. She personally helps the underprivileged people with hemophilia by helping Mangal Sutra for their marriages. She also had held various government positions like member of the Child Welfare Committee for Government Children's Home, member of Government Adoption Committee, member of Committee for Welfare of Differently Abled Children, currently member Advisory Board, Social Welfare Department, Pondicherry, resource person for NSS program, resource person ICDS, resource person Academic Staff College, Pondicherry University, counselor for adolescent children. Awards and accolades include Lifetime Achievement Award by Puduvai Pedicon, APJ Abdul Kalam 2021 for her yeoman services towards hemophilia care by Puduvai Pengal Padugappu Matram Munnetra Amaipu, Mahatma Gandhi International Peace of Award by All India Congress Social Organization, Lifetime Achievement Award in recognition of her contribution to hemophilia care from International UNICEF Council France, Certificate of Recognition for Hemophilia Care from ESAS, FACE Bharat Ratna Award from Facebook Group Organization, also released of Dr. P. Nalini by Indian Postal Department, and Lifetime Achievement Award from Indian Medical Association. Dr. Padma Shri Nalini Madam is a popular pediatrician, an eminent medical teacher, a good public speaker, and more importantly, a socially conscious doctor. I request our chief guest, Dr. Kanimuri NVN Somu, to please felicitate Padma Shri Dr. Nalini Madam. I now request Dr. Nalini ma'am to share a few words with us.
Dear friends, good afternoon, everybody. Well, this Padma Shri has been conferred to me for the work done for hemophilia. It is not my award. I worked for more than 35 years, but it's not. I have already declared That is not my award. It is the recognition of hemophilia at the national level. That is what is important, and we have to work for that. This gives us the impetus to work further for for further hemophilia, because we have many more to be identified. We have the whole chunk of women's group, the bleeding women, whom we have not identified. We have only very few people. We have the whole Vaughan Brands people, and also we are now recognizing factor 8 and other rare deficiencies who have to be also taken care of. We have the hemophilia children. We have to do many more things. It is not my award, it is your award. It is the hemophilia patients award. I want all of you to get up and then have a clap for us and pat at the back. Get up, please, all of you get up. Let's have a, this is for hemophilia. This award is yours. This is not mine. That is what I tell you. Please go on further and work for you. I'm always with you. I told, when the Prime Minister came round and then congratulating everybody, I just told him, we want more factor. We want recombinant factor for our children and our hemophilia community. How it can be done, please let us know. He said, we can do it under Atmanirbhar. You come and see me later. I said, I will not come alone. I will come with my Hemophilia Federation and other people and then talk to you about how to produce more factors, because it is not enough. And then the plasma-derived factor, I am always worried about, because double, according to World Federation, we have to have double screened plasma, which is not available in India. And then I don't know the source of plasma, how it is viral inactivation is done. We are not very sure. We have to have some plasma derived, but we also have to have a lot of recombinant factors. It is not enough if we have only factor 8. We have to have factor 9. We have to other factors, Vaughan Willebrand factor. Many more things have to come. So, and also we have to think of prophylaxis, which is non-factor prophylaxis, which is very expensive. So when are we going to do all this? We'll have to see. We have to work further, more diligently, cooperate, be united, and then work together. Let us represent ourselves. If we have a higher political will, if we have the most important political will, it can be done. I told him also, I told the Prime Minister, you had the political will to get the corona vaccine in no time, the highest corona vaccine, and prevent corona in India. Same way you should do it for us also. He said, in Atmanirbhar it can be done. Please come and see me. So I want all of you to cooperate as doctors, as hemophiliacs, and all others to cooperate and then see that this is done. Thank you. Jai Hind.
Thank you, madam, for the very great words. Now, we have a very important launch today. Hemophilia being a life-threatening condition and being a lifelong condition, we are always on high alert. And we might be traveling somewhere, but we don't know when we'll get a bleed or when we would need some factor support. So we are very happy to share that HFI has taken the initiative to develop a WhatsApp support helpline, and this was designed and developed by Saudi Alam. Sagar Gantote Amit. The WhatsApp support helpline will be launched today. Great support to all hemophilics whenever you travel. I would now request Sri Rajesh and empower to launch the helpline system. Dr. Kanimuri, Envy, and Somu to together please launch the WhatsApp helpline system. Now I request our Vice President Finance, Dr. Mr. Jagdish Sharma, to please deliver the vote. Sharma is a person with von Willebrand's disease type 3 and recently retired from the post of Principal Government School Education Department. He has been associated with HFI for over 28 years and is the founder of Hemophilia Society Jammu chapter. Due to his advocacy efforts, free factor support is available in the state since 2010. Mr. Sharma has held various posts in HFI like Chairman of North Regional Council, Executive Committee member, Finance Committee member, and is currently the Vice President Finance. Sharma ji, please, I request you to please come to the stage to deliver the vote of thanks.
You propose a vote of thanks. I would like to thank all the hemophilia members and all the VIP dignitaries just with a shawl. It is customary to honor them with a shawl. I thank. This is a way of thanking the hemophilia for the honor conferred on me. It is our honor. So I'd like. One minute. Please come. Come. You come. Bring the things. எல்லாத்தையும் எடுத்து போட்டு என்ன பைத்தியம் மாதிரி சீக்கிரமா மேல வந்து come fast. Keep on. Come, get out top. First to our secretary. Told you all, there is no hemophilia. There is no hemophilia. You have to work further. This is an impetus to tell us that it has to, you have to work further and further. PC members will do. No, now itself I'll go down and give. Meanwhile, yeah, please.
I will take 1 minute from you.
Yeah.
To my elder sister.
Thank you.
Let me take this opportunity to garland and shawl on my Agarwal brother.
All the EC members.
Many members are my friends.
This you can see.
And to Kanmoy, my member of parliament. Madam, I'm Jellikattu committee chairman. And we will be meeting very after Jellikattu soon. Okay. Like today in the afternoon will be.
Good afternoon to all of you. Thank you is such a prayer that can't be seen or touched. It must be felt by the heart. I feel honored and privileged to get the opportunity to propose a vote of thanks on this special occasion. I would like to thank all who blessed us with their presence. I am very much thankful to all of you. Words are not enough to thank their consent, guidance, and support to shape the conference. I, on behalf of the Hemophilia Federation India, convey deep regards and heartily thanks to our honorable chief guest, Dr. Kannimoi NVN Somu, Member of Parliament, Rajya Sabha. I am thankful to Shri Rajesh Agarwal Sir, IAS, Secretary, Ministry for Social Justice and Empowerment, Government of India, for taking time out of their busy schedule. My sincere thanks to Padam Shri Awadi, Dr. P. Nalini, for the gracious presence and for the continued support. We are special thanks to our today's chief guest, Ms. Kannimoi, that she has raised a question in the parliament on the hemophilia issue. That was the really our genuine demands. That was our really a genuine request. And this was a great issue, and government at least come to know what is the hemophilia and what we are doing for the cause. I think we have the special thanks to our today's chief guest, Ms. Kannimoi. Once again, we are special thanks to our guest of honor, Shri Rajesh Agarwal ji. When we go to their office, myself, Prem ji, one or two members were there, and they have listened our problems so sympathetically and take a keen interest. What is the hemophilia? How it this and that? Each and third where they had done the discussions, and they assured us, like today and on that day, definitely we will take care, and I will be try my best to clear your all the pending demands. We are highly thankful to our Secretary, Ministry for Social Justice and Empowerment, Agarwal sir. Today my words are not enough to express the gratitude to the NHM officials, doctors, our lifesavers, next to God, healthcare professionals for accepting our invitation and making it a grand success. I thank all the key persons without whose support this would not have been possible. Lastly, I thank all the staff of HFI for being of immense help in organizing the such program. If time is money, then today we have spent millions for us. Thank you once again for making this sensitization program initiative on hemophilia care 7 a grand success. Hope you all had a wonderful stay. Enjoy networking with your competitors and the technical session that follows. Thank you. I love you.
Thank you all for being a very good audience and encouraging our speakers. With this, we come to the end of the inaugural session and we are moving forward to the technical session. It's our pleasure that the technical session starts with a very good speech by none other than Professor Alok Srivastava, Professor of Medicine, Department of Hematology, CMC Vellore. We all know that he's the last word in hemophilia and is the one who authored the guidelines on hemophilia treatment. Professor Alok Srivastava will speak on hemophilia care, changing paradigm and its application in India. Sir, I request you to the stage, please.
Good afternoon, everybody, and thank you for that introduction. It's a great pleasure to be invited to this meeting. You see the picture of Mr. Ashok Verma put up there. It was 1988 when Mr. Verma came down from Delhi to meet us in CMC Vellore, asking for us to get involved with the Hemophilia Federation India. And that's how we began interacting with HFI now, 35 years ago. The story of our institution, the Christian Medical College Vellore, getting involved with bleeding disorders is much older, started in the 1950s or 60s. And so what I thought today, if we can... Sure, thank you. Sorry to leave and interrupt. We will catch up with you in Chennai. Thank you, sir. Thank you. Thank you. So while this shift is happening, maybe you can put on the slides. It might help people see what I'm trying to say. So, our institution has been involved with bleeding disorders and care for people with hemophilia from the 1950s, 60s. And so what I thought today I'll do is to trace for you some of the changes that have happened over these last 40, 50 years through the life of one of our patients also who has gone through this. So if we can get the slides up, can we? You had the slide, right? No, man, don't do it. But unless you showed, then nothing nobody will see. They are working on that. So can I put my slide there directly? अरे वहाँ दिखाएं यार सर वो प्रॉब्लम आ गया वो वही देख वो मेरे हाथ में नहीं है So it looks like we can't show the slides. मेरे देखने से कुछ नहीं होगा ना
ये लगेगा ना? ठीक है, छोड़ दीजिए। Really extremely sorry, sir. ये पढ़ना है।
Okay, we've sorted out the technology. So I'll talk to you about somebody who's now in his 50s. He has severe hemophilia A. He was born in Vellore. In the late 1960s, he managed to get good education, is gainfully employed. He has a family. He was diagnosed with severe hemophilia in the 1970s, less than 1%, when he had presented as a 2-year-old, maybe at that time, with oral bleeding. And in those days, we only had blood bank products, whole blood, fresh plasma, later fresh frozen plasma. And he had multiple bleeds in his joints, which were replaced with mostly blood bank products. Now, what was happening in the rest of the world? We know that in Sweden and in Netherlands in the 1960s and 60s, between Ingemar Nielsen and Dr. Van Creveld, they started the concept of regular replacement therapy, first using plasma cryoprecipitated and later clotting factor concentrates. And regular replacement therapy, prophylaxis against bleeding became the standard of care in the West from the 1970s. Unfortunately, in the medical literature, episodic treatment continued to remain as one of the options of treatment. In some ways, it was our mistake, having had the privilege of having led all 3 editions of the International Treatment Guideline. I take part of that blame that we did not emphasize early enough that we should not have kept episodic treatment as a long-term treatment option. So we made that correction soon. Now, what happened to this individual? Now, born in the late 60s, he went through early childhood and young adulthood with multiple complications of bleeding because he was not receiving regular replacement. A story that many people in this room are very familiar with. He had bleed in his joints, he had bleed from soft tissue, he had some dental procedures, and all of this were treated mostly with plasma or cryoprecipitate till the late 90s to early 2000, when we had more availability of clotting factor concentrates and also some recombinant factors that used to come through donations. Now, based on all this, he was getting treated, but then he was having multiple bleeds in the joints. And he, once a year, many people in Tamil Nadu go to a particular pilgrimage. They climb a hill with a temple on the top that has about 1,300 steps. So till his early 30s, he was able to do that. But then after that, he had to stop because he could not climb anymore. And therefore, what this showed was that even regular episodic treatment really does not help prevent long-term damage. Now, in the world, as I said earlier, we finally, in the 2020 edition of the guidelines, made some very unequivocal statements. And those unequivocal statements are that the standard of care for all people with severe hemophilia has to be regular replacement or prophylaxis with clotting factor concentrates and nowadays other hemostasis products to prevent bleeding rather than treat bleeding. And this should start early. Because if you don't start early, then you may have subclinical bleeding that would have caused joint damage even before it becomes clinically evident. And that episodic treatment should not be considered a long-term treatment option. So while we are greatly appreciative of more than 20-25 states providing budget for hemophilia, it's a great thing. But till they move to regular replacement, we should not think that we have achieved what we need to achieve. So it has to move to regular replacement. Now, regular replacement has its own challenges. The standard half-life products required 100 to 150 injections every year. Imagine giving intravenous injections 2 or 3 times a week to a small child. It was a major challenge in terms of convenience and compliance. One of the major problems of factor replacement therapy from the time it started in the 60s is that people develop antibodies to these products, which are called inhibitors. Now, because of these antibodies, these factors don't work. We know that. Almost 20-30% of people get these inhibitors. In any other disease, such a drug would have never been used. Unfortunately, here we had no choice, so we continued to use it. Now, what happened is that we now have, and the efficacy of this also in the highest doses of prophylaxis still had 1 to 3, 5 bleeds every year. Now, that sounds low compared to 20, 30, 40 bleeds per year. But when you add up over 5 or 10 years, even 1 bleed per year, 10 or 20 bleeds in 20 years, by the time the child grows up from a very young age to a young adulthood, 20 bleeds and you still have damaged joints. So how do we change this? So we needed new products, new approaches. Now this was for the people, 25-30% of people in the world in the more advanced economically advanced countries who could access these products. For all the rest, including most of us in India, there was no access to these products, and therefore they of course never got treatment. So a major advance about a decade and a half ago was the extended half-life products. And what happened then was that people just modified the chemistry so that these products will not go away from blood and plasma so fast. And the extended half-life products did two things. One, they increased the convenience. Instead of taking injections 2 or 3 times a week, you could take it once a week for factor 8 and maybe once in 2 weeks for factor 9. That was the one advantage. But the bigger advantage was that now we were not targeting just more than 1%. You can actually target a trough of 3 or 5%. And what difference did that make to our patient? So this man now was put on a clinical trial in 2011. He started receiving this extended half-life product from 2012. And we were targeting 3% trough level for him. Now you look at this, since 2012 it was started, his last bleed, this is a man in his late 30s, early 40s at that time, who never received prophylaxis before. First 2 or 3 years, he had 2 or 3 bleeds. But since 2015, for the last 7-8 years, no bleeds. And now you see the picture on the right, he is sitting on step number 1305 on that hill, so he can restart after taking prophylaxis, he can restart climbing those 1300 steps. So this is an example where not only young children will, of course, we should prevent joint damage, but even people with joint damage, if we put them back on prophylaxis, then they can benefit. Now, the world has moved and we now have a different understanding of how to bring about hemostasis, and this is a complicated cartoon only to say that factor concentrates are not the only way, as we know. Now there are non-factor concentrate products that will achieve hemostasis. The only one in the market so far is the factor 8 mimetic, emicizumab, but there are many more in the pipeline, and Mim8 is one which is very similar to emicizumab that is likely to which approach hemostasis balancing in a different way, and I'll come back to that. So emicizumab, as you know, is a very interesting drug which behaves like factor 8, which you see on top, that brings factor 9 and 10 together. Emicizumab, instead of factor 8, the antibody brings these two together. And instead of being given intravenously, it's given subcutaneously. It can be given less frequently, even up to once a month. And those are some of the advantages. So we have extended half-life product. We have emicizumab. The advantage of emicizumab in the many clinical trials that have been done was that almost 60-70% of people had less than 3 bleeds per year. These are the benchmarks now that we try to achieve with any treatment. And once you achieve that, we say this is a reasonably good treatment. I'm very glad that the company has chosen to market it in India, and not only market it in India, we must appreciate that they're marketing it at one of the lowest prices in the world for this drug. Now, that's something that actually almost all the other manufacturers are also doing. Given the size and volume of potential business in our country, they see that as a good business model. Now, the next product is a very unique one. So far, you don't have factor, so you replace the factor. Or you give something which is similar to the factor, like emicizumab or Mim8. Now, there's a completely different approach. Here is hemostasis, right? and you have anticoagulants and procoagulants. Normally, this is balanced and we live fine. When you have less procoagulants, 8 or 9 is missing, the anticoagulants become more strong and you bleed. So what if instead of replacing 8 or 9, which we were doing so far, you reduce this side and you get a balance by which this hemostasis now looks more balanced because you reduce something else. Okay. Now, this is what this drug fitusiran is doing. It is reducing the antithrombin. Now, we never anticipated 4 or 5 years ago when the clinical trial started that this will be as effective as it has been shown to be. So, this is data that was published about 2 weeks ago in the Lancet and Lancet Hematology, and it is very good to see that actually several Indian centers have contributed quite significantly to the study. Fitusiran, like nemicizumab, is showing zero bleed in 50-60% of patients, and 85-90% of patients are having less than 3 bleeds. The advantage here is that it is one drug that works in factor 8 or 9 deficiency with or without inhibitor. Now, a few more drugs like that are coming, but this is the first one likely to get approved, where you have one drug that works for hemophilia A or B with or without inhibitors. It is given subcutaneously. And in fact, the different dosing schedules that are now being evaluated, it may turn out that 6 subcutaneous injections, one injection every 2 weeks, is all you need for the whole year's treatment with a drug like this. One subcutaneous injection once in 2 months, and you may not need anything else. Will it happen like that? We will know once all the trials are completed. Now, we cannot talk about hemophilia today and not say anything about gene therapy. Not producing a protein that is gene because that gene is defective. So you synthesize an artificial gene, the transgene, you put it into a carrier, which is the vector, and you inject the vector into the person, or you into the person, and this then goes into the body, starts making protein that was deficient. Now, without getting into too much science, we know that this work has been going on for 20 years, and it is very good to know that is the product. They were using the adeno-associated viral vector. They put the factor 8 gene inside that, and it is now available in the world. Problem for us is that it is $2.1 million per dose. That is about dose. Okay. And then more recently, we had the next product for factor 9. It is again an AAV5 based product which has been approved for factor 9 deficiency. They went even further because they are getting better levels, $3.5 million per dose. So this is now 27-28 crores. So it's good to admire from a distance. Even in the West, it is a challenge for them to provide this kind of therapy for everybody. Multiple clinical trials are going on, most of these using the same AAV vector technology with different transgenes. Now, the Department of Biotechnology, Government of India, has been supporting a major gene therapy program at our center for more than 10 years. And we have also developed the AAV technology, which can be taken to the clinic. A big challenge in our country is the vector production technology at the industrial level. So this is what has delayed this program, but we are now in discussion with several industrial partners, and it's likely that we will be able to make AAV in our country. The transgene, the vector, that proof of concept study has been done. If the vector production happens, this will go to a clinical trial. You heard that before. But with AAV, there are some challenges because in different populations, we have already had natural infection with AAV, which makes us make antibodies that will neutralize the vector when we inject. So not everybody in this room, if we needed AAV-based gene therapy, will be eligible because we have antibodies against AAV. What is this level in our community? We've done some studies and I'll show you the result. The other big problem is that AAV-based therapy is liver-directed, and therefore we cannot give it to very young children till the liver grows in size to the adult level. And that happens only by 10, 12 years of age. So which means all our children with hemophilia will need some other treatment for the first 10, 12 years, and then only they can go for AAV-based gene therapy. Now that again brings us to square one. We don't have the mechanisms to do the treatment for the first 10, 12 years. Then these children will land up with joint problems, with inhibitors, and then only they will become eligible for AAV-based therapy. So for this reason, that has been, there are many options being looked at. One of the options that we started looking at 10 years ago was, instead of putting into AAV, we put the factor VIII gene into a lentivirus. This approach has been used for thalassemia and immune deficiency disorders for 20 years. So we put the factor VIII gene into a lentivirus and now put this lentivirus based gene into the blood stem cell, the hematopoietic stem cell, and then it will make factor VIII from the blood cells. So we've seen this before. The good thing is, here you take stem cells from the individual, you then process it in the laboratory, put the gene into it, and then give it back as an autologous stem cell transplantation. This is certainly much more involved than AAV-based gene therapy, but it can work for everybody, because all the people who have antibodies, and our studies have shown that in India, by the time you are an adult, almost 70 to 90% of people have AAV antibodies. So we may or may not be eligible. Most of our patients may not be eligible for AAV-based gene therapy. So this is something that this approach has been done, as I said earlier, for immune deficiency and the hemoglobin disorders. We have started this approach in India. So in standardizing that, one of the things that we had to do, that the drug controller and the RCGM from the Department of Biotechnology asked us to do, was to get 3 volunteer patients whose cells will be used to show that this technology has been well established in our laboratory. One of the volunteers for this was our patient. Okay, so he actually volunteered. Now, could he have gone for the gene therapy also? He could have, but he chose not to. Why? Because he's doing so well. 7, 8 years he has not bled. He's on extended half-life product. He is having a baseline of 3%. And he's not bleeding. So he says, I'm waiting. I will donate my stem cell for research, but I am not ready yet to go for gene therapy. But luckily for us, there were 2 other brave young men in our city, okay, who agreed to go, who be the first part 2 participants. And I can tell you that first patient was treated in June 22. For the first time in the world, this technology has been used in human beings in a phase 1 clinical trial, where the first patient was treated June last year, the next patient was treated about 4 months ago. So 2 patients have been treated. As a phase 1 trial, we are mostly looking at safety, but I can tell you that there is clinically significant response to this. So this is the story of the evolution of hemophilia over the last century. I'm glad that in India now we have access. We were using only plasma and plasma-derived products. We got some recombinant through marketing and donations. We got extended half-life through marketing and donations. We also have the non-clotting factor concentrates. And as gene therapy is evolving in the world, it's very nice that we have our own gene therapy products that we are collaborating with industry to bring to the people with hemophilia in this country. So the last point here, just to take home, one, it was mentioned, I didn't refer to it specifically. Diagnosis is a big challenge, and there are ways to overcome that. Regular replacement therapy has to be the goal of all the state hemophilia programs. Access to newer products, extended half-life clotting factor concentrates, and the non-clotting factor concentrate. The procurement process, starting with the tender and its allotment, as well as the distribution process. There is much to be learned and implemented there. And finally, when government or anybody puts resources, everybody wants to know how is it helping anybody. So some concept of care. But we will need more than 1,000 to 2,000 crores per year to do this replacement therapy. So cure is always better than continued treatment. So we must work towards gene therapy to relieve people of hemophilia once for all from their disease. Thank you for your attention. Is there any questions now or later, or maybe no time? Who's chairing this? Good afternoon. how many days it will
Last.
survive or last? So the question is, after gene therapy, what is the factor level of the patients and for how long will it last? So gene therapy is meant to last forever. Okay? In concept, it is meant to last forever. So that's why it is intended to be a cure and not intermittent replacement. In the factor 8 product that has been approved in the world, it went up to 150% in the first year. After that, it has been dropping. At the end of 4 or 5 years, it is somewhere between 5 to 35%, average of 10-15%. Not a cure, not a normal level in that sense, but cure in the sense that those people are not bleeding at all. From the extended half-life product usage, we know that if you reach 3 to 5%, like the patient I showed you in India, who for last 10 years plus is getting this product, if you get 3 to 5%, you will not bleed unless you have trauma or surgery. So ideally, we want normal levels, but no gene therapy product is giving us that right now. In future, it may. The factor 9 product is giving more like 30 to 50%, still not 50 to 150, which is normal, and that is sustained. So the factor 9 gene therapy is giving that level, factor 8 is giving a lower level. Both products are approved because the regulator, the physicians, the patients, the society decided that for $2 and $3.5 million, they will use such a product. But as we go forward, it may get better. Okay.
Thank you, sir.
Me. Okay, thank you. Somebody should tell us when to stop this. But I'm very, I'm very happy to answer questions. But somebody should keep
Good
track
morning,
of
sir.
time.
Sir, I have two questions. So basically, sir, first question is mine. Is that, sir, you have talked about two types of gene therapy, right, sir? That is one AAV vector, and second one is stem cell.
Plenty.
Yes. So which is better in terms of safety and efficacy, and what will be the cost implications between these two?
So, can you shut that door? Can you shut that door, please? So, Lenti, ours is the first trial in the world. It is far from a product, registered and marketing. If it gets developed in India, which it will be this one, if no safety problems come, we have to price it at a level that the industry will decide, but has to be relevant in our country. So something that the government will support. Now all of you can figure out the government is already supporting treatment at certain levels, whether it can be brought to that level, but something that the government can support. Okay. The overseas calculation of price is very different because they go by what is called value-based pricing. Currently, for treating a person with severe hemophilia, they are spending $300,000 to $500,000 per year. So if they price it at $2 or $3 million, it's only 5 to 6 years of treatment. If the gene therapy lasts for 5-6 years, you recovered your cost. If it lasts 10 years, society has benefited. So it's a different philosophy. So on the price, one of the major motivations for us to do what we are doing is that those prices, even if they make it 1/10, is no good for us. We have to have it 1/20th or less, right? Safety wise, the big advantage of AAV is that 20 years ago, the clinical trials that were done, they failed. But 20 years follow-up of those patients, no major safety concerns have come. Plus, it's a very easy administration. You go to the outpatient clinic, you get an infusion, gene therapy is over. Unfortunately, as I said, our studies, were about 1,000 people with hemophilia A and B and the normal population. We have very high anti-AAV antibody levels in our community. This is the same story in China, in South Africa, unlike the Western countries. Why we have high antibodies to AAV? We have theories, no definite answer. So most of our people will not be eligible to the current versions of the AAV gene therapy. So simple and good as it is, but for factor 9, it is giving steady state level. For factor 8, it is dropping because factor 8, the liver cell is not the natural factory of the factor 8. So it doesn't like it. It does it for a while, then it stops wearing off. That biology, that science, we don't understand fully. So alternate technologies are there. Gene editing based gene therapy is also possible. We are also looking at that. Lenti based gene therapy, 2 or 3 centers in the world are looking at that. Lenti theoretically is more risky because the virus integrates into the genome. But the current versions of the Lenti have been used for more than 10 years in hundreds of people with immune deficiency disorders and hemoglobin disorders. So far, the major risk is, will you develop a cancer? So far, that has not happened in these groups of disorders. Sickle cell disease is a different story. We must look at it differently. 2 cases happened, but it's not linked to the vector. So any of these are new therapies. While there is excitement about the efficacy, we have to be very cautious about the safety.
Thank you, sir. Sir, last question, sir. Sir, you talk about the new products. Those are in the market for the inhibitor patients. Sir, that have a higher cost, sir. So before that, sir, we have the FIVA and the Novo 7, sir. So is there any thing that which is better product, whether FIVA is better or Novo 7 is better? Or
So-
people sometimes are hemophilics also feel that maybe if I use FIVA, it is working on me. If I use Novo 7, working on me. Is
So
that-
the only I get your question, and I think we're running short on time. There's nobody controlling me here, so I don't know what's going on. But anyway, um, the one thing which was very clear when these non-clotting factor concentrate products came into use, clinical use, is that for inhibitor patients it was a no-brainer because both FIBA and Novo 7 were very useful in the era that they existed. They could act immediately when there is bleeding, and they still have a lot of relevance in that situation. But both were not suited for prophylaxis, for preventing bleeding. And the best regimens for prophylaxis with FIBA and Novo 7 were not as effective. So the approvals came first for even for emicizumab for inhibitor, because you could now have 50-60% of people with inhibitors with 0 bleed and a higher number with less than 3 bleed. So that's a no-brainer. If you have inhibitor, you need something other which will give you prophylactic control. Now, whether it will be this or other new products that are in the pipeline, currently the only one is emicizumab. In future, there will be more. Okay, maybe we should stop.
Yes, thank you, sir.
Somebody, I don't know who's controlling it. Cecil, you do something. You have to stop us. No.
Thank you.
Time,
Thank you,
stopping.
sir. You said that after 4-5 years, the factor level drops down. That is 5 to 30% in between. So, are you trying to say that the dropping of the factor level depends on individual to individual, or?
Yeah. So in AAV gene therapy, there is a major challenge. If you look at the clinical trial patients, when I said the best level was the mean, the average level was around 250 to 300%. People were worried they'll get thrombosis. Okay, so the reason for the variable response to the same dose of gene therapy, we don't understand in AAV. Same thing happened with factor 9 also. So there is a variable response with the same dose of gene therapy. But luckily anything above 3-5% is clinically useful. So all these patients are doing well. 1 or 2 have gone on to have thrombosis when the level was too high and people were not anticipating. Now people are more conscious. If the level is going too high, they take measures to prevent thrombosis. But the variability is there and we don't understand the basis.
Okay. Thank you, sir, for giving me answer. And this is Alpana Bhatnagar from Noida Society. Thank you, sir.
Thank you, sir, for the presentations and for answering all the questions. Now I request as our Vice President Medical, Dr. Cecil Ross, to please present a token of love and appreciation on behalf of HFI to Dr. Alok Srivastava. Prevention of access to care, prevention of bleeds. That's the theme for this year's World Hemophilia Day. And we have with us Professor Tulika Seth, AIMS, New Delhi, to speak on the subject. Professor Tulika Seth has been involved in hemophilia for long. Madam has She's a clinical hemato-oncologist by training, having a distinguished academic career with over 160 research papers in various national and international journals of repute. I request Tulika ma'am to please have the presentation on access to care, prevention of bleeds.
They'll come directly there. Okay. So while they're setting up the slides, I would like to say congratulations to HFI on another annual Hemophilia Day. And over the last few years, we've been seeing tremendous results of all the advocacy that has been done by the patients and by all the senior doctors. And I think we are now at a much better situation than we were before. But as Dr. Alok has rightly said, there's still many more things that we need to do. So Dr. Alok in his talk has beautifully set the context, and I'll try and take that a little bit forward with some more practical ideas. While we're waiting for the slides, if anybody has any burning questions, I think we can take those. Any practical issues or any other problems that any of the doctors from the various parts of the country would like to ask? Okay, we've got the slides. Will they project here as well? So the theme for WFH this year was Access for All, Prevention of Bleeds. So as Dr. Alok had said, the current standard of care is regular replacement therapy, which earlier we used to call prophylaxis because you are technically prophylaxing or preventing bleeds. The old terminology of on-demand therapy is basically treatment of a bleed. It cannot prevent bleeds. We've lost the slides. Okay, it's PDF. Okay. Okay. So the WFH 2020 does not consider on-demand therapy as treatment anymore. So that shows that we still have a long way to go. Now, this is an old slide that we have been talking about for many years, and we know that the patients in India, because of the lack of access to the clotting factors, we see a large number of patients with disability. In fact, only 6% of patients were disability free. Place to place, with patients living in rural areas, remote areas, even patients living in large cities. There can be patients who have access to transportation and patients who don't. And because of all of this, we know that most of the patients have problems with education and problems with work. And sometimes the problems can be so much that they even have to discontinue the education. Now, the concept of per capita consumption of clotting factors shows that in India, our per capita consumption is quite less. There is another concept in which, if we actually look at the per patient consumption, it might be slightly more, but there is still a need for a lot more to be done. Okay. I think there's some problem with the slides. Sorry. It was not a PDF, so the slides are not projecting. Okay.
Not this one.
Not the inhibitor one.
Internet went off.
Okay, internet's gone. Okay, no problem. I think we'll just have a general talk then. Yeah. My apologies. There seems to be a lot of technical glitches today. I didn't send a PDF. I sent a PPT. So the crux of what I wanted to say today was that, oh, something's coming. Okay, so because something's showing up now. What is that?
They are showing it.
They're showing it? Okay, okay. So do I say next or can I control the slides? Okay. Okay. So this point has already been made, in which we said that episodic treatment happens after you have a bleed, and so that cannot prevent joint destruction. Next slide. So why can't it prevent joint destruction? Because you already have blood inside the joint, and that blood will cause the damage to the joint, leading to eventually this joint being completely destroyed and leading to your synovitis at the beginning and later arthritis. Next. 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 So by giving small doses repeatedly rather than a big dose after a bleed, you end up with prevention of the bleed, and you have a patient who now can be able to play, run. We have many children who don't come to our OPD regularly, and you ask the mother why, and they say that the child is having the sports day, or the child is having exams, or they're giving interviews. So that's exactly what we want to do. Next. So now, is this concept of bleed free a reality or not? Earlier, when we only had standard half-life very good, whether they're plasma derived or whether they're recombinant. We often did not see patients with 0 ABRs. Why? Because you needed 3 injections a week. And even with those 3 injections a week, you would still get 1 or 2 ABRs, which we thought was acceptable. Next. Now, actually, how many patients receive prophylaxis? Even in the West, not all patients used to be on prophylaxis, again, because of the venous access problems and injections. And there are different types of prophylaxis that was given: the high dose, the intermediate dose, and the low dose. But as I said, in India, very few percentage of patients were on prophylaxis. Next. And this is there not only in India, but most of the Asian countries, very few patients were getting factors. Next. Now, the access, as I said, is a big problem. And we have patients who live in remote, hilly areas where sometimes they have to travel 2 hours by foot in order to even reach a PHC. So we need to think about this a lot in deciding who are the patients who need to be on prophylaxis and how to give the access. Next. So in an earlier conference, I had talked about good hemophilia care being cost effective. Next. So we really need to invest into our future. So how are we going to do that? Next. So there's been a lot of theoretical modeling and science behind this. And we know that if you can give good hemophilia care, you can prevent joint destruction and disability. At AIMS, we actually have many patients who come to us even now who require 4 joint replacement surgery. And the cost of 4 joint replacement surgery is borne by the government of India. So if you give these patients good hemophilia care over the early part of their life, then later on in life, the government will not have to pay for these 4 joint replacement surgeries. And this kind of work has actually been analyzed in the West. Next. So there already have been studies where people have looked at the cost of on-demand versus prophylaxis, and it has definitely shown that this is a good strategy. Next. And this is one of the studies where they showed over the lifetime of a patient, the cost would almost be the same as prophylaxis versus on-demand, but you end up with a better quality of life. You have a patient who can go to school, complete his education, and be able to go to work regularly. Next. Next. So that's basically the same thing. Next. Now, you have to realize that cost effectiveness studies have their limitations. I won't go into the details of that, but you're not really looking at many other aspects like the quality of life and other issues. And so when you're looking at many of the cost effectiveness studies, you're only looking at the outcome of a per unit cost. And in India, many times the cost of hospitalization and other things are not so high. And so it may appear that we're not really having cost effectiveness, but I won't go into that. Next. So I think what's important to note is what is the cost of not providing care? That's a very important thing to focus on. And even in the West, we know that patients who are not on prophylaxis, most of the expenditure, one is obviously the cost of the factor, but another big part is cost of hospitalization for bleeds. And there we're not even looking at the cost of surgery and the cost of the sequelae of the bleeds. Next. So the economic capacity of patients also will depend on the quality of care provided. So patients who are getting better quality of care will have better health and be able to contribute more to society. Next. Now, we know that all of the patients here want to work and they can contribute to society, and we want to make sure that all the growth in our country is inclusive. Next. And hemophilia does need some investment, but this investment is going to definitely yield dividends. The cost of care of a hemophilia patient, even in the West, is about 2 to 3 more than the cost that the government would pay for a patient without hemophilia. But as I said, the contribution to patients will also be very important. Next. Now, there are many therapies that we can do. We already talked about regular replacement. Home therapy is also very important because it's a better way of treating bleeds compared to the episodic treatment. But as Dr. Alok had rightly said, we now have a plethora of many products. And sometimes people are confused that do we use standard half-life, do we use extended half-life, do we use the non-factor products? So I think it's very important for us to understand the benefits of these. And obviously at the moment, every patient may not be able to be put on non-factor products or extended half-life products. But I think step by step, if we choose the right patient who would benefit from this, we can ensure that everybody has health equity, and gradually, without doing too much expenditure immediately, we can provide better access and improve the care of each individual patient. Next, please. So the extended half-life, basically the products that are available in India are pegylated products. Next. And again, they're not very commonly used in our country, though in the West, particularly for factor 9, they are used more than the standard half-life factor 9, and even the extended half-life factor 8 are becoming much more popular. Why? Because instead of needing 3 injections in a week for prophylaxis for factor 8, you may need only 2 or even 1 injection per week. So that's over the year, you're reducing 50 to 100 injections. Next. And people have found that it's actually cost effective. So even though you're using a more expensive product, because you're having less bleeds, you don't have to treat the bleed. And because you're treating less bleeds, overall, over time, you actually are saving money. Next slide. So this is a real world data from Canada where they actually showed by using clotting factor 9 extended half-life product, you can save money. So these are things that we need to talk to the government in your state and in your hospital and tell them that this is an effective product, not only because it improves the quality of life of the patient, reduces bleeds to almost zero, can treat target joints, but also over time, you will be able to save money. Next. So this is just a slide to summarize the benefits of the extended half-life. One, you're able to have a higher target trough level, so you can treat bleeds, you can get to zero bleeds, because zero bleeds was a concept we did not have with standard half-life. So that's something I want to emphasize. You have less injections, so the patient is happy, and you can actually even save money. Next. So now when we have inhibitors, everything changes. What you were doing before, giving factor, you can't do that anymore. And as as the question was asked about recombinant factor 7 and fever, those things cannot be used for prophylaxis. One, because they're very expensive. Two, because the half-life is not so long. And so now we have to change the way that we treat patients. Next. And most patients, we know, they have to be given fever recombinant factor 7 to treat a bleed. Some patients respond better to fever, some patients respond better to recombinant factor 7. So most of the states will have to have both of these products available. So a lot of times people ask which is better. They are both important because some patients will not respond to the other. Also, we often find that for surgery, we often prefer fever because it's long acting, and recombinant factor 7 is often preferred for younger children in case they might develop inhibitors. Next, please. So then we have the emicizumab, which is a factor 8 mimetic. And this again was one of the products that can have zero bleeds, and it can be used in patients with inhibitors and without inhibitors. So this is something that can be given as prophylaxis. So up till now, we only had the bypassing agents, which were there for treating bleeds inhibitors patients, and now we have something that you can use for prophylaxis. It's important to note that if you have a patient on emicizumab, if they develop a bleed, please don't give a second dose of emicizumab, because that is not what is done to treat a bleed. To treat a bleed, you would still have to use recombinant factor 7. So these are things to remember. Next, please. Okay, so I can't actually see from here. Okay, next. Now, health equity is really important now, and I think patients' voices are finally being heard, and we're very hopeful that the government is also paying attention to these things. Next. So, how can we make sure that things are done properly? In India, we often do things in a very different way. When people had landlines, very many places in India did not have telephones. Now that we have cell phones, almost everybody has a cell phone. So I think it's important that we think about things, and if we do, I'm sure we can come up with better ways of treating our patients to ensure that we have the right treatment for each and every patient's needs. Next, please. Next. Now, we already know that the cost of clotting factors has come down tremendously from a few years ago. And I think if we can work together, we can continue to push the prices down for many of these newer products as well. And that will happen only when we start using these newer products. And it's important to have maybe regional tenders and other things to drive down the prices, because if the prices are less, then with the same amount of money that the government is giving, we can buy more factors and help more patients. Next. Next. Okay, so even though we think that there's many issues that are still unresolved, I think if all of us go back and look at the different products that we have and rethink how we can possibly use them in different ways, we can make sure that all of our patients' needs are taken care of. So what we do at our center is patients who have very high ABRs, or patients who have target joints or venous access problems, those are the patients that we are primarily moving to the extended half-life products first, because those are the ones who need it the most. And gradually we are working with the different payers and the government to be able to support the extended half-life and some of the newer products with for other patients. We have patients who live in very remote areas and or have venous access problems, and for those patients, sometimes the non-factor products, which can be given subcutaneously, can be ideal. So the idea is that you look at your patients and you think of all of the products that we have available, and you can logically come up with things that may work for your scenario in a better way. All these products are currently not available in every state, I know that, but I think if we understand the products and we use them wisely, then we will be able to ensure that everything is there to make the patient's lives better, to prevent disability, and to reach this goal of zero bleeds. Thank you.
Any questions? Thank you, Sulika, for covering very well from standard half-life to from standard half-life to extended half-life to newer products. And we're going to be close to getting some more products into the anvil. So any questions regarding? Pardon me? How can telemedicine work?
Telemedicine was actually very useful during the COVID times. And I'm actually a little bit disappointed that some of the guidelines that were there during COVID times have now been reversed, because we were able to send prescriptions to patients, especially cancer medicines were not allowed, but other medicines were permitted. So that was really good. So patients didn't have to travel. And also we were able to talk to patients, advise them about physiotherapy, advise them about rest, advise them about when they should start weight bearing, the doses of the products. I think telemedicine, I feel, is something that we shouldn't completely remove. Of course, seeing a patient, examining a patient is very important. And so I think new patients cannot be managed on telemedicine, but a lot of follow-ups are definitely there.
Ma'am, one thing which I am thinking of, that telemedicine can only be powerful or it can be very effective unless we have the good referral mechanism. That's
Yeah,
one thing.
absolutely.
Until we have a very good connectivity between the two hospitals, from PSC, if a person is coming to PSC for some bleeding or all, or at CSC level or at the district hospital, even
Right.
district hospital doesn't have those facilities which we are requiring. So those connecting with to the basically referral systems at the center of excellence or tertiary care institute, which is important. So I think these states, I mean, many states might be here. So once we talk about these systems should be in plan and HFI and everybody should take up these things
I think
in
that's
their own state,
brilliant.
because until we have a good, strong mechanism, we cannot go for it, which I am finding is difficult. as well.
Yeah, but at least in telemedicine or an ambulatory medical care, you can have no intervention or intervention with the help of a local nurse or a local PHC or something.
Right.
And if they can't, then only they can come to a referral center.
Right.
So there are grades of intervention.
Yeah.
In
No,
a
we would need
telemedicine,
very good,
yeah,
clear guidelines about what
Guidelines
should be allowed, what should
yes,
not be
what
allowed,
should be
and
allowed.
also clear guidelines of when the patient should come to the hospital. But I think that's a brilliant idea.
And second thing is, ma'am, self-management, which we are talking, these things, you are already there in the basically committee. So we are talking about the self-management of the patients, very important. So now in hemophilia also, I think that we need to have such things in their picture. The self-management, the patient should understand how to go about it, how they can be treated at their own places also. They should understand what are their problems. Until they won't understand the physiology of it, it will be difficult for them. So the patient's management, self-management of the patient
Correct.
and the parents, which we say, and we are already coming up with those guidelines for sickle cell and all.
Right.
So I think this is important that it can be taken at HFI level, because they have been very, committed to the cause. So they can take up these things and we can design and get it back to these states to basically disseminate in these states. That can be done easily.
Yeah,
That should be taken
So what
care.
Dr. Vinita is talking about is that in sickle cell, we have special guidelines and booklets for the patients and the teachers even. So similar things can be made for hemophilia patients for the schools, so that the teachers understand, what needs to be done and when to refer, and also for the patients. So yes, of course, the doctors need to be aware, but if everybody is aware, then it makes everything seamless and smooth.
Thank you, Tulika. Thanks a lot.
Sir, I have only one question.
No,
ma'am.
later on, because we are running late. You can meet during the lunch time.
Okay, sir.
I request our VP Medical, Dr. Cecil Ross, sir, to please present Dr. Tulika Seth with a memento as an appreciation for spending the time with us and sharing this much of information. Provision of good quality treatment products and a continued supply of the same in the government hospitals is one of the main needs of the bleeding disorders community of India. This is possible only through tender and procurements. And to speak on this, the topic, tender and procurements for factor concentrates, a perspective, we have with us Dr. Meera V, HOD, Clinical Hematology, BMCRI, Bangalore, representing Government of Karnataka. Dr. Meera is the founder of Department of Clinical Hematology at BMCRI, and she started comprehensive hemophilia services in Karnataka and established Center of Excellence at BMCRI for hemophilia care, which is the state nodal center. She also developed standard operating procedures for hemophilia for Karnataka. All of you, please put your hands together for Dr. Meera V.
I thank the organizers, HFI, for giving me this opportunity to share my experience. As we have already understood from the previous talks, providing safe and efficacious factor products and the whole basket of products available is a very important challenge, which is, and there are a lot of unmet needs in this area, and is a very important target that we need to achieve in the coming years. So I'll be sharing my experiences in our state. As we all understand, while tendering and getting the factor products, it is most important to consider the safety and efficacy of the products that we are asking for, and to understand whether it is of good quality and efficacious in controlling the bleeding, and at the same time it should be safe, and the risk of viral transmission should be minimum and if possible zero, and without any increase in risk of inhibitors. There is always going to be a small risk of inhibitors, but the product that we are asking for should not have a further enhanced risk of inhibitors. And equally important is whatever product we're asking for should be able to come whenever we give the request for it. So uninterrupted supply of this product should also be ensured when we are asking for a product. We are talking about this in the most common context is many a time we ask for plasma derived products, but since the plasma derived product is manufactured from the donated plasma, and the supply of this plasma is not unlimited because it is through donation. It is not manufactured in the lab. So this uninterrupted supply, for example, is one of the key challenges when we are asking for plasma-derived products. So whenever we ask for any product, we have to ensure that the supply is going to be uninterrupted as well, because at the state level, that is one of the important challenges. So these are the various benchmark guidelines available to us about how we can tailor our requirements for our respective states. And they are very useful and important documents and can be quoted and also used as a referral. Why is it so important? Many a time this is taken for granted in many other disease segments. We should understand the background for this. It is because a whole generation of blood disorder patients have been subjected to all these transmitted infections, and this could have been avoided if all these due diligence was done from times immemorial. And once we have started doing it, we see that our present pediatric population has been largely spared from all these infections. So it is very important that we employ the due diligence while asking for all these safe products for the hemophilia care. So what are the aspects that we have to consider with respect to the safety and efficacy of a product? So the most important thing, which is often overlooked, is selecting the proper donors. So donor populations who have high-risk behavior, in most of the good companies take care and try to avoid such donors who have high-risk behavior. And subsequent to the collection, these individual the collections are screened in such a way that even in the window period, they try to detect if any of these infections are present, which is done through the NAT testing of the donated individual products and also the mini pool of this collected plasma. And this is a preferred and ideal way of testing for the transfusion transmitted infections, and it cannot be this cannot be substituted by just doing the end pool testing. This is very important diligence that all of us regulators and the technical experts have to bear in mind. End product testing is not a alternative to testing the individual donated and mini pool samples of the plasma product. And the most important process which has contributed to a better and safe, efficacious product that is available today is the viral reduction process. The previous speakers have already spoken about it in detail. This is viral inactivation is most importantly done through the solvent detergent mechanism, which is the gold standard and is a must in each and every product that we should be asking for. And subsequent to that, this takes care of the most of the enveloped viruses which are present in which may still remain in the plasma in spite of the NAT testing. Subsequent to it is the most challenging thing today, which is there is a slight unmet area here. The non-enveloped viruses can still remain back, like the parvovirus B19 and hepatitis A, and also the prions and many unknown viruses which can still be there. And techniques like nanofiltration and chromatography is important here, and they help eliminate most of these. Heat treatment is also there, but it is not shown to be effective for most of the eliminating the parvovirus. And sometimes techniques like pasteurization may also compromise on the quality of the product. The coagulation proteins also may get inactivated. Sometimes they may lead to formation of new antigens. So we should bear in mind. And it is very important that at least 2 of these viral reduction procedures must be done on the product, because solvent detergent helps eliminate the enveloped viruses, but one more procedure is needed, nanofiltration or chromatography, to eliminate the non-enveloped viruses. So while giving the technical specifications, it is important to insist that at least 2 viral removal techniques should be implemented on the the factor product. And along with this, the inhibitor risk of any given product should always be assessed by the technical persons. It should not be greater than what is already prevalent. If the product is more immunogenic, we have to go through the product history and the trial reports available, and be careful, watchful about it. So while assessing the efficacy, it is important to study the potency and the shelf life. With all these procedures for the safety, the potency should not be compromised. And products which have good shelf life, which are viable even at room temperature, always have a additional advantage. And as I said, the product history for its safety and efficacy and the inhibitor risk should be analyzed, and the clinical trial data should also be studied before asking for any particular product. So a word about the end product testing. Many companies are taking a short route and only subjecting their product to end product testing. End product testing by the regulators is a different thing, that they do it as part of their policy. But products which only do the end product testing for the viruses, the NAT testing or whatever, only in the end product and not through the initial phase at the level of the donated plasma or the mini pools, there are pitfalls which we have, you can see in the photograph. When a large amount of plasma is collected, there may be very few viral particles which have remained in spite of all the good manufacturing procedures. And in this diluted sample, we may not be able to detect the virus, but that virus still has the infectious potential and can infect the person. And for example, in this example, they have shown in a 10 ml sample, even if 2 viruses are present, they can still infect, whereas the sample will show false negativity to the extent of 82%. So this compromises on the product safety. The other contradictory possibility is the solvent detergent procedure kills the virus, whereas the lipid material, the genetic material is still present. And this can give rise to false positivity when you do the testing for the virus. But this virus is inactive. It's not going to be infective. And because of the false positivity, the product may be rejected. So this can also affect the product supply. So both this can be avoided by not resorting to end product testing, and the regulator should be insisting on the testing on the individual samples. That is very important, and it is of grave concern in our country. So all these have been very beautifully elucidated in this guide monograph. So the other aspect is the tendering process. Ideally, the technical committees which are there in all the states should have a combination of all the regulatory authorities involved along with the key treating doctors and the patient organization. This creates a beautiful blend and all the needs and concerns can be ideally addressed. This is the committees that we have in our state in which all these stakeholders have been beautifully synthesized. So to summarize, whenever we assess a factor product, you have to look at its quality, the various aspects which I already covered, and also the technical expert who is doing the technical assessment should also study the manufacturing steps that the product has been subjected to, and also look at the potency of the final product and the product history and the clinical trial details. So all this due diligence should be followed at each and every step. So the other question that many of us have been lingering in all our minds is how do we indent when we give when we ask for a particular quantity that each of our states need or each of our centers need, how do we come zero down the mathematics for this? So a rough guidance that we are following is we have collected the data about the number of patients we have with the various subcategory of conditions, hemophilia A, B, von Willebrand disease, and the number of patients of inhibitors who are there. And also every year there's a likelihood of few more patients developing inhibitors. So we have to factor in for that. Even year on year, we have to ask for a 10 or 20% increase in the budgetary allocation because there'll be newly diagnosed or registered patients. And if we are planning on prophylaxis, which ideally all of us should, that also should be factored in when we ask for the allocation. And the past history of utilization with a year-on-year increase in the allocation accordingly, and the WFH standards. So ideally, at least 10 or 20,000 units per person of the factor is to be asked for. And some of the key landmark studies have also influenced the way we ask for our products. For example, the CIPET showed that the previously unexposed patients, what we know as PUPs, they have a higher risk of inhibitors if they're exposed to some of the recombinant products. But whereas subsequently the other studies have shown it is not always so. But if it is possible, it is useful that we can give them products with have the von Willebrand factor in it till they have at least 50 exposure days. So this can also be factored in while we indent for the factors. And we have to have a contingency planning for many of these kind of emergency situations. And including, as I said, year on year, the number of patients on inhibitors can increase. And or if we have started becoming a tertiary care center where we treat do a lot of surgeries, treat major bleeds like intracranial bleeds, there is a higher risk of them developing inhibitors. So we have to factor in these aspects while asking for the medicines. So the centers having a larger body of work have to ask for more amount of factors. And good data collection helps us in zeroing the numbers for all of this, having both the physical records and online data, either and ideally in a registry form where all this data is available, which we can use to calculate the amount of medicines we need. And the other aspect is when when your specifications ensures a competition, the price of the medicines come down. And when you ideally, it is better to have a single product rather than each strength being of a different type. So because the patient doesn't exactly require 250, 500 in those numbers. So the patient may require different, based on his body weight and the kind of breed he has, he may require different amount of factors. So instead of giving a concoction of products, it is better that it is of a single type. So when you invite the tenders per IU, you will have a same type of product in different strengths, which is the likelihood of complications like inhibitor may also be much lower when you do that. And having the whole basket of products which are available in the country is always good. Just now, Madam spoke about how you can individualize the care, when you can give the standard half-life products, when you can put them on extended half-life products, and who are the ideal candidates for the non-factor therapies. And this kind of individualizing also brings in economy in our factory usage. I'll show you a slide about our utilization data. And having a database, a registry is a very good idea. All these things will automatically, this data is available in the registry and you can use it. And having a good stock distribution system and subsequently monitoring it on a real-time basis so that you can send the stocks before it is exhausted is very important. And you can give, instead of giving the orders in a single go, you can give staggered in. Once the rate contract is fixed, you can buy the products in a staggered manner. Then in between, if there is a large number of patients who are developing inhibitors, then in the next installment you can ask more of that product rather than some other product. But of course there are many administrative constraints in that, but we need to work on that. So this was our tender in 2017. So year on year, whatever new products have come in, we have gone on asking for them. So in Factor 8, we have all these products, both extended half-life. In Factor 9, we have both normal Factor 9, which are both in the recombinant and plasma-derived variety, and extended half-life Factor 9. In Factor 8, we also have another product, which is the intermediate purity Factor 8, which has the 1 millibrand factor. Both the bypassing agents are needed because, as Madam also said, the APCC has a longer half-life. The recombinant Factor 7 has the immediate onset of action. Some patients respond better to some products. Sometimes combination of products are required sequentially. And non-factor therapy, I think all the speakers have spoken about. Many a time it is very useful, and even this should be there in the basket of products. And when we start using them with experience, lower dose is very much feasible, and that comes out to be much more economical rather than giving recurrent on-demand treatment, giving once a month or once in almost sometimes more, even more infrequently. This has shown in many centers that it is becoming increasingly more economical. So EHL product, I think many of the previous speakers have spoken about it. It is very convenient for the patient and the treating doctors because the number of venipunctures, hospital visits come down, and for the same amount, a much higher trough level is reached and patient has a better quality of life. And the studies have shown equal safety and efficacy, and that there are better clinical outcomes, and in the long term it has proven to be more cost effective. So the patients with inhibitors are a very vulnerable population, and the treatment for these patients is very challenging because many a time the bypassing agents are not always effective and the treatment is much more expensive. So there is a huge unmet need in the treatment of this sensitive population. And these non-factor therapies, which presently which are available to us, have proven to be very useful in bridging these gaps. So some of the points that we have to remember while tendering is different company products which may be of the same recombinant technology, but they're not identical and they use slightly different manufacturing procedures, and combining them at each and every infusion is the long-term data is not available and is fraught with its own risk. And tenders hence should be ideally quoted per IU so that there is a uniformity of product available at any given time. And as for the same reason, we understand that the factors are given per body weight and based on the site of bleed, and the dose keeps varying on the same day and on a day-to-day basis. So product uniformity is very important. And it is important to have a wide range of whatever products are available, because that helps deliver the best individualized treatment in the most economical way, because one size does not fit all. This is, for example, our experience and the utilizations which have changed dynamically once we started having a basket of products. And it is possible to build in the contract a variation in the amount that can be supplied and also allow for contingency planning for the when the actual requirement is more or less than what was planned for. And involvement of all the key stakeholders can lead to a process which is much more efficient and patient friendly. And having a national or regional database registry and stock monitoring and the distribution system is very useful in minimizing the impact of a shortage. This is the distribution system which we are following. The state blood cell and the medical corporation takes care of the distribution. This is the 3-tier system we have. So the state blood cell has all the time a contingency amount of factor. The stocks are always, some amount of stocks are always there with them, and they give a slightly higher amount to the nodal center where tertiary level care happens, and all the districts get the amount of factor as per the data of the patients' numbers and the utilization that they send to the state blood cell. So you can see we have mapped the whole state and the districts. The patient data is available. For example, if a particular district has good number of factor 9, they get a slightly more amount of factor 9 to those districts. Some states hardly have any factor 9 patients. There we don't send factor 9. Similarly, von Willebrand, if a district has given the data on the amount of von Willebrand patients that they have, the von Willebrand factor is sent there, or else it is not sent. It is sent in areas where the demand is there and not as a policy. So this helps in the optimal utilization of the product. So a teamwork helps in delivering better patient services. Thank you.
Excuse madam. Madam, I have one question, madam, please, regarding tendering. Hello. Hello. In spite of you are taking so much care regarding efficacy, safety, and all those things, once the product is approved by DGCI or FDA approved product, and still as a from patient organization, we feel some products are still not good or some reactions are happening. We do, because to whom should we complain? Nobody listens to the poor this patient side, because see how you can do so that this product should be ignored from the tendering process.
So that depends on the specifications that you give. Unless the technical bid is cleared, the next financial bid is not opened. So if the product meets your technical specifications, only then you can clear the technical bid. So it is possible. That precaution should be taken at that stage. Once your product has cleared the technical bit, there is nothing you can do. So acting much before is important.
No, so what you have to do is, supposing if you are saying one product is good, one product not good, how you are going to say that? So what you have to do is, if you feel that any product is not good, you have to report it. Okay, that when I took product A or B or C, I get this, my fever was there, chill was something like that, and therefore, hello.
No, I think what Dr. Cecil is saying is very important, but that is after approval. So it's already in use. Before approval, the problem in our tender process, and we've had major discussions in other meetings also, and very important that it is coming up in this meeting. When the tender says you want a bottle which has factor 8 or factor 9 or vulnerable factor, nothing else, there are many bottles with factor 8, factor 9 or vulnerable factor. But the tender has to say that that bottle should come with data of clinical usage, safety and efficacy. It has to come with a drug master file that can be inspected if needed. So these points are specified in the World Federation guidelines of choice of treatment products. So what our state ministries that are putting out the tenders need to understand is that we do not just say paracetamol 500 milligram. We have to say factor 8 or factor 9 or whatever, with all these other data to back up its safety and efficacy. When a particular product is presented in the tender without those backup data, then that product gets rejected before the price is seen. So the important thing is to ask for clinical data of safety and efficacy.
Yeah. So after the product is already there in the market, that means you assume that is all gone. You have got a difficulty, then you have to report, and all the people across the state will report, and then it will tell you.
Thank you, sir.
Which should be taken into consideration, because we are not talking about that. We are talking about WFH guidelines is good, but the plasma policy of India should be considered. It has not been considered, then it's also an issue. That should be taken up. So everybody should see those things. These are all on the sites. And they have been revised regularly, and the transfusion medicine guidelines are also being revised. So one should see those things.
Ma'am,
Thank
I
you,
have
thank
a
you.
just small question.
Last question.
Yes, sir.
Yeah.
So what is the ideal percentage? Because there are many states who are now procuring the recombinant factor. So what is the ideal ratio between the recombinant and the plasma derived factors?
So that is based on the patient data that is available with you, and also your experience in the past few years. When you have in the midway, you would have faced with the shortage crisis. For example, in our state, we are asking for about 50% of the budget is for factor 8, and about 10 to 15 is for factor 9, and more than 20-25 inhibitor products, and the remaining. So that is based on the data. So also work out, but it is important, especially that you have a good allocation for the inhibitor patients, because that is unexpected. It is dynamic. It keeps moving. So don't look at the 80% factor 8 population. Some of them are, so you have to keep that in mind.
Ma'am, I am asking about recombinant and plasma.
Again, you are getting the plasma for basically the vulnerable patients. So based on that data and some amount for the pups, you can ask for the vulnerable.
Thank you, Dr. Meera V, for sharing a detailed perspective on tendering and procurement. Now I request our VP Medical, Dr. Cecil Rosser, to please felicitate Dr. Meera V with a memento. A huge round of applause for Dr. Meera, please. With this, we break for lunch and networking for 1 hour. One of the objectives of IHC is also to aid in networking with the experts, policymakers, doctors, NHM officials, patients, and patient organization representatives from across the country. So we'll be back with very, very important sessions after the lunch, which is for 1 hour. And there is a gentle reminder, if there is anyone who have not yet checked out your rooms, kindly do the same and hand over the key to the reception. We have very, very important sessions from government sector after lunch and a critical panel discussion. So I hope you will enjoy the lunch, the networking until we restart the session in 1 hour. Please be back in the room and be seated, please. Yeah. Good afternoon, all. I hope you all had a very good lunch and a good networking session. So we'll start with the post-lunch session. We have a small felicitation program before the technical session. Okay. We start the post-lunch session with a very happy news and a felicitation. We are happy to inform you all that one of our members, a person with hemophilia, Sri Bommandan from Tirupur, has received award for Best Employee in Hemophilia category from Honorable Chief Minister of Tamil Nadu, Sri M.K. Stalin, on World Disability Day. He received a state award and a gold medal. I now request Vice President Development, Sri Ramu Gatkar, to please felicitate Bommandan. A huge round of applause for Bommandan, everybody. At this occasion, we would also like to share with you all slogan contest winner. Many of you might not be aware that we have a very strong women's group for Hemophilia Federation India, because women are usually the ones who have to take care of the children and have societal stigma. So we ran a slogan contest to have a slogan for the women's group of Hemophilia Federation India, which would convey the essence and the motto of Women's Group of India. And we have a winner, Neha Rai Thakur from Kolkata chapter. And the slogan that we selected is Educate, Empower, and huge round of applause for Neha as well as to the. Now we start with our technical sessions again. The first session today is by Dr. Parul Bhatt, who will be speaking on ITI and prophylaxis treatment, a real-world experience. Dr. Parul Bhatt is the professor and head of medicine, GMS Medical College and Hospital, Sola, Ahmedabad. So this is a real-world experience from Government of Gujarat. I request Dr. Parul Bhatt to please share the presentation here. A big round of applause to Dr. Bhatt.
Okay. Good afternoon, everyone. It is difficult to be a post-lesson lunch session, but even though sharing of my experience at my hemophilia daycare center in Ahmedabad, and very proudly and very happily, I just congratulate all of you on World Hemophilia Day. I just wish you introduction of hemophilia. That hemophilia is inherited bleeding disorder in which there is a deficiency and lack of factor 8 and factor 9, and it is a Greek word. Two-thirds of the cases of hemophilia are inherited, and hemophilia is typically expressed in male and females are the carriers. Severity level is consistent in the family members, and 30% of the new cases having new mutation. And we achieved a very great role with the cooperation of the everybody in a teamwork, that life expectancy is increased up to the 80 years of the hemophilic patient. It is a very good and appreciated, but now the time is to think of something else, and this is what is the complications of hemophilia. So sorry. So life expectancy is of course has been increased, but the time is to address the complications of hemophilia, as we got the maximum available factors and the drugs which are in non-factors drugs which are available to get the maximum benefit to the patient. But now it is the time to address something new, and that is what the complications of hemophilia. Usually we remember one eye, but in hemophilia treatment you have to remember three eyes. I, this is immobility, infections, and inhibitor formation. We are somewhat capable to prevent the immobility by providing the optimum treatment to the patients. Infections, of course, is now not a big issue because of availability of recombinant factors, but the inhibitor formation is still need to be addressed and is to be taken in a deep to taken care by us. So inhibitors in patient with hemophilia, how, let us go in deep about this something about the inhibitors, because inhibitors develop in the most significant treatment related complications of the patient with hemophilia. Inhibitor patients are associated with, because it is associated with significant morbidity, higher bleeding complications, increased disability, and decreased quality of life. Directed against the replacement factor of 8 and factor 9 that typically neutralize the activity of the factors. The development of inhibitors are the severe complication of the treatment of the hemophilic patient. Challenge for us when the patient with the inhibitors. So bleeding, because the challenge is in form of that bleeding does not stop even after the factor replacement, worse the joint disease, worsen the quality of life in form of absent from the school or from the workplace, or increase the hospitalization. And very big risk factor is we have to address is a death due to intracranial bleeding. That is not a uncommon thing that we have seen in a patient with the inhibitors. So what are the things happen in inhibitors? That is inhibitors, as I mentioned, is a allo antibody that develop in patient because of the typically the first 20 exposure. This is what we are not worried in adult patient. But these are the figure shows that a cascade of the clotting cascade in which the Y is suggestive of the antibody that will, when there is a presence of this cascade cannot be completed because of the presence of the antibodies. So that this antibodies covers the available factors which are so that 25 to 30% of the patient of hemophilia, severe hemophilia A, are having a inhibitors, which is common in them, and generally due to IgG antibodies that causes loss of efficacy of the exogenous factor 8. And in the hemophilia B, it is 6% of the patient, which causes sometimes acute renal failure, anaphylaxis, and it is also a question of the treatment. So it is a very important slide to understand. The incidence and prevalence of hemophilia A. Because today why we are worried about the inhibitors in the hemophilia. Any particular point of time at present, and when we are sitting together here in world, at present in India, we can say 30% of the patient are having inhibitor in their body, even though they are getting all the optimum treatment at particular point of time. So we have to address this thing. And there you can see in this slide, there is a increased inhibitor incidence is already there. Every time the new cases are adding in the existing numbers of the patients. So 30% of the patient with severe hemophilia A, and 13% of the patient is, even though there is a no severe hemophilia, even though they are not on regular treatment, on demand treatment. So you can see the how much number of the patient are having inhibitors in their body. So we have to be very cautious about it. And we have to see this slide that there is a death is also common in the patients who are having a hemophilia with inhibitors. So prevalence of the cases are very high. You can say up to the 20% of the patients can have a prevalence at any cross section. You can see the patient are having a hemophilia with inhibitors at present. So inhibitors are the major therapeutic challenges in the hemophilia in form of, because it is a patient without inhibitors, they have more difficulties in achieving hemostasis as known by the replacement, and 70% mortality rate is there, and the increased risk of uncontrolled bleeding and progressive disease, joint disease, 2 times increase hospitalization and 3 times annual cost of therapy. So that also matters very high. Since morning we are thinking about the same thing, like cost and patients care, that to be access for all, that is what the slogan is. So this is also the major thing we have to be included in that part. To annual cost of the therapy should and can be only reduced by the addressing the inhibitors in the patient of the hemophilic, and it also affects the give rise to the greater disability, need the mobility assistant device, and impaired the quality of life. Overall quality of life has been changed, will be affected. You can see in this that how much the patient may develop the swelling and joint disability. So what are the factors that help or it can aggravate the inhibitor development? It is a multifactorial. Sometimes the genetic factor, risk factors are already there, and this is something like the treatment related factors, treatment related risk of the factors. So in genetics, it is a disease. If it is severe, then there are all the chances genetic mutations can happen in any particular. If patient are visiting to you since long, you have to think of that, is there any genetic mutation is there or not, you have to keep in mind. And race is also been we have to keep in mind. And treatment related, of course, we are looking every time the exposure of the how much dose of the factor 8 or 9, and period of the intensive care, that is the intensive care usually in the surgical procedure or something like a accidental trauma to the patient. So we have to every time check for the this point to sing. So another things are, there is a null mutation is also common, family history is to be asked for, race and everything is to be addressed for, and immune response also to be checked for the patient. So genetic factors influencing the development of the inhibitors, even though if every time you are giving the required dose only, not the more dose of factor 8 or 9, but there are some genetic factors that are also mutations can also happen, and so every time you have to be vigilant to get it done that the patient is having any development of the inhibitor development or not. So this is again some environmental factor that affects the inhibitor development in form of the intensity of the first factor 8 exposure. Usually we see in the pediatric age group. Then sources, now it is not a much concern about it, as we are getting a standard factors. Early prophylaxis, trauma, surgery, and infection and inflammation, these are all the factor we have to keep in mind as and when we are dealing with the patient who are not responding to the routine factor replacement therapy. So this is again a very important slide to be keep in mind, because see, most of the time we think that it is a pediatric age group, first 50 exposure patient is more likely to develop inhibitors. After that, when the patient become adult and comes to us, then we are not much have a awareness or something like we are not calculating the risk of development of inhibitor in that case. But this graph shows that, however, there are all the chances, highest risk of developing inhibitor in first 50 exposure, that is fine. But there is a second peak in their life that comes after the age of 60. So we have to be vigilant about the second peak of all the types of inhibitor. It may be low responder or it may be high responder. But there is always a chances to develop the inhibitor at the later of age also. And another important risk factor to be keep in mind is the prophylaxis is only have a green signal. Rest of the treatment, whatever we are offering to the patient, all are having a red signal. All are having a chances to develop inhibitor. So no treatment gives us a guarantee that patient will not develop the inhibitor. Only and only prophylaxis has been given our surety that there are no chances of the inhibitor development. So looking to the all the risk factor, keeping in mind, there is another important aspect is the clinical suspicion of the development of your patient inhibitors or not is very, very important. Unless and until a doctor keep in their mind that there may be chance that we can miss the patient and we can increase the cost of therapy as well. So we have to suspect in the patient when there is a hemophilic patient, a poor clinical response to concentrate, lower factor level after giving the factor and after the expected infusion of the to the patient. And laboratory of course will help us. In that case we'll go in detail how to do it, but the mainly the important thing we have to first and foremost keep in mind and suspect the patient may develop inhibitor at any point of time, irrespective of giving a standard treatment. There are all the chances of mutation as well. And a very simple screening test at your hemophilia daycare center or at center is simple APTT test. Screening with the APTT test is very simple and we can use in a very routinely also. And if it is been prolonged or something, then and then quantitative test is to be applied. That is a Bethesda test. So again, I will emphasize that clinical diagnosis has a more important role to diagnose a patient with inhibitors. So if the patient's symptom persists, joint and muscle bleeds more than 3 days, in spite of adequate therapy, any bleeding that requires more number of factors or more quantity of the numbers, and even though sometimes if the patient is having breakthrough bleeding because of the some miss prophylaxis dose, you have to again suspect, go for the APTT at least. So slides are not moving. Next, okay. Yes. Next slide. So WFH has given a guideline. Slides are not moving on that side. Okay, fine. So these are the guidelines we have to keep in mind in our daycare center also. Okay, any staff can go through it every time. It is after initial factor exposure, after intensive factor exposure, that is more than 5 days. When there is an intensive, then post-surgical or something like, if patient develop recurrent bleed or target joint involvement, despite of the adequate treatment, failure to respond adequate treatment, lower than expected factor recovery time, if you are able to assess the factor S activity, suboptimal clinical laboratory response after the replacement therapy, before surgery we are doing routinely an invasive procedure, and there is a suboptimal post-operative response with the factor, also we have to check for the inhibitor. Pre-operatively we are checking, the surgeons are asking for it, orthopedician are asking for the inhibitor level, but post surgery also we have to look after, because 7 days are critical for them to recover. So this is a guideline we have to keep in mind. And this is another thing you can utilize for the suspect, the patient with this thing, that is we know, but 150 the highest risk for this, but the thing is important I want to convey is after 150 exposure days, it should be screened annually. It should be screened annually, irrespective of the no complication to the patient, or factors are been given adequately, and there is no there is a proper response to the therapy, even though you have to screen annually if there is a this is a guideline as per the guideline. So diagnostic workup in the inhibitor cases, how to confirm, that already been mentioned, but important thing we have to classify is a low responder and high responder. So this is again a laboratory test. We can go first, as I have mentioned, is a this APTT test. That patient plasma has been used for with factor 8, and we can see the corrected APTT, and that is a patient's APTT will be find out. But if the patient's plasma is normal, then you will get the patient does not having APTT corrected. So this is what routinely we send to the laboratory, and we'll see the APTT level to the patient. But lab diagnosis, especially as I mentioned, that is a clinical suspicion is very important. Mixing of the prolonged APTT will be there, and it is to be checked with the Bethesda quantitative test. Moving. Slides are moving. Next, okay, there is a line wise. So Bethesda stage inhibitor titer, if 5 BU is there, it is considered to be positive, or patient is having a inhibitors in their body. So this is another important chart you can keep in your clinic or in a hemophilia daycare that anybody can interpret. That is, if the Bethesda test is less than 0.6, it is not detected. Patient is safe, not having inhibitor. But if it is between 0.6 to less than 5, then it is been to be divided into low responder inhibitor, and the more than 5 it considered as a high responder. We'll go in detail about how it has been high responder and low responder is very important to be addressed. So more than 50% of the this patient of factor VIII deficiency have an inhibitor in a high responder group. So again, very important to screen patient for inhibitor every time and any time, and annually, of course, compulsorily. So this is, we have to check for whether patient falls in which category, whether it is low responder or high responder. And it is one of the amnestic response that will also, inhibitor may be present, but the body will react with the exposure to the, or not to the antibody. So this low responder, after receiving the factor, the inhibitor titer does not rise, and high responder, there is all chances that patient will develop. So this is the area of interest where we have to keep in mind. This is a common practice so many times we are doing. If patient is not responding the usual dose previously was taking, we will increase something like 10 unit more or something like 20 IU per kg more, and we'll take the chance sometimes at resident level or something like that. But there may be harmful to the patient that will increase again the inhibitor level in the patient. So this is again a very important critical point where we have to catch the patient and not to waste the factor replacement therapy and factors. So this graph shows you a very important aspect of the inhibitor, whether it has been low responder or high responder. And it will also prevent the use of the or wastage of the factor VIII. If we continue to give in high responder factor VIII more and more doses, then again the inhibitor will increases in there. And low responder, if we continue to give factor VIII, the inhibitor level will not increase. So we can take the message from this slide is only one thing, that we have to every time categorize. Otherwise, there is a wastage of the replacement factors in your patient. And there are chances of the high development of factor inhibitors, and that will require long time to treat the patient. So up till now, we know that inhibitors are very important to diagnose, and which are different factors and which are the how to test. It is very simple. APTT and Bethesda test will be very simple to do, and it will be possible every center and everywhere in the pathology laboratory. The important thing is now how to approach. Since morning we are talking about it, that patient having inhibitor and bleeding management, of course, by the stopping bleeding by the factor 7 or PCC, we can do it. But the long-term strategy, that is the eradication of inhibitor by the immune tolerance induction. It is the long-term strategy we are thinking since morning. We know that is a short term. When patient is diagnosed recently developed bleeding, we can treat with the factor 7, factor 8, or with activated factor 7 and the APCC. But the thing today we are going to be very important aspect of the treatment of the in form of immune long-term treatment in inhibitor, that is immune tolerance induction, because it can be induced in all patients with inhibitors, and patient again go to the prophylaxis or on demand. So long-term management why the immune tolerance induction is required. That is what the our goal today is, to prevent the patient to have any complications with the inhibitor, because it is very important to enable the regular factor treatment in case of bleeding and surgery, enable the prophylaxis treatment with factor to prevent hemophilic arthropathy and life-threatening bleeding, increase the quality of life, reduce the cost of hospitalization, and bypassing agents are required less. Lifetime cost efficacy. If ITI is performed early and successful, long time there is a cost of the therapy will be reduced, and potential to modify the inhibitor to enable the factor to use even in presence of low residual inhibitor. So there are all the advantages to initiate the immune tolerance induction, that is ITI. Changing? So you can see this graph then when patient has been given as a ITI successfully, the inhibitor level it reaches to the baseline. So it is the important thing to catch the patient, how much difference. You can again give the low dose prophylaxis to this patient. Previously you can giving a higher dose to the patient, higher and higher. But once you catch the patient at inhibitor level, put the patient on ITI, and then you can see the successfully the patient's requirement of the factor will give, comes to the very low level. So another way we can see these antibodies are covering the factor VIII activity. Once we start with the ITI, the antibodies keeping the free availability of factor VIII, cannot able to cover all the factors. Slides are not moving. No. So in between you can see that patient is having some free factor VIII available for the management or for clotting, and after post successful ITI, your factor VIII is available for the clotting cascade to be completed. So it is so useful to eradicate the antibody. As we know, it is preventive for everything, that antibodies to be removed. So inhibitor eradication is ultimate goal of the inhibitors management. ITI is successful in 80% of the patient with hemophilia A and 30% of the patient of hemophilia B. So it very success rate is very high. Just coordinate with the slides. So this is a protocol we can use for ITI protocol for hemophilia A patient. You can use high dose, that is 100 to 150 IU factor VIII per kg body weight 12 hourly. High dose up to 200 you can go. Intermediate dose is also been there, 100 IU per. But usually in India, it has been recommended at low dose 25 to 50 IU per kg of the factor VIII every day, alternate day, 3 times a week is very acceptable and effective same. So to be successful, ITI must be achieved persistent. What are the success when you give this alternate day? Then it is the BU level will reduce by less than 0.6 BU, and factor VIII activity will be remain in blood more than 66%. Half-life of the factors are also been increased. And stopping ITI, when to stop the ITI, that is to be considered when there is a, if inhibitor response is persistent or either it not being decreased by 20% within 9 months, within 9 months, starting from the treatment, it can be extended up to 33 months. So high dose versus low dose international studies consensus also recommend that there is no difference in the outcome of the patient, those who are on low dose or on high dose. So usually because of the availability of factors, we usually prefer in India, that is a low dose prophylaxis, that is ITI. So these are our real world experiences. At our Sola hospital, we are running a hemophilia daycare center since last 5 years, in which we are providing the 9 to 5, the immediate access to the patient, and up 24 hours it will be available in a casualty place. So at that time, we made a SOP for all the treatment, for the replacement, for prophylaxis, and for ITI. It is a regular practice at our center to detect hemophilia inhibitors and then induction of the ITI. This is a routine practice at our. We have made a camp every first Monday of the month for the inhibitor detection in all the patients every yearly. For till the all the 250 patients are enrolled at our center. So we have screened up till now all the patients. They have their identity card in which it has been mentioned the inhibitor negative, inhibitor negative, or is their level of the inhibitor. So that card will help us to when they come in emergency as well, whether to give the factor 7 or either to continue the factor 8. So that way also it will be useful. So we made a routine practice at our, when patient come to us and we suspect, then we screen them for the APTT level, and then we'll confirm with the Bethesda test, and we categorize. And we initiate the ITI by the getting the Bethesda report, counseling the patient that it is a long-term treatment, and doses of the ITI is being used at our center is 50 IU per kg, given 3 days a week, every alternate day. And we monitor the Bethesda test every 3 monthly for the see the treatment response, and decrease the titer level, whether it is less than 20% is there or not, or is there any response is not been as per expected. We check it, and we will repeat the Bethesda test after 3 months, and that will be, if it has been not detected or it will be less than 0.5, then we consider as a successful ITI. But there are some challenges also. If there is an increase or no significant decrease in the inhibitor level, increase the dose of factor 8 by 60 IU, 10 unit international unit per kg. You can go and increasing every monthly up to the Bethesda test comes to the normal, and that is maximum we go up to the 100 IU per kg up to the 9 months. Then we have to again revise sometimes some diagnosis, or we can keep the patient on another drug. So this is what the protocol we follow at our place. Some looking to this previous, okay. So duration of the ITI at our place is 9 months. The patient should be patient on ITI therapy. If there is some bleeding episode, we replace it by activated factor 7 in form of 1 mg per 10 kg, and we can see the later ITI is to be resumed within 2 days. After correction of the acute episode of bleeding, we resume the again ITI. And we consider then when patient is having ITI successful, inhibitor eradicated, and once the successful ITI is achieved, another short-acting factors, short half-life factor, 8 prophylaxis is been given to the patient. We don't give patient another chance to develop inhibitor. We immediately put the patient on a prophylaxis. And as I mentioned in early slide, that only and only prophylaxis gives us a green signal that your patient will not suffer from the inhibitors in their body. So we put them patient on a prophylaxis. There is no alternative for this. So we take the consent to the patient for a whole thing. They will continue ITI for 9 months if required, and after he should be ready to come every alternate day for the SHL prophylaxis and another prophylaxis that is in form of EHL or MSC, that we are going to get it. So if the patient is inhibitor positive report with the acute bleeding, that is what we know. We give the factor 7 in form of 1 mg per kg, and depending upon the site and severity, we can repeat it, and it should be administered, and Bethesda test is to be checked for before giving this drug. So these are our some important real world experience. You can be surprised. Okay, these are the things when it is to be considered to be implemented, how rewarding it is, how satisfaction will get it. It may be only in 1 or 2 patients. This is something a specialized thing. That is in 250 patients we have screened for inhibitor. We got only 77% of the patient are having inhibitors in there. But after that, only 1 or 2 patients who are getting a real result of this. So you can see this patient case 1, in it is a 45-year having severe hemophilia, having a right knee arthropathy. They diagnosed as a hemophilia at the child age. Then you can see how many complications he had gone through. That is, patient developed retinal bleed, loss of vision on right eye, having 1 intracranial hemorrhage in 2017. Then he got road traffic accident. Then again at that time also he had a intracranial hemorrhage. And he has been diagnosed at that time pre-operatively. Before that, it was not been considered, and he was not taking treatment at our center as well. So somewhere when he got the accident at that place, the pre-operatively, it is a common practice. They diagnose a case, has a Bethesda test for inhibitor, and it was showing 43.2 BU per ml. And the factor 7 was given because it was a roadside accident, and inhibitor was checking it during surgery. Before surgery is a common practice. But after that also, after that, patient took a rest at home, not repeated Bethesda test postoperatively also. And after 3 months, he was been again checked for the Bethesda test, and 19.3 BU per ml was been there. And after he again comes to us at Sola for the treatment, further treatment, we did the counseling because you had a very big intracranial hemorrhage and other complication. This is only the ultimate option for your treatment to future plan that prevent all the complications. So we have given a ITI counseling, and that was been started on May 9th. 50 IU per kg short acting factor 8 has been administered thrice day weekly, and with the factor inhibitor level were decreased to 0.9 immediately after 3 months, and patients are remain bleed free on ITI therapy. So then again the patient wants, I just don't want now any problem, and they just want a normal level because he passed through very long complications. So ITI was continued for next 2 months on 26 to, and then again after total 5 months the BU level has been achieved, that is less than 0.5, that is 0.5, that has been declared as a successful ITI. Then patient put on a regular prophylaxis dose of the SHL 20 IU per kg 3 times a week, and after that the patient was switched to the EHL. That again it has an advantage. We have a availability of the extended half-life factors 8. That is a 50 IU per kg every weekly we have given. We got the promising results. We got the promising result with the eradication of inhibitor and on prophylaxis. The current status of the patient is to no episode of bleeding at any joint, no intracranial bleeding, any internal bleeding, is regularly doing exercise, muscle strength was proven, has been improved, overall quality of life has been improved. Current Phi score of the patient is 24, and this HJHS score is 15. So it drastically improvement has been seen with the prophylaxis as well. And case 2, we'll go in a few more slides. That case 2, the young patient having undiagnosed with 13 BU, then within 3 months, it achieved a successful ITI, and now patient is on a prophylaxis. ठीक. So, summary and the take-home message, that is inhibitor formation is a serious complication of the hemophilia management. For on-demand and surgical management, these two drugs are available, but ITI with factor 8 is the only proven and recognized strategy to eradicate the inhibitor. Early detection, prompt initiation of ITI result in better patient outcome. When an inhibitor is detected, all cases should be offered ITI in order to optimize and chances to inhibit the inhibitor eradication. All ITI protocol are equally effective. Lower dose is been much better with the Indian setting to initiate the ITI. Next. So this is our hemophilia center's data. You can see that 152 patients are already been under treatment with us. Out of that, 142 are hemophilia A, 10 patients of hemophilia B. We have detected 6 patients having inhibitors in their patient, and we have successfully completed ITI in 2 patients. 4 patients are on treatment with ITI, and out of that, 3 patients, not on ITI, but other patients developed bleed and been treated. You can see that SHL prophylaxis, we are able to put on 17 patients 3 times a week. EHL, 5 patients are doing excellent with the extended half-life prophylaxis, and 1 patient on factor 9, we are done excellent with the prophylaxis. No bleed since last 4 months, and they are doing excellent. They're improving their Phi score and HSJ score. This is our hemophilia daycare team. Together teamwork, we done excellence with all the staffs and the doctors. With together we perform prophylaxis, ITI, and the eradication of the inhibitors in all patients. Thank you very much for kind listening. Thank you. I hope all will be sensitized for at least inhibitor detection and initiation of ITI. Any questions if time permit? Otherwise, it will be fine at the end of this thing. Anything? Anybody? However, it is again a post-lunch session, so I hope it is gone through your mind, not from overhead. Thank you very much for organizing committee, giving me this opportunity to share our real-world experiences. Thank you.
Thank you, Dr. Parul Bhatt, ma'am, to share your experiences. Especially, it's very happy and willing to hear that ITI happens even in government sector. Now, I request Dr. Premro Palwa, President, to please felicitate Dr. Parul Bhatt. A big round of applause for Dr. Parul Bhatt, please. It is our honor to have with us today Advisor Health, Ministry of Tribal Affairs, Mrs. Vinita Srivastava. Mrs. Vinita Srivastava has always been a part of hemophilia family and has been instrumental in getting support for hemophilia management through blood cell of NHM. Ma'am, we request you to please speak a few words to the gathering.
नमस्कार, शुभ अभिनंदन। अच्छा लगा सबको सुन के एंड इट वाज अ ग्रेट लर्निंग अगेन, क्योंकि मैं तो सुनने और समझने में पे ज़्यादा विश्वास रखती हूँ, क्योंकि जितना मैं सुनूंगी और समझूंगी उतना we can come up. So on behalf of Honorable Minister of Tribal, because he was supposed to be here today and he had some meeting in the PMO, so he couldn't turn up. तो मैं उन्हीं के उससे एवज से आने की कोशिश की और जानने की हीमोफीलिया फेडरेशन या हीमोफीलिया से जुड़े रहने का रहा है, काफ़ी सालों से अरसा रहा और इनिशिएट किया कंट्री में। खुशी हुई कि पेशेंट्स ग्रुप ने मुझे समझाया कि कैसे इसको आगे ले जाना है। तो सिखाने वाले सब लोग थे, बट पेशेंट ग्रुप वाज वन पर्सन एंड सम ऑफ अ गुड एक्सपर्ट्स, आई कैन से दैट सम हैव ऑलरेडी स्पोकन, तुलिका मैम ने बात की अभी, एंड अदर गुड एक्सपर्ट्स वर देयर हु टॉट मी हाउ टू गो अबाउट इट। सो वो मेरी लर्निंग थी और इंटरवेंशन कैसे एनएचएम में लिया, विच वॉज नॉट अ पार्ट ऑफ एनएचएम, बट इट इज स्टार्टेड एंड इट वॉज अ लर्निंग फॉर मी। लेकिन अब चूंकि समय के साथ रहते रहते थैलेसीमिया, सिकल सभी सीखा और अब बहुत सारी नई चीज़ें सीखने का भी मौका ट्राइबल अफेयर्स में मिल रहा है मुझे। दिस इज़ वेरी इंपॉर्टेंट। बट मैं एक ही बात कहना चाहूँगी कि जो सिस्टम में हम लोग रह रहे हैं उसमें बहुत सारी ऐसी चीज़ें ईजाद होनी चाहिए जो समय के साथ बढ़ती चली जानी चाहिए। लाइक वी वर टॉकिंग अबाउट पेशेंट मैनेजमेंट, हम बात कर रहे हैं पेशेंट्स की, मैनेजमेंट की, हॉस्पिटल मैनेजमेंट। वेरी डिफिकल्ट फॉर अ पेशेंट टू गो टू द हॉस्पिटल। मैम ने अभी बात की थी टेलीमेडिसिन की, इसलिए मैंने वो बात शुरू की और मैं उसी से एक बात शुरू करना चाहती हूँ कि सेल्फ मैनेजमेंट ऑफ अ पेशेंट इज वेरी इंपॉर्टेंट व्हेन डॉक्टर्स शुड आल्सो टीच देम। आपसे बढ़िया जानकार कोई नहीं है, बट आपको अब समय आ गया है कि आप अपने पेशेंट को उसकी जागरूकता इतनी ज़्यादा कर दें कि वो अपने बारे में समझ सके कि उसे करना क्या है, एंड विच इज़ अ चैलेंज फॉर अ डॉक्टर। इट्स नॉट अ ईजी जॉब फॉर यू ऑल। ये मत समझ लीजिएगा कि बहुत आसान तरीका है करने का, बट नाउ सेल्फ मैनेजमेंट ऑफ अ पेशेंट इज वेरी इंपॉर्टेंट विच वन शुड टेक अप। पहली चीज तो ये दिमाग में रख के चलना चाहिए कि किस तरह से उसे क्या चाहिए वो देखना है, हमें क्या देना है वो नहीं देखना है। अभी तक हम कोशिश ये कर रहे थे कि एटलीस्ट इंडिया में फैक्टर्स अवेलेबल हो जाए, ये सारी चीजें हो जाए। अब समय आ गया है कि हम उससे पूछें कि उसको क्या चाहिए, और जब उसकी हमें ज़रूरतें पता होंगी तो उसी हिसाब से हर स्टेट की पॉलिसी रिकमेंड होनी चाहिए। फैक्टर्स जब तक स्टेट ईडीएल्स में नहीं आते, आई एम वेरी हैप्पी कि राजस्थान ने बहुत अच्छा काम शुरू किया था, जब तक वो सब स्टेट की स्पेसिफिक प्रोग्राम्स में नहीं एंटर होते, इंटरवेंशन कितने दिन, ये बात सोचिए, इंटरवेंशन कितने दिन। And this is a time when you all have to collect together and come up with specific state-specific policies, or the government of India says that the blood disorders policies are important. This is a time where we should hang on it. तो आपको ये सब बातें ध्यान रखिए। मैंने सेल्फ मैनेजमेंट से लेके यहाँ तक की बात इसलिए की क्योंकि अब ये समय आ गया है कि हम पहले फैमिली थी, अभी भी फैमिली है, वो आज भी चल रही है। ऐसा नहीं है कि आज की तारीख में फैमिली नहीं है। सो फॉर मी एवरीबडी इज़ अ फैमिली एंड एक्सटेंडेड फैमिली होने का फ़ायदा ये था कि मुझे बहुत सही। तो अब मैं सभी से एक ही बात कहूँगी, थिंक अबाउट द पेशेंट सेंट्रिक। लेट्स स्टार्ट वर्किंग टुवर्ड्स दैट कि किस तरह हम पेशेंट को सोच के हम अपने स्टेट की पॉलिसीज़ में क्या इवॉल्व कर सकते हैं। और ऐसा एग्जाम्पल सेटअप कीजिए, स्टेट्स हैव अ बिग ह्यूज थिंग्स इन देम। हेल्थ इज़ अ स्टेट सब्जेक्ट, वी ऑलवेज कीप ऑन सेइंग। सपोर्ट सिस्टम आप लीजिए गवर्नमेंट ऑफ इंडिया से, मना नहीं कर रही हूँ, बट उस सपोर्ट सिस्टम को लीजिए, बट अपने सिस्टम को मजबूत बनाना आज की तारीख में आप लोगों के हाथ में। स्टेट स्पेसिफिक पॉलिसीज डिजाइन कीजिए अगर जरूरत पड़े। क्या हुआ था तमिलनाडु में, मुझे याद है अभी भी, आई थिंक डॉक्टर शांति से, वी स्टार्टेड विद द स्टेट स्पेसिफिक पॉलिसी फॉर ब्लड की हमने स्टेट स्पेसिफिक पॉलिसी बनाई तमिलनाडु और उड़ीसा दोनों स्टेट्स के लिए। उसी तरह से उन्होंने अपनी कुछ और पॉलिसीज भी ईजाद की हैं। My only concern is that now the time is that you start designing your state specific policies for these blood disorders as well. And this can be taken up very easily because now the time is कि आपकी मजबूत हो चुकी है, जो थोड़ी जड़ें थी, जो कमजोर थी, वो मजबूत हो चुकी। Now start working on that. And all my state officials are here. I know them personally, so I'm again reiterating this, that start working for this. ये काम अगर आप शुरू कर देंगे तो आपका जो तरीका है वो काम करने का बहुत ही फर्क हो जाएगा। एंड यू विल हैव वॉट एवर यू वॉन्ट टू डू, यू कैन डू इट। तो एक तो ये चीज ध्यान में रखिए, सेल्फ मैनेजमेंट का ध्यान में रखिए। सेंटर्स, जो सेंटर ऑफ कॉम्पिटेंसी एक्सीलेंस बनाए थे हमने, सेंटर ऑफ कॉम्पिटेंसी जिसमें सारी चीजें हों, फ्रॉम प्रिवेंशन टू मैनेजमेंट पार्ट। आप ये मत सोचिए कि हमने केवल इतना शुरू कर दिया, उससे हमारा अगर सीवियस नहीं हो रहा तो हमें परेशानी है। प्रिवेंशन पे तो बात करनी ही चाहिए ना। अभी मैडम बोल रही थी एपीटीटी कहाँ है, हमारे यहाँ सब्जेक्ट है क्या? चेक करिए। इसीलिए बार बार स्टेट स्पेसिफिक प्रोग्राम की बात कर रही हूँ। और जब तक आप ये नहीं सोच पाएंगे, समझ नहीं पाएंगे, इट विल बी डिफिकल्ट फॉर यू टू मैनेज द शो, क्योंकि इंटरवेंशंस शॉर्ट टर्म होते हैं। अंडरस्टैंड दिस एंड वी हैव टू गो अ लॉन्गर वे। एचएफआई से मैं अभी प्रेम से बात कर रही थी, मैंने प्रेम से कहा क्यों नहीं तुम अपने यहाँ ये इंटरवेंशन शुरू करो एंड गिव इट टू द स्टेट्स टू अडेयर इट, व्हाई नॉट? करा तो जा सकता है। यस, दैट नीड्स अ ठप्पा, दैट कैन बी इजिली डूएबल। स्टेट स्पेसिफिक ठप्पे लग सकते हैं। इट्स नॉट नेसेसरी दैट द गवर्नमेंट ऑल्सो, तो दिस पार्ट, द एनजीओ पार्ट कैन ऑल्सो वेरी वेल contribute in the systems, which is very important. तो मैं ज़्यादा बात नहीं करूंगी, बट मुझे एक ही चीज़ जो इम्पोर्टेंट लगी है कि अपने देश में क्या क्या हो रहा है वो जानने की कोशिश कीजिए। क्योंकि जैसे आज प्लाज्मा पॉलिसी की बात चली, मैं मीरा से भी कह रही थी, वाई WFH पॉलिसी? वी हैव टू थिंक आवर ओन पॉलिसी। वी हैव गवर्नमेंट ऑफ इंडियाज पॉलिसी, व्हाई नॉट? एंड दैट इज बीन रिवाइज्ड. We have blood transfusion policy. That has been revised recently. The transfusion medicine guidelines are there. Why not to see that? And they are pretty good. ऐसा नहीं है कि जानकारी, उसमें बहुत कुछ ऐसी जानकारी है जो नहीं है आप लोगों के पास। तो थोड़ा पढ़ने की ज़्यादा बढ़ाइए। रेयर डिजीजेस में अभी बहुत नई चीज़ें हुई हैं, उनको ध्यान में रखिए। सो यू विल कम टू नो व्हाट एग्जैक्टली हैज़ टू बी डन। अभी हम बहुत जिसे कहते हैं बिखरे हुए तरीके से काम कर रहे हैं। एंड मैं ये अपने ही एक्सपीरियंस बता रही हूँ क्योंकि मैंने खुद भी देखा है। क्योंकि इनिशिएट कर रहे थे ना जब, तो बस लग रहा था किसी तरह शुरू हो जाए, चीज़ें शुरू हो जाए। अब चूंकि चीज़ें शुरू हो गई है, अब उसको कहीं पे एक नया धरातल देना है। एंड दैट इज़ वेरी इंपॉर्टेंट इफ यू ऑल contribute. And I will also ask the companies to do a CSR activity. अगर हमारी आप प्रिवेंशन पे बात कर रहे हैं, तो अगर इन टेस्टिंग भी हो रही है, एपीटी और ये सब नहीं है, तो लगवाइए ना। आप सबको चाहिए कि सीएसआर में क्या कौन काम कर रहा है, करवाइए सीएसआर में काम। दैट्स द राइट वे ऑफ डूइंग थिंग्स। दे शुड आल्सो कम, दिस इज फॉर कंट्री ना, दिस इज नॉट फॉर अस। एंड हार्डली मी और माय ब्लड सेल ऑफिसर्स और एनीबडी डॉक्टर्स हु आर, दे आर नॉट पेशेंट्स, बट दे हैव टू थिंक ऑफ पेशेंट्स। सो उस तरह से काम करके एक नया इजाद कीजिए, मेरी यही गुजारिश है, because things can be done. It's doable. The sickle cell mission has given an impact that things can be done. It is the only mission in the world. And all credit goes to every patient, every policymaker, and the doctor itself who has done this real commendable job. So all these things are possible. मुझे एक बार किसी ने बहुत दिन पहले कहा था ये पॉसिबल नहीं है. लास्ट ईयर की बात बता रही हूँ. आई थिंक मैम भी थी. तुलिका मैम, चूंकि मैं उनको बहुत ज़्यादा बात करती रहती हूँ, क्योंकि हर छोटी चीज़ पूछ लेती हूँ. सर दर्द भी होता है तो पूछ लेती हूँ कि कहाँ क्या करूँ. बट मैं बता रही हूँ, इट वॉज टोल्ड टू मी कि इट इज़ इम्पॉसिबल, कि नहीं हो सकता. और मुझे पता था ये ऐसा तो हो ही नहीं सकता कि नहीं हो सकता. नहीं वर्ड तो मैं अपनी डिक्शनरी में रखती नहीं हूँ, अभी भी नहीं रखूंगी. तो काम तो करना ही होता है और काम किया जा सकता है. इसलिए स्टेट्स को बार बार मैं आप लोगों को कह रही हूँ, कम अप विद दी स्पेसिफिक प्रोग्राम्स. और सब लोग यहाँ पे बैठे हैं, चाहे वो डॉक्टर गुप्ता हो, महेंद्र हो, रूबी खान, उधर सब बैठ रही, मनीष भी दिख रहा था, विप्लेंदु है, सब लोग दिख रहे हैं. और तुम लोग सब लोग, these people can do it. Yes, wherever I am needed, I'm always there. I'm always there for the patients. I'm always there as a hand holder. जब आपको जरूरत हो, I'm always there. I will help you out to get these programs done at the state level also, which is very easily doable. I'm saying again, doable. So take it like that. And best wishes to all of you. नई कमेटी देखी, अच्छा लगा, सबसे मिली, बहुत खुशी हुई, बहुत लोगों से मुलाकात हुई, बहुत पेशेंट से मुलाकात हुई. मेरे लिए कुछ बच्चे बहुत बड़े हो गए हैं, अच्छा लगा मुझे उनको भी देख के कि चिल्ड्रन हैव ग्रोन अप, दे आर डूइंग वंडर्स. सो ऑल क्रेडिट्स टू गॉड एंड ऑल ऑफ यू, बिकॉज डॉक्टर्स आर द सेवियर्स. सो आई एम वेरी फॉन्ड ऑफ डॉक्टर्स. एक्चुअली मैं उनको कहती हूँ कि दुनिया में अगर भगवान के पास के बाद कोई दूसरा दिखता है तो मुझे डॉक्टर ही दिखता है. उसलिए नहीं क्योंकि वो, लेकिन वो किस रूप में है वो हम देखते हैं. तो इन्हीं सब शब्दों के साथ मैं ज्यादा समय आप लोगों का नहीं लूंगी. अच्छा लगा सबसे मिलके, बट इसमें गहन चिंतन की वापस आवश्यकता है. केवल प्रेजेंटेशंस और ये करके इसको रोकिए मत. प्रेम, दिस इज योर ड्यूटी व्हेन यू हैव बिकम अ प्रेसिडेंट ऑफ दिस. इट इज योर ड्यूटी टू सी एंड एनालाइज व्हाट यू हैव टू डू अगेन. ठीक है, पूरा रिवैम्पिंग पे सोचो कि क्या किया जा सकता है. डोंट गो कि क्या हो रहा है, कैसे हो रहा है, वो सब छोड़ो. जो हुआ है, एक स्टेबल, हमारी स्टेबिलिटी आ चुकी है, अब उसमें क्या आगे बढ़ सकते हैं उस पर ध्यान देना चाहिए. थैंक यू सो मच एवरीबडी, इट वाज ग्रेट. थैंक यू सो मच.
Thank you, Madam Vinita Srivastava, for the inspiring words and for the continuing support. I request our President and Vice President Development to please felicitate with the memento. Hemophilia and bleeding disorders are inherited conditions, and genetics and prevention of hemophilia is a very important topic. To speak on this, we have with us Dr. Deepanjana Datta, Consultant Medical Genetics, Kolkata, West Bengal.
Thank you so much. Can I have my slides, please? I would like to thank my Calcutta Hemophilia chapter, Mr. Santosh, and Mr. Prem over here for having me here. Thank you so much. And can we have the slides, please? So since morning, we all have been talking a lot about factors, and we also, Abhi ma'am also spoke about prevention. So to prevent or bleeds or to prevent further in the generation, we need to understand the genetics of hemophilia. And in this case, when we talk about hemophilia, it will be either hemophilia A, B, or C. When we are looking at A and B, they are X-linked disorders, which means that they are passed from the female who are the carriers to the male people who would be affected. And also can be the VW, which is autosomal dominant, and that is not limited to sex. Now, I'll not waste too much of time regarding what these are and the mild, moderate, severe, because you have been hearing that from the morning, but both of these F8 and F9 are on the X chromosomes. Now, if we look at genes, and if we have to like simplify that genes down, it's basically like a blueprint. हम घर जैसे बनाते हैं, तो घर बनाने से पहले we have the blueprints, and genes are also blueprints. Now, the F8 gene is a longer gene. It's a bigger gene. It has about 26 exons. So ये हम लोग एक ट्रेन के डब्बे जैसे सोचेंगे, तो इसमें 28 exons है, तो ये बहुत बड़ा gene है. लेकिन the F9 gene is a smaller one. It has only 8 exons. Now, why this is important is because when we are doing a genetic testing, we need to understand that there can be changes in these exons and regions, or the intronic regions. So, जैसे whenever we look at a particular, like say if we are looking at a particular line, say Ram ran to the cat. So if we just move the cat and we say Ram ran, so it's a deletion. So there can be these kind of changes. If we have something in between, it becomes an insertion. If there is a change from RAM to RUM, RAM becomes RAM, and the meaning changes. So it can be a missense mutation. Similarly, there are different kinds of these mutations that will affect the ultimate meaning or the protein. So that will actually lead to what we are saying as severe, mild, or moderate, and hence the information is important. Like apart from this, there is also another thing that we see especially in the F8 gene, what we call as the insertion. Now, when we look at the insertion mutation, the inversion mutations, these are intronic inversions which we are looking at, and in this case you can see that we cannot, if we are reading through, like when we are sequencing, it's basically reading ABCD. Now, if we are doing a gene sequencing and reading ABCD, we can read it from behind also, but the meaning will stay same. But in case of these inversions, what happens is that if there is a small change which cannot be detected if we are doing a sequencing, like ABCD becomes ACBD. But this is not picked up when you are doing a normal sequencing. You need a special kind of PCR or primers to actually detect these kinds of inversion. So there are two of these present in intron 22 and intron 1, which can also lead to severe forms of hemophilia. Now, yeah. So if we look at the profile, on your one side, you will see the F8 profile. You can see that the intron 22 is the most common one, inversion. And we also have other kinds which we were talking about, the missense, the nonsense, the point mutations. While for factor 9, the most common are the point mutations, while the other deletion duplications are in smaller amount. Why do we need that? We need that to understand what to test the patients. So when the patient comes, that we first need to understand whether it's a moderate or a severe hemophilia. If it is a moderate or a severe hemophilia, then we actually, especially if it is below 1, we actually start with the intron 22 inversion and the intron 1 PCR. If that is negative, because we said that is the most common. Now, if that is negative, then we will go down to sequencing or reading each of them for these point mutation. And if that is also negative, then we go for the smaller deletions duplications, which is done by the MLPM. Similarly, for mild hemophilia or hemophilia B also, we will normally sequence first, and if it is negative, we will look at MLPM. Now, we said that the inheritance of A and B are both X-linked. So here it is a diagrammatic representation where it shows that the mother is a carrier. Women will have two X's. So one X is mutated, the other X is fine. And there will be, for the daughter, they will either receive the good X or the bad X. If they receive the good X, then they are getting that from their like father also. And if the father is asymptomatic, then they are normal. But if they are getting it from their mother, they become carrier. But the son here will receive this X from the mother, and hence the son is affected. And if the son receives the good X and the Y from the father, then the son is also normal. So if we look at it, then 50% of the male people will be affected, while 50% of the female would be carriers. But when we say that hemophilia is a X-linked disorder, this is true for all X-linked disorders, that even females can have hemophilia. So there are certain conditions like Turner syndrome, there are certain conditions called lionization, where one X gets silent, and in those situations, even a female can have hemophilia. So don't be under a preconceived notion. It is best to check if you have a suspicion. So excuse me. Yeah. So if we look at the testing protocol, so normally we rule out inversions, then direct sequencing, MLP, and in certain cases, we can do karyotyping as well. So if we look at it, when you're, as madam also said, that when we are looking at severity, the severity is not restricted to just, these mutations. These mutations, like when we are playing a game, say we all like Sachin Tendulkar or we all like Messi. But Sachin or Messi is not playing the game alone. They have other players which are there and they do take part. Now, when we are looking at hemophilia, there is a plethora of genetic factors that actually influence that particular phenotype. Normally, when we are looking at inhibitors or we are looking at a phenotype, these should also be looked into. But these are not looked in general as far as India is concerned. But that is the reason why we say that 30% of the people might develop these inhibitors. These inhibitors don't have anything to do with the morbidity or mortality, but they just make the bleeding difficult to control. Now, if we look at mutations, the larger mutations which are there, the larger deletions, the larger nonsense which will actually lead to truncation of the proteins, will deplete the proteins of the body. And here, when you are having these replacement factors, you will tend to develop, you have this chance of developing the inhibitors. But in other cases, the other cases like the missense or the smaller, changes there, the chances of developing inhibitors is less. Now, this is again a diagrammatic impression of what we are saying. So female has 2 X's, male has 1 X. Now, if there's a good X and a bad X, and here in case of the male, there is good X because he's not affected. In this case, the chance that the male will get is 50%. They can get 1 good and 1 bad. And the female can be a carrier, or the female can be or the female can just have, both the normal ones. So we need to test for the females. We need to test. Just a biochemical testing will not tell us whether they are carriers or not. Now, if we are looking at inheritance, the first one we already discussed. The second one is very important, that if you are a person with hemophilia and you are married to a normal lady, the chance that your male children will be affected is completely zero, because you are passing on the Y, you're not passing the X. But the chance that you are passing on the X chromosome to your female is almost 100%, and hence all your daughters would be carriers. So this is something which we shouldn't forget. So this is some carrier, which means we know that the female child of a hemophilia person will always be a carrier. So now the next one is that if this person marries another carrier who is, if a hemophilia person marries another woman who is a carrier of hemophilia, then even a female child can be affected, and there will be about 50% of the male children affected, and one would be the carrier. So we need to understand what we are looking at. But hemophilia is not always hereditary. It's sometimes like 30% of the hemophilia will also have sort of no family history, and it's a de novo mutation. It happens in that particular person itself. So So when we are looking at women with who are carriers, are women's having no symptoms at all? This is very important to highlight because we are hearing since morning all the symptoms of hemophilia. But even women can have certain issues. They have bruises. They do have heavy periods. They do have problems during their menopause. They also have problems during delivery. So this needs to be, there is a chance of postpartum hemorrhage. So we need to be careful about them and they need to be screened properly. Also, while delivering a baby, these babies can also have hemophilia, and hence utmost care needs to be taken when you are giving vaccinations and all. So here I would also like to point out, like we were hearing that, hemophilia is a treatable disorder now and we can detect it. So in this case, newborn screening should also include hemophilia at this moment. We do screening for disorders which we know are treatable. Right now, hemophilia is a treatable disorder, and newborn screening should be done, because what we do, we end up missing mild cases. Severe and moderate cases are picked up, mild cases are missed, and they come up as accidents which create traumas, and we cannot do anything about it. So this is where, when we ask to you for a genetic testing, probably there are a lot of questions that come in. If you are a sister to the brother, you might feel that whether I'm a carrier, whether I pass it on to my generations. You as a person with hemophilia might have this issue that what do I do next, whether I have this chance on passing it to my daughters, and what happens to my daughters. So very simple thing is, without anxiety, just go for a testing. If you test, like in this case, we tested this female, she has a F9 variant which we are seeing. In these cases, normally we would do an amniocentesis or a CVS, which is an invasive test where we either test the amniotic fluid or we are testing the chorionic villus around 13 weeks to 18 weeks. And when we are doing the testing, we isolate the cells and we do the genetic testing. And in this case, you see the fetus was tested, and unfortunately, this fetus was also affected. Now, in this case, it is a choice of the family whether they want to continue or not continue, but then they can take the prophylaxis, they can take precautions before having this child. The other methods, if you don't want to take a risk, you can actually use a donor egg or a donor sperm, depending on what we are talking about. In this case, like if you are a carrier, we can take a donor egg. If you are a person with hemophilia, you can take a donor sperm, and in that way you can prevent it in the next generation. There are also preconception testing that has come up, like pre-implantation testing, where we can test the embryos. So here the embryos are made with your own gametes. The eggs and the sperms come from yourself. We make these embryos, and from these embryos at day 5, we take a biopsy of the trophoblast cells which would form the placenta, and once we take that, we can do a testing. This is called PGTM, and in this case we will select the good embryo and implant it back to you. Now, right now we spoken a lot about gene therapy. Just and the one gene therapy that got approved is the gene therapy with the AAV virus. So when we are looking at it, then basically these viruses, how it is done is, these viruses have two repeat regions in the two ends, and in between there are these regions which are important for the making of the virus. What is done is that this region is modified and we put in the transgene. Now this transgene has a promoter which is specific for a particular tissue. In this case, it is specific for our liver. So they are then sort of packaged into these viral heads and injected. And when they are injected, because I said they have a liver specific expression, they will go to the liver, they will express, and that is where these proteins will get expressed. But then, as we were talking like previously also, so there are certain problems or limitations with this. When we are saying limitations, there will be immunological responses and affected by adenovirus itself, and if we are affected by adenovirus, we might not respond to this. So again, your factor levels differ. 5% cases that there is a problem. There can be vector-related antibodies that can come. There can be immunosuppressors. There can also be that the virus is not accepted and your body actually has gained a lot of it. As far as the significantly, but it has been shown that this is the factor 9 one, where also it has shown very promising results. But if we are looking at it, then can I have my slides back? Thank you. So if you're looking at it, see, there will be a low dose cohort and there will be a high dose cohort, and how much this will be retained will vary from ethnicity. So right now we don't have an Indian value and Indian cohort because we don't know what is happening here. But these values will be different because of the background which we had already spoken about. And this is not the only one, as sir said in the morning. Dr. Alok was saying this in the morning. What we are talking about is in vivo gene therapy. There is also ex vivo, where we can actually put these into the stem cells and these altered stem cells can be introduced. Also, there is gene editing, where we are actually using CRISPR-Cas and reprogramming the cells and then putting back. So all these are in line when they come in. We don't know which one is good and which one will be actually sustainable till the end. But when we are doing an assessment, there's a genetic counselor, there are all the hematologists, there are the surgeons, every sphere, it's a multidisciplinary one, who will actually do the disease education, the psychosocial assessment, the risk assessment, and the genetic testing. Now, in the morning, yesterday, we were actually talking about this thing that when we are looking at counseling, who will counsel? So we also need to generate this, that, we don't need a counselor or we don't need a geneticist at every center, at every place. What we need to do is we need to actually have a good referral system. So if we have a good referral system, then it should be referred from the top to the bottom, and the main places, if they have these testing facilities or these assessment facilities, it will be very helpful. So this is basically where right now we are actually diagnosing historical patients. If we do a newborn screening, we do these kind of prenatal testing, we will have more of the patients who are not, affected. They are pre-symptomatic, and those pre-symptomatic people can be treated and they will not become historical patients, but can have a healthy lifestyle. So with that, I would end my talk. Thank you. Yes, ma'am. I can't hear you.
Wonderful presentation, madam. Thank you so much. I just wanted to know, we are talking a lot about that we can separate fetal cells from the peripheral. How do you look upon that aspect instead?
You're talking about NIPT, correct? So see, NIPT has not been developed for hemophilia as of now, but in the Western world, NIPT has been developed for thalassemia. For NIPT to develop, we need a very strong background of what mutations we are going to study. So that is the reason why I would request here at HFI that if you can have a project, you have so many individuals, if you can have a project and if we can come up with the common mutations, we cannot test in an explorative way in NIPT. We need specific mutations. So if we know those mutations, then we can do a cell-free study, and it has to be developed per India. It cannot be developed on basis of West. We need to know our mutation profile.
Ma'am, you told that there are several mutations, a plethora of mutations in hemophilia. Ma'am, will this will affect the gene therapy also?
Yes. It will not affect the gene therapy. All of you are taking factors. So ultimately, the protein is the same. The mutations are affecting the protein. What will happen is how you will respond. Say somebody has a deletion and somebody has a point mutation, which is not a truncation mutation, which means that protein is produced over there. And somebody has a mutation where no protein is produced. So obviously, these two will not behave the same way. Your factors are also not behaving the same way. So like you right now know that the ones which a truncation mutation can develop a inhibitor, we need to understand that here it's just not about that. It is also about the immune system which will come in, because we are introducing a virus. Though it's a naive virus, it will not do anything, but still it's a virus that you are introducing, so your body will respond. So this plus those immune system, what will come up is something that we don't know. The response will vary, definitely vary.
Ma'am, is it specific food to different mutations? The gene therapy will be different or the same?
No. The way this has been done, this is not gene editing. So gene editing will be specific to mutation. In this case, we are not doing gene editing. We are introducing a transgene itself. So the ones which are available now, it will not affect them. It will not be a mutation specific one. No.
Thank you, ma'am.
Anupama, I think we should proceed. Dr. Cecil had just.
So, thank you, Dr. Deepanjana Datta, for the speech. I request VPD Ramu Gadkar to please felicitate Dr. Deepanjana Datta. Accessibility to treatment and timely treatment is a big need for hemophilia. To speak on implementation of home-based therapy and challenges, a real-world experience, we have with us Dr. Anupam Datta, Associate Professor, Department of Medicine, Assam Medical College Hospital, Assam, from Government of Assam. A big round of applause to Dr. Anupam Datta.
You have the slides here. Good afternoon, everyone. So after a lot of scientific talk, probably I will be the one who will be talking a little bit of science. Can I have my slides? So first of all, I thank HFI for giving me this opportunity to speak on home therapy. And I'll be focusing more on the management at home, and probably my focus will be more on the patient empowerment and back to the patient's involvement in the management of hemophilia, and the fact that they will be having the greater say in the management. So can we have my slides, please? Implementation of home therapy. My slides are on. Yeah, thank you. So this is Alex Dossett, and he's a cyclist and he's a pro athlete. And he suffers from severe hemophilia A. Then we have Chris Bombardier, who is a mountaineer, and he has climbed all the peaks, highest peaks of all the continents in the world. We have Miles. Miles is an US junior Olympic player. And then we have Chandler Jackson and Cortland Jackson, who also have hemophilia, and they're professional basketball player. My point is, and which has been made by Madam some time back, is nothing is impossible. It may be difficult, but it is achievable. May not be today, may not be tomorrow, but one day. So what's the roadmap to the treatment? The first thing is obviously education and awareness, which we are doing right now. Second is obviously identification by clinical and laboratory that have been discussed. And then we have management, where we manage the acute bleed and then the complications. But what then? Do we leave there? No. Actually, the story just starts there. How do we prevent the bleed? How do we prevent the joint damage? How do we do a prompt treatment of the further episodes, emergency management, inhibitor management, physical, and ultimately, and the most importantly, treatment and self-care, which is the patient's own domain. So this has been discussed earlier. What I will say is what happened to us. So 2014, we started the training and awareness. In 2016, we started our first hemophilia OPD on every Saturday with only 46 patients. In 2017, we started getting the humanitarian aid, and that's when we started the episodic treatment. Whenever someone had a problem, we gave them factors. But in 2018, the government of Assam started procuring factors, and then we started the prophylaxis. How did we start? We started with the children first, because of the lesser number of factors being required for the children. Then we went for those who were having more bleeds and those who were more debilitated and wheelchair based. So our response was published, and we saw that the annual bleed rates significantly reduced both in hemophilia A and B. The hemophilia joint score improved, and also the functional assessment improved. When that happened, that's when many more patients started coming to our center, because our center is in the Dibrugarh, but many people came to us and they said that we wanted to have prophylactic therapy. Now, this is a case Tananina from a place called Dapurijo in interior of Arunachal, who came to us with intracranial bleed. We treated the patient improved, but the patient saw that there is a treatment called prophylaxis, where the patient can be given on regular factor replacement and the patients improve. Now, how do we do that when the patient stays in a place? It takes 3 days to even reach to our place. That's when we came with the idea of the home. We looked into the idea which is already there in the West, that's called the home therapy. So it is immediate access to the factor concentrates and therapies and other hemostatic agents at home. So it can be home-based prophylaxis or home-based on-demand therapy. So what are the benefits? First is optimal early treatment, reduced hospitalization, and less long-term disability, because you treat immediately. Now, it cannot be just there. It has to be supervised. So we physician supervisors, then we have the nurses, then we have medical social worker, volunteers. So what we did was we made a hub and spoke pattern a kind of a point of care, where Dibrugarh Assam Medical College was the hub, and we have multiple spokes in each and every district. So each and every district's patients would be taken care by the local volunteer. They will be reporting to the nursing coordinator or our physiotherapist, and who would be ultimately reporting to us. And that's how we could monitor everything. What was important is proper education about the recognition of the bleed, the dosage calculation, storage, aseptic techniques, venipuncture, record keeping, and proper storage of the products at home. First thing that we did was obviously education and training with regular CMEs, and also hands-on bedside training by, this is our nurse, hemophilia nurse, who is been teaching the parents. What we found something very interesting was the use of mannequins, which were used for the undergraduate students and the nursing students to teach them how to give home therapy or self-infuse. We also tried some vein finders, which are quite useful and handy for the patients and the parents to use. We didn't just stop there. We also started short training programs with certifications, where they would go through a short training, and then the certification with which we say that, yes, you can go ahead and now you can give the training. You can give the infusions. We didn't again stop there. We went a little bit more further, and our nurses reached their home. And at home, we hand-holded them to give the factors. Here on the right side, you can see they're giving emicizumab, which is quite easy. Once they learn it, it becomes quite easy for them to do. It's not only there, then we have to review and evaluate. We need to see whether their treatment adherence is there, the injection techniques, the understanding of the prophylaxis, what does it mean, and how do we do it? We do it by home visits. We ask them to demonstrate when they come to our OPD, and also ask them to make the videos and send us. This is the record keeping that we do. We have our office. We do keep records of who gets how much factor. And this is the record at both ends. The patient will have their own records, and we will have our own records. It's also very useful to be part of various registries that has been highlighted in various talks today. And when you are a part of the registry, the whole procedure of who gets how much factors and everything gets recorded. This is the kind of thing we look into it, whether the proper storage of the factors and the needles and the sharps are there in the refrigerator. They don't mix it with other things. How to keep track of the vials? For example, we have given someone 10 vials, the batch and the lot number is recorded. Patient take that at home, they take it, they bring back the empty vials. When they bring back the empty vials, then only we refill them. If they cannot give us the empty vials, we'll not give them the. This takes care also of one more important thing, that is the waste disposal of the glass vials, the needles, the sharps, and the plastics. What are the challenge? Yes, the bleeding recognition is a challenge. Self-infusion is a very important thing that we have understood. It takes a lot of time. Self-care, record keeping, adequate supply, that is very important way to ensure that the government gives us regular factors for us, and storage and reconstitution. But the biggest challenge is the inertia that can be from the part of the healthcare provider, the patient itself, and also the policymakers. We don't stop just only the factors. There are other things where the patient empowerment is required. So what are the adjuvant therapies, the pain medications and antifibrillatics? What are the price? We all know about the position, the rest, ice pack and everything. And the fitness. We don't stop there. We have to talk about the fitness, swimming, and a little bit of an exercise and physiotherapy. So in our HTC, all those patients who are on factor replacement, out of them, 43 of our patients, both young adults as well as elder ones, are on self-infusion. 34% are on home infusion, which means the parents or the guardians do it. And 19%, it's the local pharmacist or the local nurse who do it. And it's only 4% who actually come to our HTC to take the factors. The home therapy got a big boost during the COVID time. As you can see, this was the graph of our patients who are on home therapy, but it was after the COVID and the lockdown that suddenly this got pushed, and most of our patients now are on home therapy. The health economics has been talked about. There are lots of positives and negatives. We published a paper on the adherence and cost effectivity of home-based prophylaxis over institutionalized prophylaxis in patients with hemophilia, which we find out two important factors. One is the skip in the prophylaxis. Earlier, before home transfusion, there was mean of 25 skip in a year, plus minus 11. But after home therapy, it came down to 4 skips per year. And the transportation cost came down almost from 3,500 to somewhere around 400 rupees. We break it down and we found out that before the home transfusion, almost 50% of the patient were spending more than 2,400 rupees on just transportation alone. And after the home-based therapy, 88, almost 90% of our patients were spending less than 800 rupees per week. We also looked at the skip in the prophylaxis. Earlier, 77%, almost 80% of our patients were skipping more than 12 doses per annum in the prophylaxis, regular prophylaxis. But after initiating the home therapy, almost 60% have no skip and 20% have at 1 to 3 skip. That's a significant thing that has come. The school absenteeism improved, and hence these grades improved. We got very good results. Many of our students are becoming now toppers in their class. And so we may not have cyclists or Olympic players in our HTC, but we have our local heroes. We have Biu Singh, who runs 2 NGOs. He's on home therapy. We have Chaudhary. He runs to anyone's help. And we have Bittu Singh, who though was once in ICU for 2 months because of serious bleed. Now he aspires to be a politician, and he actually wants to look into the disability thing. One of our proudest moments was one of our patients actually joined medical college this year as first-year MBBS student. And that's patient empowerment. That's what we are talking about. That's what should be our goal. And I would always like to mention him. I would not name him. He was not given the permission. But he is from a river island called Majuli. If you know, Majuli is the largest river island in the world, in the river Brahmaputra. And 3 months every year, it's flooded. So from May, June, July, it's completely flooded. They cannot come to our hospital. And he is not only a hemophilic, he also knows something called the Khotrio dance, which is a dying culture of the Assamese tradition, Assamese culture. And to stop him from dancing is kind of stopping our culture. And when he started on home therapy, now not only he dances, he teaches Kshatriya culture. And he takes classes twice in a week, and just before the class, he will take the infusion. And I'm saying here that you can measure the hemophilia joint score, you can measure the functional scores, you can even measure whatever the improvement the patient is having psychologically. But what you cannot measure is what a patient can contribute to the society back by being a doctor or an engineer or a responsible citizen, and in this case, probably someone who is preserving the culture of a whole state with the help of home therapy. And now this kind of what we are talking about, the whole thing, patient empowerment. Thank you. Thank you all.
Thank you, Dr. Anupam Datta, for the inspiring speech. I request our VP Finance, Jagdish Sharma ji, to please present Dr. Anupam Datta with a memento as a token of our love and appreciation. Next, we have a panel discussion about programs and sharing of best practices. The panelists from states are Dr. Sunita Agarwal, Delhi, Dr. N.K. Gupta, Bihar, Dr. Ruby Khan, MP, Dr. Vishnu Sharma, Rajasthan, Dr. Rahul UR, Kerala, Dr. Mahendra Kendre, Maharashtra. We have with us as moderator, Dr. Shashikant Apte. Please give a big round of applause to all the panelists.
Good evening, everyone. We had to slightly change the schedule because some of us have to catch the flights. And the way we are running late, 3 of us would have missed the flights. So it's a very important session. I'll invite panelists, Dr. Kendre from Maharashtra to come to the dais, Dr. Sunita from New Delhi, Dr. Vishnu from Rajasthan, Dr. Gupta from Bihar, Dr. Ruby Khan. So I thank my other speakers for allowing us to reschedule the program. So before we start, I would suggest, I'm Dr. Rahul from Kerala. Sorry, I forgot your name, Dr. Rahul. I would suggest that for 2 minutes, please speak about your program in your concurrent in the program and how the things have been changing in hemophilia field. Starting with Dr. Sharma, Vishnu.
Sir, basically I am working in SMS Hospital, Jaipur. It is the biggest hospital in the Rajasthan, and I think it is biggest hospital in North India except AIMS. So we are providing free of cost factor. We have activated factor 7, that is NOVO 7, factor 8, factor 9. Extended half-life factor 8 is also available, and we have extended half-life factor 9. And recently we have started Amicizumab also. And we are around 10% of patients are on regular prophylaxis, and we are hoping that more and more patients will be incorporated in prophylaxis after this extended half-life because of the less number of hospital visits. And we are doing regular surgeries also. We have performed almost around 15 surgeries, around 10, 11 minor surgery, including circumcision, liver biopsy, intercostal tube drainage, dental extractions, and major surgery including hip replacement, knee replacement surgeries. And we have done knee replacement surgery in a hip replacement surgery in a patient of inhibitor, hemophilia A with inhibitor. So the managing hemophilia A with inhibitor in a surgical setting is very, very challenging.
Absolutely.
And the patient did well, hemostasis was excellent, and patient is doing excellent.
Thank you. Excellent, Dr. Vishnu. Dr. Gupta.
In Bihar, earlier the program was taken care by the society. In 2020, blood cell was formed, as told Dr. Ms. Vinita Srivastava. I was
appointed as nodal officer. So nowadays, some development is being taken. Like number of patients as per society, it is 1,644. But since there was no registry in government sector, so NHM create a website and put a registration, and all patients are being registered. Nowadays, 1,045 patient is registered in government websites. So still there is a difference of 500 or 600, but we are fulfill the gap. We are taking list from society and comparing with the government website. So very soon this gap will be filled. There are 4 daycare center. All 4 daycare center is being established by under CSR project. 2 from Intas and 2 from Care India. And fifth one is Purnia, which we will establish with NHM fund. Apart from this, we will try to declare all district as hemophilia treatment center. So far as and Patna also has AIMS Patna has also requested for daycare center. So they will itself establish their center. So and one hemophilia treatment center is already run by the society at New Gardner Road Hospital. So we are improving the facility to the hemophilia patient. We have nominated nodal officer in all districts of Bihar and already trained on 19 September 2022. We are publishing advertisement in newspaper every year. Today it is also published in 2 Hindi newspaper, 2 English newspaper and 1 Urdu newspaper. So every year we are publishing newspaper advertisement in newspaper. I have shared with Mr. Prem Balwa that cutting. Disability certificate we are issuing to the hemophilia patient. We are giving digital donor card to all patients with barcoded, and patient can get anybody can get information from that very barcoded. Free testing, treatment, and vaccine is also available. So far as red contract is concerned, we have both plasma derived and recombinant, and plasma derived factor is available in 31 district out of 38 district, and recombinant is available in 31 district out of 38 district, and plasma derived factor is available in all 38 districts. So this is also recent 2-year achievement. We have included both plasma derived as well as recombinant in essential drug list. So now there is no need of fund from government of India or any. It is included in essential drug list. Then government have to keep all these drugs in all hospitals. So we have make a game change in our state. I have never asked from NHM now for fund. This year I have not put up in ROP also for factors. So this is great relief for me because it will be done itself.
Okay.
Nothing to worry.
Excellent.
And so far as factor is concerned, in 21-22 recombinant factor, 16,430 units were supplied to all districts, and in 2022-23 it is 27,000. So recombinant factors demand is increasing, but I am concerned with the expenditure of plasma derived. It is 5 lakh unit in 2019-20 and again 5 lakh unit in 21-20. So this is my concern, and rate contract of EHL is also under process. Very soon we will get from corporation. Thank you. This is the
Thank you. I will also invite Dr. Biplendu from West Bengal. He has just reached to join the panelists. Dr. Biplendu. We'll go to Dr. Sunita. Dr. Sunita, you come from state of Delhi.
Yes,
it was the first state to start a comprehensive hemophilia program. With you and your team, Dr. Naresh, you created a certain yardstick in the country when nothing was there. How do you seen when it started on day zero and today after 15, 16 years?
Yeah. Thank you, sir, for giving me opportunity to speak about my state. Yes, you rightly said, before 2007, we didn't have so much facility for the hemophilia care. We are dependent upon some NGOs and like that, and we are not getting any treatment in any government hospital. But in 2007, our Lok Nayak Hospital, associated with the Maulana Azad Medical College, got this opportunity, and we are the central network coordinator for all of the state. And we have now the three hospitals, that is the DDU hospital and the Guru Tegh Bahadur hospital. We have the daycare centers, but our center is the hemophilia daycare center, one of the biggest center in the Asia and the state of the art center, even recognized by the World Hemophilia Community, which is providing catering. At present, today registration was 3600, in which around 2800 was the hemophilia A, rest are the hemophilia B, and the some rare bleeding disorders, few patients, von Willebrand disease, factor 7 deficiency, even the factor 13 deficiency also. We are not only providing the therapeutic in the form of the standard half-life product. We are only providing as a basically demand therapy, sir, as per our government state policy, but also providing the diagnostic. We have the attached lab with us. We are doing the factor 8 level, factor 9 level, PT, PTTK, mixing studies, CBC whenever required, even the fibrinogen level and all these things. We also have the counseling. We have the social worker with us. We have the physiotherapist. Even from time to time, we are running the awareness activity in the form of the, would say every year we are celebrating the Hemophilia Day. Now we are celebrating on the 25th of the April, as Eid is on the 23rd, and we are mainly catering to our population. And not only the awareness activity, we are did the wonderful job in COVID also. It is the only center in whole state which was open during the COVID time. All the facilities were shut down, but our center were open, and the patient are regularly coming to us for the factor replacement therapy, and then the telephonically we are counseling them on the daily basis. 20 to 30 patients were counseled about the treatment, how to remain safe, stay at home, follow the COVID protocol and all these things. And the vaccination drive was started when we called the patient, give the factor therapy at center, and go then send the patient for the COVID vaccination. We in the 3 to 4 months, we vaccinated all our hemophilia patients according to the government policy, I would say. And to empower them, it is the basically not only we are the providing the tent, we have to empower them also. So we are always giving the self infusion training program. We have already reached that 100 to 150 patients, basically to train them the self infusion. They know how to give the factor at home whenever needed. And it was need was that sometimes factor is available in their state, because we are not only dealing with the Delhi, we are dealing with the UP, we are dealing with the Haryana, we are dealing with the some other states also. So, but they were hesitant to take factor, their family were hesitant, even the doctor were hesitant. So we have made empowered them ki how to take factor. Now they are self-reliant. In even the some, we have the some government beneficiary patients like the ESI, CGHS, they are getting factor on the regular basis, so they can self-infuse therapy. But still our dream is to get the regular replacement therapy for all the patients, because all demand cannot prevent the disability in future. Our dream is to give the regular replacement therapy on a regular basis, but still we are basically all are the support by the our government only, daily government. So for the regular replacement therapy, we need some support of NHM. We need some support of even the factor from the humanitarian ground, which still we are not needed. If we get the factor from these factor, then we give the regular replacement therapy, then the home therapy, which is our dream. Maybe the non-factor therapy, emicizumab, and the extended release product. These are our dreams for our center, and we are trying to fulfill. We are trying to get the emicizumab as well as the extended half-life product in EDL list of the Delhi government, but we are not succeeded. But regular replacement therapy, it's really a dream for me. I have done low dose prophylaxis in around 100 patients in last 2 years. Low dose prophylaxis, it is successful. Results are remarkable, but still I have so many patients. I want to, if I have to do this, I need the support of some from the factors from the humanitarian ground.
Sure.
Thank you, sir.
Thank you. Coming to Dr. Ruby from MP.
Sir, in Madhya Pradesh, we had started in year 1920 under blood cell of NHM. Previously, there were 3 societies in Madhya Pradesh.
And later on from NHM, from the support of NHM, we had started 8 hub center, which are, because MP is the biggest state, so we had established a hub center in 8 district hospitals, where we empanel the spokes districts, like all 52 districts and medical colleges where as a spoke they connected to the hub centers, and then we made nodal officers. There were 8 nodal officers. We started training from the MMC सर के नरेश गुप्ता सर के गाइडेंस में हमने उन सबको दिखाया कि what is excellence center which they want to be established there in the state. And after that we did lot of CMEs trainings, even they have taken training in the lab diagnosis. We sent our technicians also. The most important thing which we did in the Madhya Pradesh, we established this lab testing facility and each district hospital. In Madhya Pradesh, in every district hospital, we are having fully automatic coagulation analyzer, so that PT, APTT can be done, or any patient, for even like for pregnant women, like many patients which can be misdiagnosed or could not be diagnosed due to unavailability of the diagnostic facility. Now, many new patients we are diagnosing at the district hospital level only, and we are providing factors. Now we are using for this factor. We have RT of all factors, like recombinant plasma. Recently we did for the imicizumab also, and the process of this EHL is also we are doing the rate contract. Now we are also going for make a treatment guideline for hemophilia. This will be like state policy for us, okay, because we want to establish these daycare center in each district hospital, so that patient could not travel a far distance from their actual place. And also we are going to take the physiotherapists, like physiotherapy assistant at the daycare center only. And continuously we are trying that. Even like in Madhya Pradesh also, we had included all factors, recombinant factor and factors 8, 9 and factor 7 in the EDL. So it is a good step. Like, and also in the future we are trying for this national for the state level registry of these patients, so that we could able to track those patients. So we are moving forward with
Thank you. So Dr. Kendre from Maharashtra, I come from Maharashtra. I would like to hear Dr. Kendre and how the things have changed over 10, 15
Sir,
years.
Maharashtra is a big state. There are around 4,500 diagnosed patient of hemophilia, and 10% are hemophilia B, around 400 patients, and 300 patients are inhibitor patients. All these patients are treated in 9 centers only. This figure is very less, but we have planned to increase this next new 10 centers in the state that will provide these services, 2 district in 1 center, 2 district for 1 center. So we are providing factor 8, factor 9, both plasma derived and recombinant, and factor 7 FIBA. Till today, we have adequate factor in all present centers, and we will provide all the factors 10 centers in planning for the training for the whole physiotherapists in Pune or in Mumbai. We have also included this hemophilia disease in Mahatma Jyotiba Phule insurance scheme. This scheme is conducted in Maharashtra for many diseases, and this hemophilia disease is included in this insurance scheme, so that each family will cover up to 5 lakh rupees, so that the hospital can get the fund for local procurement of this factor in case there is shortage of the funds. We are also issuing the disability certificate for hemophilia, sickle cell, thalassemia. We have some constraint of factors in case of IC bleed, GI bleed, major surgeries, or any accident. Patients are referred from many states to Mumbai, to KM hospital, and there is a shortage, but we will manage through HFI scheme. They are also providing the factors. So that is the constant. Many times, some patient require 100 vials of factor 7 FIBA. One of the patient in Pune in BJ Medical College required 46 lakh rupees for his fracture femur for the FIBA. This news is also published in the newspaper. We are showing to our bureaucrats, our commissioner, that we require this much fund. I have also, now recently we have new commissioner and new secretary. I have given the brief about this disease and the funds required for that.
Sure. Dr. Rahul from Kerala, he has recently joined Kerala program. Kerala is one of the best organized programs, in the country. Can you elaborate from here how you plan to go ahead in Kerala?
Kerala currently has a more decentralized sort of near to home sort of hemophilia care program. So over the last 2 years, the total number of centers has been actually increased around 8 to 9 times. So from the 7 centers, it has reached now 94 centers where the factor availability is there. So starting from the sub-district level taluk hospitals to the medical colleges, we have a facility to provide factors right now. So when we move ahead, actually, we have a more robust primary healthcare setup down the lane. So empowering the basic architecture of our public health system would actually contribute in building the confidence of the PWH group as well in comprehensive care. So that is one aspect. Other than that, we have a robust data capturing mechanism through the Ashadara portal, and an evaluation of this data and the mapping of the patients according to their geographical location, and tailoring the treatment mechanism, either to go for the right now we have the prophylactic management up to 18 years and on-demand therapy after that. And the home-based therapy is very limited, basically going for the additional dose requirement as per the discretion of the treating physician. So this mapping can actually help in addressing the patient concern to a larger extent.
Correct. So thank you, Dr. Rahul. Dr. Viplendu, Bengal is really a populated state, huge number of patients. That is the size of Bengal is quite small. How you have organized yourself?
That's a very interesting. In our state, the program was started from 2007. As a nomenclature, as that time, the nomenclature was the TCU, the Thalassemia Control Unit, and the Thalassemia Control Units are also look over the hemophilia program. That is, at that time, we have the 24 TCU. Just now, we have the 36 TCU, and interestingly, we are worked jointly with the blood banks. So we have the 87 blood banks. So 87 blood banks, we have proposed that the 87 blood bank, also the screening unit. Because for the blood bank, the quality control purpose, the blood bank should require for the quality to detect the quality of the PT, APDT, and the other test is required. So if we are merged with this, so the patient also maybe the screening at the blood center also. Apart from the 36 center, we are use these centers, and we have a very good software recently launched, that is the Thalamos software. And Thalamos software, we have the traceability of the each and every patient. Just now we have the 1700 factor 8 hemophilia persons with hemophilia PWH, and 100 nearly 200 patients for hemophilia B, and others total vulnerable factor 13 deficiency also there, to nearly total 2200 patients are line listed. But this is basically the tip of the iceberg. So we are trying to search out the number of patients, how can we detect, and so we are like to stringent or our protocol for screening with the involvement of the blood banks. Now we are also have a very strong IEC. For last 3 to 4 months, we are using the IEC material. We are using the metro stations. We are there's an audio visual IEC. For not only the metro stations, we are using the radio channels, that the FM radio. We are use that, and that is in Bengali, but that is created by me. and that is already already all the metro station, metro channel, the traffic station. Also, it is published regularly at the interval of the 1 or 2 hours. And now the drugs already is included in our essential drug list. The factor 8 and factor 9 and others, the inhibitors, factor 7 and that is the pegylated factors and the long half-life factors also included in this in our protocol. That is the factor 9 is now recently the factor 9 is totally from the is come from this our state budget, and the factor 8 from our we are getting from the NHM. And we are also tried to we are also implemented the home-based therapy during the COVID time, and we pick up the patient. At that time there no vehicles is available, so that was available. So that's why we arrange a vehicle with with the talk our ministry, and we arrange a vehicle 102. Actually, we are, and the patient was also taken from his home, and and the infusion is given, and after that the also patient is छोड़ के चला आया. So
Okay.
These are, and recently we tried for that the make a line list. Those patients are staying at the remote to remote area. So we have a good primary, secondary, and tertiary healthcare system. So that at the level of the PHC. So if we are able to identify that patient is under this territory, that PHC, so we think about that we can put some medicines that emergency. So if there's any things can happen, so for on-demand therapy, he can he or she can get the medicine from there. And we are also implement just recently we have planned for low dose prophylaxis also, and we are very soon we also started this. So that's for West Bengal.
The question is to the entire panel. Any one of you can answer it. Is in your state, you're encouraging your laboratories to participate in external quality assurance program? If so, which EQUAS program they are participating?
Yeah, not yet, but our the two nodal centers, the one is the NRS Medical College and another is the Kolkata Medical College. They also regularly participate for the other center. We have not just we have the 37 centers.
Sure.
35, not yet.
Sure. What is the scene on inhibitor testing in Bihar, Dr. Gupta? How frequently or how many centers are doing inhibitor labs in Bihar?
Now it is not available in Bihar, but
Okay.
we are trying at AIMS Patna.
AIMS Patna, okay. And do you have any specific could not Bihar, West Bengal, and after I'll ask Dr. Vishnu because that is a center, and I'm very proud to say and very encouraged to say that very major surgeries have happened under his supervision and guidance in Rajasthan. Can you brief in, say, a minute, how you organize your surgical teams in government setup?
See, sir, basically surgery requires multidisciplinary approach. We need to incorporate surgeon, anesthetist. Laboratory importance is also there. We have to send inhibitor screen, factor recovery levels. Hematologist is a key for the successful implementation of surgery. So we need to include all the people's. Blood bank is also very important part because these patients also requires or may require transfusion. So it is sometimes it is difficult to the organize the things in a limited time period, available time. But we have done major surgeries including hip replacement, knee replacement surgery, multiple minor surgeries we have done. So it is possible if you have will.
Correct.
So one thing I would like to add, sir, regarding everybody is talking about availability of PT and APTT. So PT and APTT can be done at PHC also. Manual PT and APTT can be done at PHC because it requires only PT reagent, calcium chloride, water bath, and stopwatch. So it can be done at PHC. You can do PT, you can do APTT at PHC also. And you can do mixing studies if you have normal pooled plasma.
Actually, very important point Dr. Vishnu has said, Dr. Jaswin is sitting here. People are talking of automated machines. It's a convenience. Any new company introduces a coagulometer. Those new coagulometers are calibrated against 3 very senior technicians appointed by ISTH, and they calibrate the machine. So actually, the gold standard even today is manual PT, APTT. It should not be demeaned. A lot of people say we are not having coagulometer, we can't do automated PT, APTT factor assay. It's not mandatory. If you adjust yourself, it can be very well done. It's a very important point, and Rajasthan has been an example. Absolutely.
Assay. So at least we can do inhibitor so mixing studies.
Correct. Coming to MP, what do you think, Dr. Ruby is here? If you have to ask for one wish, what will you ask for your officers and advisors?
Patient for the prophylaxis of for the all hemophilic patients, those who are already registered, they must go on prophylaxis.
Okay. Now we have, that's my next question. During COVID days, the home therapy was allowed at majority of the places. When COVID is over, why home therapy is not available in non-COVID days? Anyone from the panel?
A resource. So we are not very much resourceful country. So and there is a chances of the wastage also. So that's why the home therapy is discontinued. But I think first awareness. If we are aware the patient properly, then we can implement this very cautiously. First, awareness is the first thing.
Absolutely. But let me tell you my personal experience, because we have been doing home therapy for quite a long time, though we are not in a government system. And in fact, patient and patient's parents are more careful about wastage of factor. And home therapy, if it is on prophylactic basis, it's a fixed dose. So our experience is slightly different. The wastage at home therapy is not real. People were worried. Let me tell you where my worry is. How the product is stored. What kind of storage facility they have. Will the factor work? Will there be anaphylactic reaction? If anaphylaxis happens, who is responsible? These are the issues in my mind. But with these issues, if we are going to go for prophylaxis, ideal way will have to be home therapy, education, awareness. Dr. Rahul, Kerala, I know that some outcome analysis was done, because I have not seen any of you in the panel routinely collecting the outcome data, say simple parameters like annualized bleed rate after factor was started. Can anybody have that data in the panel to show that we did this? ABR was 20 before we started giving water factor. Now the ABR has dropped down to 5. The days missed at school were something like 60. They have dropped down to 15. Is any state collecting that kind of data, Dr. Rahul? What about Kerala? Because I remember we had a meeting in Kerala a couple of years back. I was part of that. And there was a discussion to collect this kind of a simple outcome data.
Yeah, we do have the data available actually, but I haven't worked on that.
Sure. Now, I'm not asking you what exactly the data is, because now 10, 15 years have happened. We have been harping around on factor replacement, factor support. It is very crucial now to create some kind of a database on very simple parameters where nothing high technology is required. Because if somebody asks you what we have achieved, this data is going to speak. So anyone, Dr. Sunita? Can you speak in the mic?
Sir, it is working. gave a post thesis to my postgraduates for the low dose prophylaxis on factor 8 and the low dose prophylaxis for the factor 9. We have recruited at that thesis 15 patients. Now it is more than 1.5 hours. Now that we have increased the patient. In these patients, we are collecting the annual bleed rate at the end of the thesis. It was initially 12 to 18 per year in my patients, but now it decreased to 3 to 4 per year with just low dose prophylaxis. That's the 10 unit per kg weekly in hemophilia B, 10 unit per kg twice weekly in hemophilia B. And under the patient care support, I have given emicizumab to five patients. And I would say that it was a wonder. One of the patient father came to me and Dr. Naresh Gupta, sir, there is some problem in my family. We asked what happened. We would think there will be some problem regarding the drug and this. Ki, sir, he doesn't follow our rules. He just forgotten that I have hemophilia. He is playing cricket. He is playing football. So this is the annual bleed rate with that just zero in that 6 months. When the patient were getting, 5 patients were getting the emicizumab for that, sir. This is the...
Sure. Specific policy, plasma derived, so much of recombinant, so much of EHL, so much of emicizumab. Anybody has any written policy? Somebody? No policy?
We are planning, actually we are planning and
Okay, okay, okay.
we are planning for that with reference to the and age of the patient, so that we are planning for
Correct.
that kind of that.
No, because the issue, procurement alone is not important. The distribution is also important. Because patients should not be traveling beyond 1 to 2 hours maximum. In the the policies, who gets emicizumab if you have sanctioned emicizumab in your states?
For patients with inhibitors, hemophilia A with inhibitors, only for patients with inhibitors.
Okay.
So but it is up to us to decide whom to give.
Okay.
So we are giving for inhibitor patients.
Anybody has approved emicizumab without inhibitors?
Sir, we have not.
So it is approved for without.
No, anybody in the states, are you giving emicizumab for hemophilics without inhibitors?
Yeah, in our state, in the medical college, there is a trial. There was the trial going on.
No, trial is a different thing. I'm talking in the state system. I'm talking in the state system. See, trial is a different thing. It's a different thing. The monitoring, everything becomes very strict.
Till date, there is no demand from treatment. That's why we cannot proceed.
Because data shows that in the Western world, 70% of the patients of hemophilia A without inhibitors have switched over to emicizumab. And that is a fact. The data has been published in global survey. Nearly 70% patients. 70% is a huge number, where it's once in a month subcutaneous. Another drug comes, it will be once in 2 months dosage. So 12 injections a year. No, the question of venous access. So many things become easier. So with that, I would stop here, but I'll give 15 seconds to each panelist. If one area you have to harp, which area you will harp in Rajasthan?
Sir, I want extended half-life factors for everyone. So
Fantastic.
basically, it has changed the treatment paradigm of hemophilia B especially.
Absolutely, agreed. Sir?
Training of all nodal officer, standard treatment of hemophilia to them, so that there should be uniformity in all states.
Thank you. Dr.
First, the IC is the most important thing. So information, education, and the communication. If information, education, and communication, the most of the patients are undetected. So detection and patients should come forward, and not only the factor therapy is not beneficial for the patient. The comprehensive therapy for each and every one, the physiotherapy and the other modality of treatments that can imbibe the patient. That is very important for each and every one.
Sir, my my dream is regular replacement therapy, either with standard or extended half-life or the non-factor therapy, along with the home therapy, with awareness to the families as well as the community regarding this rare disease.
Thank you. Dr. Ruby?
Want to create a comprehensive state policy for operational and management of the hemophilia, which include all spectrum of the treatment like prophylaxis, this emicizumab and EHL, so that we can strategically do the things.
Dr. Kendre?
Right now, the state blood cell have launched the National Sickle Cell Mission and generate a national portal. So, like this portal, we have to establish the portal for hemophilia also, so that we can identify exact number of patients, how many times they are bleed, and we can enter the factor given, factor consumption, ABR, all should be included in that portal.
Dr. Rahul?
Focus would be definitely on empowering the healthcare workers in the public health system down the lane from the primary level to the tertiary level, and also involving the patient advocacy groups and patients into the decision making mechanism, and thereby building the confidence, and program will be more oriented on improving the quality of life of the patient-centered programs.
Thank you. So it just showed how diverse can be one wish. At 10 years down the line with various state governments, so there is no uniformity in our needs. We can have maximum 3 questions. There is one question here from the audience. Please ask questions to the panelists. Anybody? Be quick, be very quick, short question.
See, sir, Maharashtra, 4,500 patients, approx 42 crores budgets is coming. Ruby Khan, madam, see, MP is the bigger state than Maharashtra. Budget is 12 crores. Patients are approx 1,000. Where are other patients? I don't know how this variability is there. Just comparing 2 states, Maharashtra and Madhya Pradesh, I think there should be a similarity regarding identify outreach like this or treatment like this. But why so difference is in between? So patients are many times are asking us, see 54, this
Bashiram, be very
MP.
specific in the question. Don't, we are running short of time. Please be very brief.
So just comparison between these 2 states. Yeah. Regarding treatment protocol.
So in Madhya Pradesh, we started like all the things from 1920. Like it's only 3 years where तो patient का भी awareness होते होते कि patient were not previously informed, they were not aware about that MP has started. Otherwise, only the societies were giving the factors. Now the government is also supplying. So the awareness अभी लोअर लेवल पे, विलेज लेवल पे या जहाँ पे पेशेंट है उनके पास इंफॉर्मेशन पहुंचे. कई बार ऐसा होता है कि मैं खुद पेशेंट को मुझे ही बताना पड़ता है. लाइक आई यूज्ड टू टॉक इन बिटवीन, लाइक हम कई बार डायरेक्ट पेशेंट से कांटेक्ट करते हैं जिसमें हम उनको बताते हैं कि नहीं आप डिस्ट्रिक्ट हॉस्पिटल जाइए. दे आर लाइक डिस्ट्रिक्ट हॉस्पिटल में फैक्टर अवेलेबल है बट दे आर गोइंग टू महाराष्ट्र. सो समटाइम्स दिस इज द लाइक लैकुना देयर समटाइम्स अबाउट द अवेयरनेस. मतलब पेशेंट को पता ही नहीं है. तो इसकी वजह से एंड महाराष्ट्र इज लाइक उनके पास बहुत पहले से पेशेंट रजिस्टर्ड हैं, तो वो डिफरेंस इसीलिए आ रहा है. बट आई थिंक वेरी सून व्हेन दिस काइंड ऑफ रजिस्ट्री विल स्टार्ट, सो वी कुड एबल टू डू दैट एंड बेटर.
Thank you, Dr. Ruby. There is another question from Delhi. What are the policies for inhibitor patients in Delhi state? To Dr. Sunita.
Sir, in the inhibitor patients, whenever patients of inhibitor comes, we give either factor 7 and factor 2 and the FIBA. It is whenever the patient, basically we are following the on-demand therapy. Whenever demand arises, we give this therapy.
Thank you. Yeah, last one. Anju?
Yep. Thank you all the panelists. Only one question. Everybody talked about the treatment part. Is there anything in pipeline for the prevention, carrier detection, or any policy being framed and formed for the benefit of the patients and their families by the state government, even MP as well as Maharashtra?
Anybody? Any state having policies on carrier detection? Anyone?
We are just like We are planning, definitely it takes, we are going, like, we are establishing this prenatal diagnosis centers in some of the medical college or the ICMR institute where could able to do these kind of testing. So it is there in the, and there's in the pipeline to, in the guideline also, to incorporate this in the guideline. But right now we are not having that kind of facility, but definitely it will be included.
Last comment by Dr. Kendre.
We have planned at Nagpur Daga Hospital, but there is some problem so that we cannot do the serious sample collection. We require some expertise in Nagpur. We have planned, but it is in primary phase.
Thank you all. Thank you all the panelists. We are fairly stuck to the time. We have crossed 4 minutes. We have overshot 4 minutes. But again, thankful for all these. They are busy people. With them, we have been benefited. The community has been benefited. And I think they deserve a great applause from the community. Thank you all. Thank you. One second.
Dear guests, good evening to all of you. And I just have a small information to tell you that our MC, Dr. Anupma, she has left for the day. She had a flight to catch back home. So now I would be taking forward this agenda. And since I am not a specialized person, so you may excuse me. So, but I will take forward this agenda from here. So it is my privileged honor to request our panelists to receive a token of our love and gratitude from Dr. Shashi Apte, our very own. Now I request our President HFI, Mr. Prem Roop, to please felicitate Dr. Rahul. Yeah. May I now please request Dr. Sunita Agrawal to receive a token of gratitude from Dr. Shashi Apte. I once again request HFI President to kindly facilitate Dr. Sunita Agarwal. You give him? Yeah. Thank you, Dr. Apte, for your wonderful support, as always. And I thank all our panelists for their very educative talk and sharing their experiences and insights on hemophilia situation in their respective states. Thank you, sir. Now, moving forward with the agenda, I would like to request Dr. Nida Radhakrishnan to please come on the stage and deliver her talk on long-term prophylaxis experiences, a real-world experience.
आपका कौन सा एडेप्टर है वो दे दो एडेप्टर somebody has to help me with the projector. I have both. You can just show me what you have. So it's okay. We'll do it from here. That's okay. Okay. So good evening, everybody. So I know we are really behind schedule. I would thank the organizers for this opportunity. I've been asked to speak on prophylaxis and a little bit on experience of using EHLs. I think everyone's late, so I'll really rush through my slides. Okay, so I work in this center in Noida. It's a pediatric center. So predominantly we take care of children, and probably around 15 to 20% of our patients are adults because there is no other provision in the district. So we give factors for adult patients as well. These are the numbers of patients that we treat. I think there's some issue in the projection, so the aspect has changed. So, as you know, children usually present with all these kind of bleedings. A lot of bleeds in the initial few years can be actually reduced if you counsel the families well. But later, of course, there would be multiple joint issues, and these are things which we can prevent if we take care of treatment correctly. So if we take care of preventing bleeds, that actually helps a lot in preventing many of these joint bleeds as well as severe bleeds like intracranial bleeds. So so these are the types of bleeding. So in India currently, most centers you would have heard now would have been treating episodic treatment, but episodic treatment is not actually part of any treatment protocol anywhere in the world. Most centers in the West have moved towards what's called prophylaxis or replacement therapy. So to those officials who are here, who are involved in tendering products for their state, I think it's a time we should consider changing towards prophylaxis for all your patients and just keep some reserve episodic treatment for breakthrough bleeds at all. So that would be the ideal way of managing. So in the beginning, our goal of hemophilia management used to be like when it was probably Mr. Verma's time, it was saving lives basically. At that time, people did not know about diseases or patients were not being diagnosed. And the whole emphasis was to get them to be alive. They should not die of any major bleeds. But now from there, we have moved on to saving patients from disability. And now it's not just disability that matters, it's the quality of life that matters ultimately. They should go to school normally, they should work, have a family life like any other person would have. And that's probably why prevention of bleeds is the theme for this year as well. So joint bleeds is the most important aspect that impairs the quality of life for any patient. So when you start off being a hemophilic, in the first few years, it's actually a little easier to manage. It's just that the parent should be aware of that. The child should not fall down and nobody should really pull the elbow and things like that. But once the joint bleed sets in, although you have access, suppose you're staying in a center which is like 1 kilometer away from your, in a home which is like 1 kilometer away from your treatment center, even then, you're treating after a bleed has happened eventually results in disability. And that's what we are looking at currently as to why do you want even that to happen. So like in many other disorders like diabetes or thyroid, hypothyroidism, thalassemia, for example, we are not waiting for the hemoglobin to drop and child to go in cardiac failure and then give blood. We are giving blood such that the growth remains normal. So that should be the dictum for hemophilia as well. And if you treat properly, the benefits would be that we have very little joint bleeds. It will not become zero. It will come down. Say from 20 bleeds, it will come down to 4 bleeds in a year. That is great. And that will result in less arthropathy, fewer muscle bleeds, reduced chance of major bleeds like intracranial bleeds, fewer hospital admissions, less frequent monitoring required, less time off work, and eventually it will all go to a better quality of life. So we all know how prophylaxis is given, but the main one which is important for improving joint outcomes is primary prophylaxis. So primary prophylaxis has to reduce the joint morbidity. Whatever we are giving after the joint morbidity has set in is actually not going to improve significantly, but still in our experience, even those tertiary prophylaxis ones have also improved while on good products like EHF. So in our country, this is the annual global data by WFH every year. So this is the 21 data, which shows that just under 9%, under 18 years of age, only 9% of patients are on prophylaxis in our country. And over 18 years, it's only 4% of patients. So it's like less than 10% of patients all over the country are on prophylaxis, which is something which is actually we should be ashamed of, because if we are actually planning a program and if we are actually tendering for drugs and getting it, it's just a question of increasing it by probably 20% or so, and that will give you a good prophylaxis cover for majority of your patients. At least pediatric patients should be under that. There are multiple ways of giving prophylaxis. I think this is all standard guidelines, but there is no evidence that one is good over the other. There is a lot of centers who are practicing low dose prophylaxis in our country. See, what dose we use is to determine by what you want to do, what the patient wants to do. If the patient wants to have a very active life and run around and do a lot of sports activities, that low dose will not help. Low dose will help you to go to school, come back from school, and not have any spontaneous bleeds as such. Once in a while, you still would have, but spontaneous joint bleeds will be reduced while on low dose prophylaxis. But for any other active lifestyle, you need to be on a higher dose regimen. Also, while on low dose, you can still have subclinical bleeds, and that's why, and so you still can have joint damage which can set in. So this is one of the earliest papers which showed prophylaxis versus episodic, and I think this is again something which need not be discussed, because we all know that the joint outcome is significantly better, quality of life is significantly better if you are on a prophylactic regimen. So currently, world over, standard of care would be to give prophylactic factor replacement either as SHL or an EHL. Most centers in the West would now, most patients would prefer on an EHL, not just from a sustained trough level, as in a trough level which is good, around above 5% for a good period of time, not just because of that, also because of reduced injections, reduced hospital visits, etc. And today morning, Dr. Ross discussed what was normal for a hemophilia. I think we should all aim for what is the healthiest thing possible which we can offer to our patients. So while we put them on prophylaxis also, still we have issues which come up, which includes compliance issues, home therapy related issues. So many a times, even if we teach them, it may not be, the parent may not be confident. So the person who will actually administer may not be the person or his family member. It might be a nurse nearby or a technician nearby who knows how to give an IV access. So that is still okay. But we need to factor in these aspects before we advise prophylaxis. We'll still have breakthrough bleeds, so they should be told to come for on-demand treatment. Subclinical bleeds may still be there. IV access is required. So if we're starting for small chubby babies, that must again and something which we need to consider. And finally, definitely, there will some patients will develop inhibitors with or without prophylaxis. They will require additional treatment. So this is our experience. So we have around very few patients. So out of the total around, I think 600 odd hemophilia patients, it will be around 11 of them are on primary prophylaxis. We have few patients on secondary and tertiary through World Federation support. So World Federation supports patients as in we have received support since the last 2 to 3 years, and that we are using primarily for patients who have joint issues for their secondary or tertiary prophylaxis. We have patients, we have 43 patients on emicizumab now, 42 are inhibitor positive patients, and one is an inhibitor naive patient who is staying far away from home. So he is chosen to, he's getting products through his father's employer insurance, and that again, that is the 43rd patient. And of all these prophylaxis, it is SHL for 25 and EHL would be 26. So although for the rest of the 550 odd patients, I would still want primary prophylaxis. That is not being currently provided by the state, and we are using whatever we have for joint rehabilitation, CNS bleed, support during examinations, etc. But what has been the learning curve over the last few years has been that when you engage families in their own health, that improves outcome significantly. Rather than giving prescriptions, if you tell them that this is what is happening and we want you to reach here, that really helps. So getting them to participate in their own health, getting them to understand what is HHS or quality of life scoring. We use PDHAL scoring a lot. So that also helps them to, if they see a number and they know what to target ahead. Home therapy, self-infusions definitely help. They have to understand that factors are just a part of the treatment. It is not the entire treatment. The entire treatment would be a very good rehabilitative program. The fact that they have to come to the hospital in between regularly whenever they are being called for and not just for a bleed, this has to be understood by the family from the beginning. And we saw a lot of heroes being talked about by every speaker, celebrating whoever has done well in life actually gives you to cherish for the other family. So this is something we've been following. Every month on a second Saturday, we do what is called the Living and Winning program. It's called GO or GITO. So that means that you're actually showing families the way forward or anticipatory guidance, which will help them, which will help small families deal with problems. For a 1-year-old, a family with a 1-year-old would know what to expect when the baby is 3 years or 5 years, that kind of thing. And over the years, we have had even better drugs also that has helped us do it. So these are how self-infusion is taught. And measuring outcome is a very, very important part of this. So as part of our regular patient registers, we have HHS, we have HAL, as in PED-HAL, and we have quality of life scores that have been implemented in our regular routine work. So this is a small video. I think when I was asked to speak on prophylaxis, I think finally, can the audio be on? So this is compiled by Manju Singh, our counselor. So I think the final ultimate outcome of prophylaxis would be that they live like any other child. So if you have a joint that helps you dance like any other child of that age group, that is probably the biggest advantage that we can have. No? So most of these children are on prophylaxis, either EHL or emicizumab, or some of them on SHL prophylaxis also. So it's just a small thing which we compiled over the weekend. And whenever you do a program, that really helps. So there is a significant advance. So from episodic treatment, moving towards prophylaxis with EHL, and moving towards non-factor replacement has been a big change in the last 1.5 to 2 years that we have seen. I think gaps between treatment in the West and the East are very, very narrow right now, and at least in many centers, and outcome data is crucial for that. I'll take 5-10 more minutes just to discuss my next part. I would have been asked to speak on experience on EHL also. So since we are running late, I'll just finish off that as well here. So one of the good things that happened in this prophylaxis bid was that we had new treatment options now. So one of those treatment options is extended half-life products, and another one is non-factor replacement. So non-factor we discussed earlier, and through trials we have some other non-factors also available with them, and that has actually changed in terms of giving injections subcutaneously once a month is like a big advantage for most of the families that we treat, and especially children with inhibitors and very high ABR rates. Now coming to extended half-life. So extended half-life is like extending the half-life of your current standard half-life product. What is the advantage of that? If the product stays inside the intravascular system for a longer period of time, you have a better or a higher trough level for a longer period of time. So if you have a higher trough level, what is the advantage? The advantage is that you can do, for me, the advantage is that they can safely do physiotherapy without the risk of a breakthrough bleed. They can safely go and do activities without the risk of a breakthrough bleeding. So these are two things which gives them confidence. So earlier when patients used to come in, they used to tell that, madam, hum physiotherapy nahi karenge, exercise karne se bleed hota hai. First of all, you have to take out that you have to disengage physiotherapy and exercise as two big things from out of their minds. You have to tell them that this is something that you will do for the rest of your life. Every new hemophilia patient who comes in is told that half an hour of movement, passive movements of all joints have to be done for the rest of your life. So when you tell it that categorically, that somehow sinks in. So maybe it doesn't happen in the first time, but slowly over time. So even if for a child who has never had a joint bleed, we still engage the mother, ask the mother to keep the child on her lap while watching TV or playing with the child, move all joints. So that part has to be understood by the mother. So now when you are talking about a slightly older child who has had bleeds and is coming to you, there will be some wasting of the proximal muscles, or there will be pain while moving. Even if there's no acute bleed, there still can be swelling. So for them to accept physiotherapy is a big deal. So whenever you tell them also, you start off with isometric exercises and slowly build it up. But in that context, whenever it is nice to have factor support while you're doing it, because they can be also confident when you're doing it. Now, in that context, when you have a drug which gives you a higher trough level and gives you a longer period of action, that actually gives the family confidence to do it. So that has been the experience in managing patients with EHL. So your dose actually comes down, so they don't have to come to the hospital, or they don't have to get pricks regularly, one. And two, even if you're dosing intermittently only, so like factor 9 EHL you're giving once in 2 weeks, and factor 8 probably once in a week, or maybe twice in a week. But that the reduction in the number of injections is actually a big deal for the family. So this is how EHL is defined. These are all standard publications. I won't go into it. The advantage is more in 9 EHL than 8 currently, because 8 is metabolized inside the body. You need von Willebrand factor. 8 is carried by VWF. But now there are newer products where there is recombinant VWF also that is supposed to increase. That's just been, I think, approved now couple of months back, and that is again going to increase the factor 8 EHL THA half-life also will increase significantly. So now these are the methods of using it. You have pegylation, FC fusion, and albumin fusion, and these are the multiple advantages. So this part, the science part of it, I'm not coming into it because it's all well recognized, and we know that these are products which are available in our country. Now, what has been our experience? So we have experience of EHL initially through the World Federation products, which used to come to us, which still come to us. So they give EHL primarily for surgery and for prophylaxis and for board exam prophylaxis. So this has been our initial experience, where we used it for a few patients. With just a small numbers of patients we used it, and we used it at a dose which is actually much lesser than what they had recommended. So because we were rationing it between multiple patients, we saw that even if we're using at a lower dose, we still are getting benefit. So we are currently using it at a dose of around 20 IU per kilo, and that too once in 2 weeks. So it is 7 patients initially, and these are all patients who are very, very bad joints. Like you can see the ABRs. Out of the 7, we have data for 5, which showed very high ABRs. The blue ones are ABRs pre-EHL prophylaxis. And you look at the orange one, orange is absent in 4 because there is no bleed after that. So all of them achieved, out of 5, 4 of them had 0 bleeds, and only 1 child had a ABR which you couldn't even calculate. When you do HHS also, there is improvement in the HHS scores which was seen. I think I've shown the slides earlier. I'm not sure if you have seen this, but this is a child during COVID. He had quadriceps palsy. He had multiple psoas bleeds, and following that he had femoral neuropathy, and he was not able to walk, and he was wheelchair bound during COVID. And subsequently he was started on prophylaxis, which was available through World Federation only. So I'm not sure the video is not moving. So this is basically now he's doing well. He's in Pune now. Actually, he's doing in symbiosis. From symbiosis, he's doing BBA. How do you go forward? Yeah. So these are the doses which we have used. Even the number of hospital visits come down. Your bleed becomes 0, 1. 2, your hospital visits come down. 3, even the vial consumption. If you look at the IU per consumed per month, it's not very clear here. So if you're on standard half-life, you're consuming close to 6,000 IU per month. Once you switch to EHL, it actually comes down to 1,000 or 2,000 IU. So even from a cost economic thing, it makes sense. Similarly, contractures with wasting, if you see after even 3 months or so, you can see complete recovery of the target joint can be seen. Similarly, we have used in 2022 and 23, we have used through the World Federation support, we have used it for a board exam prophylaxis. And again, thankfully, last year as well as this year, all the children who are on this were able to complete their exams. I'm skipping the slides on the science part of it and just sharing experience. Long-acting factor 8 was also available, and this long-acting factor 8 we have used in 28 children till now. And basically for tertiary prophylaxis or pseudotumor dental extraction, or family living like 200-300 kilometers away, we have used it when they are in a difficult area to access. So this is one pseudotumor you can see. This is in May, and by the time you are on November, the girth is reduced significantly and the movements have improved. So to conclude, the biggest advantage of an EHL product is that it gives you continuous and improved adherence or compliance to continued physiotherapy, better joint scores, there is reversal of target joints, and this essentially all boils down to better compliance of the family. So this is my team. I thank the National Health Mission as well as the World Federation for supporting us, and I'll be happy to take any questions.
Dear ma'am, thank you so much for presenting and broadening our understanding on long-term prophylaxis. I request one of our EC member, Mr. Santosh Jaiswal, to kindly facilitate madam with a token of our gratitude. Thank you, ma'am. Thank you, Santoshji. Now, moving ahead, I now request Dr. Vikram, consultant hematologist, NHM Telangana, Government of Karnataka. Is he here, sir? Yeah. Please, he will be delivering his talk on advantages of newer treatment therapies. Sir, all you.
Good evening. Thank you, HFI, for the opportunity. I think mine will be the summary presentation of what happened from afternoon. So I was asked to talk about advantages of novel therapies. It's not moving. So hemophilia, severe hemophilia, the characteristic bleeding is the joint hemorrhage, which happens spontaneously and which happens recurrently, which will lead to the chronic inflammation, cartilage damage, and eventually there will be restriction in the range of movement, and that will lead to the disability. So this disability will affect his career, school absenteeism, school dropouts, and career unemployment, and also a lot of psychological issues. And most of the times these implications are not only on the patients but on entire family. So what is the solution? So solution is replacing the factor. So previously we used to have we started with whole blood, FFP, cryo, and what changed the management of hemophilia is the availability of clotting factors, both plasma derived and recombinant. So these clotting factors, when we administered on a regular basis, what you call it as a prophylaxis, that will do the decrease in the rate of annual bleeding, not only joint bleeding, other bleeding is also decreased, and also because of that, the quality of life is improved. The child can participate in all social activities, child can have a more active lifestyle. So that will improve his overall quality of life. So that is the reason prophylaxis has been made as a standard of care. So as the previous Dr. Nita ma'am was saying, that in spite of being a standard of care, only less than 10% of our patients are on prophylaxis. Access to the clotting factor concentrate is one reason, but there are also certain other challenges because of which we were not able to implement prophylaxis on a larger basis. So first is high infusion frequency. Because of shorter half-life of factors, either factor 8 or factor 9, you need to administer 2 to 3 times a week. So factor 8, you need to give minimum 3 times a week. Factor 9, you need to give minimum 2 times a week. So because of that, for that matter, any drug which has a higher frequency, the compliance will be low. The child may not come, the family may not come to the hospital setting for the repeated administration. And also to give repeated IV injections, especially in a toddlers and young children, it will be very difficult because of poor venous access. And second second challenge, rather I say, is the intravenous administration. All the standard of life clotting factors right now licensed are to be IV, to be used as the intravenous route. So as I said, for some patients, it will be difficult to get the IV access, and for some patients, because of repeated venipuncture, you may get the vein damage and phlebitis. And third challenge with the present treatment is that you administer factor every for 48 hours or every 3 times a week. Suppose assume you administered a factor. So there will be on day 0 you have administered factor, there will be a peak level, and slowly the factor level will come down and it will reach to less than 1% before the next dose. So there will be peak when you give on the day of factor administration, and there will be a trough less than 1% just before the day of next infusion. So assume a child who has a very active lifestyle, who is more physically active, will not sustain any bleed on the day of infusion, but will be at the risk of bleeding when before the next dose, because his factor levels have come down to less than 1%. So because of these peaks and troughs, those study level drug concentrations are not maintained. So because of that, prophylaxis may not achieve that zero bleeding for all patients, especially those with active lifestyle or more physically active. And one more challenge will be the inhibitor formation. So for any patient who has been who is deficient in particular protein, when exposed to that protein exogenously, his body will think that exogenous protein as a foreign and start mounting response. These response is nothing but antibodies, and this is what we call it as inhibitors. So inhibitors generally 20 to 30% of severe hemophilia patients will have these inhibitors. So what happens with these inhibitors is this will neutralize the exogenous factor, whatever we give. So because of that, control of bleeding in these patients will be a difficult thing. And to control the bleeding, you need to give the bypassing agents, which are costly and which have a shorter life. So you need to give multiple doses. And also the frequency of bleeding in these patients will be high. So because of that, the morbidity, quality of life is quite bad in inhibitor patients. So overall, the 4 challenges we have with the present treatment. One is intravenous administration, high frequency of infusion, inhibitors, and steady state. We don't have a steady state hemostasis. We have peaks and troughs. Now let's see some novel therapies. I'll be talking about those therapies which are presently available to the patients and not those in the trials. Extended half-life, there are newer therapies are extended half-life, non-factor therapies, and gene therapy. So extended half-life, here what we are doing is, to the normal recombinant factor, you are attaching a protein which has a longer half-life, suppose like albumin, or you're attaching certain molecules so that the molecular weight is increased and it is not easily cleared from the body. So because of these reasons, the half-life is prolonged. So EHL has more half-life compared to SHL. So this factor 8, if you see, the routine SHL half-life is 8 to 12 hours, and you have to administer 3 times a week. And the same with EHL will be around 18 to 20 hours, and you can administer 4 times, once in every 4 days as per the drug product information sheet, but it can be given once in a week also. And for factor 9, there is almost a 5-fold increase in the half-life with the EHL, and as per the product insert sheet, you can give once in a week, but real life experiences show that it can be given up to once in every 10 to 14 days. So because of this decreased frequency of administration, so the advantage is, one is the decreased frequency of administration, and also because of longer half-life, the trough levels are maintained more than 1% for longer time. So because of that, the bleeding risk will be low, and subsequently the quality of life is also improved. So the 4 challenges whatever we had, one, the reduced infusion frequency we can achieve with EHL, and also steady state hemostasis to certain extent we achieve with the EHL. But again, it has to be administered with the intravenous route, and also it has a similar effect to the SHL on the inhibitor formation. There is one EHL of factor 8 which is in trials for the subcutaneous route, which is not currently in the market. So now next we will go to the non-factor therapy. So all these days we were manufacturing factor 8, which is structurally and functionally similar to the endogenous factor 8. So what new we are trying is, we are preparing a molecule which is functionally similar to factor VIII, but not structurally similar to factor VIII. Why, what makes, so how does it make a difference? So when the molecules which are only functionally similar and not structurally similar, so the inhibitor risk will be low. So inhibitors formation, yeah, or if the already inhibitors are formed, the level will not increase if the structure is different. So one of the only approved product and presently available in the market is the emicizumab. It's a monoclonal antibody which is humanized on with two ends. With one end it will attach to factor 9, and with the other end it will attach to factor N, and subsequently it will activate the coagulation cascade. So as I said, it has a no structural similarity, so it will not either increase or increase the already existing inhibitor levels. So major advantages, it is has to be given once a week for 4 weeks, and subsequently you can give once a week or once in every 2 weeks or once in every month. And one more advantage is the route of administration. It is subcutaneous route of administration. And also important things to remember, it works only for the hemophilia patient as a prophylaxis, and useful both in inhibitor non-inhibitor patients. All these days we were talking about annualized bleeding rate, whether it has decreased compared to previous or not. Now on emicizumab, the trials have shown more than 2/3 of patients being zero bleeding rate. And also in case of you have a breakthrough bleeding, you have to administer the bypassing agents. So coming to our 4 challenges with the prophylaxis: reduced infusion frequency. Yes, it can be given once in a month, or once a week, or once in every 2 weeks. It has a steady state hemostasis. Yes. And it is subcutaneous route of administration, so again that's an advantage. And also it has no effect on inhibitors. And one more important advantage with the emicizumab is lot of minor surgeries, especially dental related or arthroscopy procedures, contracture release, all these can be done without extra factor support. But one disadvantage will be it will interfere with your all lab investigations related to the hemophilia patient. Factor APT, PT, APTT, APTT, factor assays, inhibitor assays, all this will be affected by the emicizumab. So whenever the patient is on emicizumab, the lab should be informed that the child is on emicizumab, so that proper reagents can be used. So other drugs which are still under clinical trials, so how the basic mechanism is, we have 3 pillars of hemostasis. Factor pathway inhibitor. Both advantages, both the drugs work for both hemophilia A and B patients, and both inhibitor non-inhibitor patient, and the both can be given subcutaneous, and the frequency administration is also once in every week. So conclusions: previously our primary objective used to be the decreasing the annualized bleeding rate. Now the primary objective has moved from the decreasing annual frequency to the decreased bleed frequency to the zero bleeding. So in achieving that zero bleeding, probably novel therapies will be useful. EHL definitely has a decreased frequency of infusion and improved quality of life. And emicizumab is the first and only non-factor therapy approved because of its advantages on no effect on inhibitors, subcutaneous mode of administration. All this will make emicizumab probably the future of hemophilia. And there are other drugs which are still under pipeline, which all belongs to non-factor therapy, will improve the care of hemophilia in future. Thank you.
Thank you, Dr. Vikram, for enlightening us through your talk on newer treatment therapies. Now, may I again request Santosh Jaiswalji to kindly felicitate with him with a token of love and gratitude. Moving forward, I request Professor Jasmina Eluwalia from the Department of Hematology, PGI, MER Chandigarh, to deliver her talk on laboratory workup in bleeding disorders. Ma'am, welcome.
Good evening, everyone. I see a thinning audience, but that's all right. I can imagine that we've all been saturated with the information regarding hemophilia. Greetings from PGI Chandigarh for this World Hemophilia Day today. And for the next 15 minutes, I'll be speaking on the laboratory diagnosis of hemophilia. So may I have my slides, please? Thank you. Is this working? Can you just move the slides, please? Yeah. So there is a big need for laboratory diagnosis of hemophilia, and this is because bleeding disorders are a spectrum of quantitative or qualitative defects in factors and coagulation factors and platelets. So there can be a problem in any coagulation factor or in the platelet, and the manifestation may be the same. The coagulation factor defects include the common ones like hemophilia A, B, and von Willebrand disease, and the rarer ones like fibrinogen, factor 2, 5, 7, 10, 13, and fibrinolytic pathway factor deficiencies. The platelet disorders include the common thrombocytopenias, which may be either acquired or even congenital platelet function disorders like Glanzmann's thrombasthenia. Next, please. So the lab has a very important role to play because we need to diagnose the bleeding disorder very carefully so that correct therapy can be initiated. And in some disorders like von Willebrand disease, after making the primary diagnosis, we need to subcategorize it because one treatment doesn't work for every type of von Willebrand disease. Then once the diagnosis is made, we need to monitor therapy. And while the patient is on therapy, if he develops any complications, we need to diagnose that in the laboratory. This is especially true for inhibitors, which we see in hemophilia. Next, please. So anybody who's going to run a coagulation lab for the diagnosis of the bleeding disorders will need to keep this basic screen available with them. This is the prothrombin time, the APTT or the activated partial thromboplastin time, the fibrinogen assay, platelet count, thrombin time, and bleeding time. Out of these, the first four, according to me, are mandatory and should be available everywhere if you don't want to miss a very significant bleeding disorder. The other two we may use as and when required. Next, please. So let me go through this talk today with the help of a case. We have a 5-year-old male child who's presented with bluish patches on the arms and legs on minor trauma. He has had joint swellings in the right knee since 2 years of age. There's been no history of transfusions. He has 2 siblings, one older male who's normal and a sister who is also normal. The pediatrician thinks that it is hemophilia. So he sends this patient to the coagulation lab where we run the basic screen. Next, please. And the basic investigations show us that the APTT is prolonged. This is what we usually expect in a hemophilia. And the question we now need to answer in the lab is there a possibility of a bleeding disorder? So in the face of that history which we have got and this abnormal test, yes, there is probably a bleeding disorder. Next, please. So where all can this APTT test be done? So this is possible now if we think it would be possible in a level 1 center, which would be a taluk hospital or a rural hospital. And the coagulation lab there would require everything that we need for manual testing and for doing a platelet count, which means you would need centrifuges, pipettes, stopwatches, tubes, water baths, cell counters, microscopes, and staining methods. The reagents would include the PT and the APTT reagent, calcium chloride solution, and normal plasma. Normal plasma can be purchased on a commercial basis, which is very stable and can be stored very easily. However, one can even prepare in-house normal plasma by collecting 12 healthy donors, taking their plasma and separating it and storing it for as and when required. But it must be remembered always that if you are planning to do some in-house storage, then you need a deep freezer. So this increases the cost at a peripheral level. Manpower, Unlike many other screening programs where just ASHA worker or an ANM can, do the initial screening, coagulation tests are very finicky, and you need to have a technology training in manual testing if you want a reliable report for the primary. You need an MBBS doctor at least to interpret the results in the proper context. Next. The next question, when we get an abnormally prolonged time, that we have to ask ourselves is next. So for that, we do a very simple thing called a mixing test. We long time. It might be the PT which is prolonged, which is seen in factor 7 deficiency, or the APTT which is prolonged, and we of normal plasma. Normal plasma contains all factors. The patient's plasma is deficient in. We add them. If there is a normalization of the prolonged clotting time, that indicates a factor deficiency. That is our hemophilias A, B, or C. Then we expect a prolonged APTT. It may be an isolated PT prolongation. For the rarer factors like factor 2, 5, and 10, both PT and APTT may be prolonged. So you can do a mixing test on either of them or both of them. If you look at the tubes on the right side, the left is APTT, and the right side is that of a normal pooled plasma where the APTT is normal. So if you get the stop coming to normal, it is now 30 seconds from the starting 75 seconds. This indicates a factor deficiency. And next please. If this does not correct and stays prolonged, then this indicates a inhibitor. Next. So the inhibitors can be, they can be produced due to a variety of things. They can be lupus anticoagulant, heparin, or in the context of today's meeting, mainly a factor inhibitor, especially factor VIII inhibitor. There can also be other inhibitors and some other situations which can cause an inhibitor-like effect in the plasma. Next. So after we have decided that there is a factor deficiency, now we have to answer a question, which factor deficiency is this? So if we look at these results, we see that the patient's plasma showed a prolonged APTT, which corrected with addition of normal pooled plasma to 38. So this is a factor deficiency. If we add one part of patient plasma and factor VIII deficient plasma, and the clotting time does not correct, what it means is that the patient's plasma also does not have factor VIII, and the factor VIII deficient plasma does not have factor VIII. So the patient has a factor VIII deficiency. So if the mix is continuing to show a prolonged time with factor VIII, we call it a factor VIII deficiency. So once we get this, we say this is suggestive of a factor VIII deficiency. The next thing is to confirm it by a factor assay, which in this case was less than 1%. So what this patient has is a severe hemophilia A. Next, please. Next. Now, where can this level of testing be done? This would probably need a level 2 center, which would be a district or a civil hospital, where we can perform at least mixing studies to differentiate between factor deficiency and inhibitors, and then follow it up with a factor assay to decide to confirm the deficiency. This is usually like a coagulation lab of a pathology department. The equipment that would be required for this center would be that of a level 1 facility, plus at least a semi-automated or a fully automated coagulometer. The reagents required would also be the same, but now because we have to do factor assays, we need factor deficient plasmas also and calibration plasma also. The minute our tests start getting more and more complicated, for example, we are trying to now do a factor assay, we need quality control material to be available so that we are sure that our results are correct and the test has been run properly. The manpower now that we need would be more skilled. We need a technologist who would be having adequate training to perform both manual tests and the running and maintenance of an automated coagulation analyzer. And now we need a pathologist who will be able to interpret the results in the proper context. So as we are going higher with more complexity of tests, we need more trained manpower and more equipment. Next, please. Once we have said that we have got a factor VIII deficiency, what else is required? So we may need to do some additional tests because some types of severe von Willebrand disease may look just like severe hemophilia A, both clinically and in the lab tests. So we would need to do a von Willebrand there. And rarely a patient with mild factor VIII deficiency find factor 5 and 8 deficiency. So in this situation, we would also need to run a factor 5 assay to rule that out. Because that has a management. And if the patient is not responding to therapy or is needing surgery, then we are thinking of inhibitor screening, and we would need to then do a Bethesda assay if we find an inhibitor. And if there are other family members, we may need to screen them for the deficiency. This can be done directly with factor assays. We don't need to do screening tests on them. And finally, we may even need genetic testing for the patient to find his mutation, because some mutations are associated with very high chances of developing inhibitors. In the female relatives of this patient, as you've heard before, we will need to find out whether they are carriers or not, so that we can plan their pregnancies accordingly. If the mother is already pregnant, then we need to do the testing of the fetus to find out whether the fetus is affected or not. And in the research setting, we need to have some genetic information sometimes, because as you can see, many new therapies are being tried out. And at some stage, we may need to see if there is any particular mutation which gives rise to an altered response to a particular therapy which is being introduced. Next, please. So where can this be done? Now, this can be done at a level 3 center, which would be a medical college or a center of excellence. This would have coagulation lab level 2 facilities, along with facilities to rule out von Willebrand disease and to do a Bethesda assay, as well as platelet function testing if required. The equipment would remain as that of a level 2 facility, along with now a platelet aggregometer and a flow cytometer and deep freezers. The reagents would be that of a level 2 facility with addition of monoclonal antibodies, ELISA plates, and basic training in how to extract DNA. The manpower here is now somewhat different. Besides the technologist, we need to keep in mind now the workload and plan that many technologists required, and the technologists may need basic training for molecular techniques. We definitely need a pathologist at this stage. It would be good to have an obstetrician on board so that chorionic villus sampling can be done, and a genetic counselor would be of great help, because you might have a different sort of bleeding disorders, some X-linked, some autosomal recessive, some autosomal dominant and recessive, where you would need to counsel the family accordingly for the next pregnancy. So what is the other testing we can do for the bleeding disorders? If it's other than hemophilia A or B, then we need to have more advanced facilities which would be available in the reference labs. These could be apex labs in states. This could be something like our institute or the AIMS, where we would have all the requirements required for the lab at level 3, along with the ability to do a complete von Willebrand panel with multiple analysis and genetic testing, and the facility to look for rare bleeding disorders as well. Because we would like to think they are rare, but our population in India is so much that I'm sure we will find lots of rare patients with rare bleeding disorders also if we start looking carefully. And what would be the role of this level 4 lab? It would be essentially to maintain quality control for the labs which are under it, that is the level 2 and 3 labs, to train manpower for all techniques which are pertaining to the labs lower, to do troubleshooting for various tests involved at all levels, then to participate in research, and to keep on updating diagnostic techniques which are emerging with relation to the newer treatments and newer technology which is being available. And this, I can tell you, is moving really fast as far as hemophilia is concerned. As soon as the new drugs come, we realize that many of our old tests will not help in monitoring them or we need to take these on board. So from the research point of view, I'm sure you have all heard this. There is a very good and very heartening development, which is the quick diagnosis of severe hemophilia A and von Willebrand disease. This is through the team at NIH Mumbai, which has developed a technology for a rapid CAR test to detect severe factor 8 and von Willebrand antigen deficiency, and can be done both on whole blood and plasma. So if the result is available in 10 minutes, and though the kit validation is still going on, if this comes, then even our hierarchy, which I have just mentioned to you for lab testing, can be partially done away with. Because this is a sort of a patient care test. If it is to be done on whole blood, then it can be done even at a level 1 center. It just looks like a pregnancy test. There will be an extra line which will be there in a normal person, and in the patient, that line will be missing. We're still waiting for this kit to come in, but since the validation is on, I'm very, very hopeful that we'll see it soon. Next, please. So let me share the local experience at PGIMR Chandigarh. We have an annual test load of coagulation tests, which is around 90,000 tests a year. Out of this, fresh bleeding disorders just form 300 cases of this total load. And since 2000, since I joined the department, we have records of nearly 3,300 patients who were sent to us for investigation of a bleeding disorder, not thrombocytopenia by itself. Next. We have a lab staff comprising 3 technologists, 1 senior resident who has passed MD pathology, and 2 consultants in the lab. And we offer a variety of tests, including most of the coagulation assays, a thrombophilia panel, platelet aggregation, HIT testing, anticoagulant monitoring, and platelet flow cytometry. Next. And for this, to ensure that the lab returns very good quality results, we participate in both the national and international QC programs on a regular basis. And we are helped in our work by the genetics lab of our department, which runs the factor V Leiden mutation. And now for hemophilia, we are also doing Sanger sequencing, next generation sequencing, and MLPA. This is essentially under the guidance of Dr. Reena Das, who looks after this lab. We can do platelet electron microscopy in select situations with the help of the Department of Histopathology for platelet function disorders. Next. The workload, the annual workload of 300 fresh cases, we would that has nearly 11% children. So they form a very important part of the patient cohort that we are investigating. The age may range from 12 days to 77 years. Some bleeding disorders really present late. And male-female ratio is almost 2:1. Despite all this extensive testing, we can only find the answer in 70% of cases. In 30% of the cases, we are not able to find why our patients are bleeding so much. And this success of 70% is also mainly because we have a very large chunk which is constituted by hemophilia A and B. Next, please. If we look at the 8-month testing data from the hospital, we see that we do, this was actually looking at the pre-COVID and the during COVID time. I was just seeing whether we had decreased the rate of testing because most of the other tests had gone down. But that was not so for hemophilia, which is very heartening. That means our patients were still coming to us for investigation during these very tough times. And we seem to be doing far more factor 9 assays. We did a lot of more inhibitor screens, and Bethesda assays remain the same. So there is a need for continuing this testing for this category of patients, even though there is a national calamity or a world calamity. Next, please. The genetic testing was undertaken in our department through a project funded by the DBT for about 3.5 years, where we looked at 713 patients from 633 families with an aim to find the spectrum of mutations that we have for bleeding disorders, most importantly hemophilia A, B, and the other rare bleeding disorders as well, with a purpose of making a panel so that we could go straight to mutation detection in once we had found the factor deficiency or the kind of defect there was. So we first identified that, then we ran an NGS panel, we found the mutations, and then we were in a position to do carrier detection, which we did in 117 families, and antenatal testing, which was offered in 58 families. The interesting part of this study was that out of nearly 300 there were many novel variants that we found, which means that we can just not rely completely on Western data to help us in our antenatal testing and mutation detection. We need to continuously keep updating our database because we are probably going to have newer and newer mutations. Once they are there, then we need to look for those mutations in that family and then be ready to do antenatal testing using those novel mutations. Next, please. So for hemophilia A, there were 400 families, whereas 87 families were tested for hemophilia B. This is the genetic testing. And we were happy to find that we were able to identify as many as 95% mutations in both these categories. And carrier screening was done in 100 females for hemophilia A, 17 females for hemophilia B, and antenatal testing was done in 45 families for hemophilia A and 12 with hemophilia B. And we could diagnose 14 hemophilia A fetuses, which were subsequently managed in a particular way that we avoided the birth of a hemophiliac child. Next, please. So I think I'll conclude my talk by taking you to the core essentials, which I believe are very, very important for any lab, any level, to diagnose hemophilia. First is you need a good team. There has to be a set of people who have a very high level of motivation for testing for coagulation tests. These are really not very simple tests, and not just running a sample through a counter. These are functional assays, so they need very good handling and very careful pre-analytical monitoring. The staff must be always provided opportunities to update skills. Then we need good equipment. With this equipment has to be capable of performing all the desired tests that we need. These have to be properly backed up by maintenance contracts. In many state levels that I have seen, there is a very sad story that very expensive equipment has been purchased, but there was no maintenance contract. So if the machine malfunctioned or failed, after that there was a big break before it could get working again. There has to be provision of a suitable workplace for the machines. I may be able to work in temperature of 40 degrees, but the machines will not. And if you want reliable results from a lab, we have to keep the machines in very good order. This is such a challenge in many parts of the country. Wherever we plan patient care testing, it's absolutely, asking for trouble if you don't have a backup machine. Once you have your patients coming, it's a shame if you have to tell them my machine is out of order or I can't provide you this test at that time. So many of us don't plan for a backup machine, but I think this is a very important thing that we have to keep in our minds if we are planning to offer coagulation lab testing services. Good quality reagents. All of us working in government setups have been, programmed that we have to buy the lowest cost. But sometimes these are not the best. And what I feel is that if we are giving a patient a diagnosis, it should be made perfect to the best of our ability, so the patient doesn't have to go to another center to confirm the test. This can only be done if we have good equipment and good reagents. If we have reagents, we need an unbroken supply. Again, it's very disheartening. The lab spends so much effort to set up a test, and suddenly we realize that there's no fund to buy any more reagents. One of the reasons for that is most centers I've seen get into an yearly contract for buying reagents. We need to have a contract which is a minimum of 5 years. Then you can see the results of your good work and your good laboratory practices and your good testing, when you can watch your patients increasing over the years and monitor them as according to your will. There should be storage and holding facilities with proper refrigeration for all these reagents because they're very sensitive to temperature. And I have seen that there is a lot of wastage in centers where, there may be one patient who comes with factor 13, but we have to be ready for it. We must keep it. So I feel there can be some kind of a policy by which we can share reagents within the state. We can buy one pack and I can share that with, 3 other labs who are willing to do it instead of wasting that. And finally, I think there is no substitute for good governance. We need a continuity in the administrative focus on the disease. So we need somebody to be watching hemophilia as if, their lives hang on it, and fast movement of files and budgets. This is at every level. By the time we, plan to get a new machine and get a new technology in, it's already 3 years down the line. The West has already come up with a new treatment or a new machine, and we still haven't got the old machine in. There should be policies facilitating quick uptake of new testing techniques. So I think if we have this, then most of us would be a lot more happier working in the labs where we have to diagnose bleeding disorders. So I'd like to thank you for your attention. Be happy to take any questions. Janan, thank you very much.
Thank you, Professor Jasmina, for delivering your talk. And Madam, please stay back a moment while I request our VP Finance, Shri Jagdish Sharma ji, to present to you with a token of our love and gratitude. Thank you, ma'am. Thank you, sir. The next talk is Novo Nordisk Commitments to Hemophilia by Dr. Maya Sharma. She is the Senior Medical Director from Novo Nordisk. Dr. Maya Sharma.
Good evening, everyone. I'll request for the presentation, please. All right, so I'll be talking about Novo Nordisk's commitment to rare diseases and specifically hemophilia. And I would say the journey of Novo Nordisk actually started exactly 100 years back, and that too with the love story of husband and wife. It was Dr. August Crow and Dr. Mary Crow, both of them being doctors. And Dr. Mary Crow was actually suffering from diabetes. And then they learned that in Canada, these doctors were residing in Denmark. And then they learned that insulin was extracted in Canada. And while Dr. August Crow was there to deliver a lecture in Yale University in US, he learned about insulin being extracted in Canada. So he reached in Canada so that he can provide treatment to his wife, Dr. Mary Crow. And there, the journey started of insulins, where he promised the researchers that he would manufacture and make it available worldwide for the benefit of diabetes patients. And that's how, for 100 years now, we are driving change. And we are driving this change through scientific and digital innovations for the last 100 years. But even if I have to talk about what we have achieved in these 100 years, it is serving our purpose, improving the lives of millions of patients, 50% of diabetes patients who are dependent on our insulins worldwide. But besides that, what I want to highlight today is our core capabilities. Now, these core capabilities have been in the space of proteins and peptides. Now, being proteins and peptides, it made it imperative that we gave it through injectables. And that is why for the last, I would say 99 plus years, all our molecules, all our proteins and peptides were given only through injections. But then we had a breakthrough, and last year we launched a molecule, a peptide in a pill, and which became a blockbuster for diabetes. And now with that, we are venturing into RNA interference, cell therapy, and gene editing as well. Now, coming to rare diseases. Now, here you're seeing picture of a gentleman who resides in US and he's suffering from hemophilia B. In rare diseases, our ambition has been to decrease and work more on these endocrine disorders. Our purpose is to know that every innovation, whether it is an epic innovation or an everyday innovation, that we are able to bring us closer to a purpose, that it is able to help us realize what is impossible, and help us serve the patient with a cure one day finally, not only with chronic with management, but cure one day. And our strength lies in our agility, and we are ideating without limits. Now, talking about the rare disease journey, maybe not 100 years like insulin, but at least 60 years. So it was 60 years ago that we started researching in the field of plasma factors, and we realized that there are certain proteins and peptides which, when absent, can lead to bleeding disorders. And then we manufactured the first plasma products and clotting factors in 1970s. 1980s is when we launched the first recombinant factor 7. And then in 1990s, Novo 7 was launched, followed by Novo 13 in 2012, Novo 8 in 2014, Refixia in 2018, Esperoct in 2019, and this year we are looking ahead for the launch of Concizumab. Now we follow an innovation-focused R&D pipeline, and with footprints in multiple therapy areas. Even within rare disease, we are focusing not just on hemophilia, but also on other hemoglobinopathies, rare factor deficiencies, acquired hemophilia, hemochromatosis, and Glanzmann thrombasthenia. Our research pipeline includes NDAC in sickle cell disease, concizumab, mimate, and also N13 PMS trial. So we've been building on our heritage in rare blood disorders. We have this Novo 7, the factor 7 product, which is currently approved for hemophilia with inhibitors, acquired hemophilia, Glanzmann's thrombasthenia, surgery in hemophilia disorders, congenital factor 7 deficiency, the Novo 13 for factor 13 deficiency, and we have got Novo 8 and Esperoct for hemophilia A and Refixia for hemophilia B. And why do we continue to innovate in the space of hemophilia when we already have so many factors available? It is driven by our need for hemoglobinopathy because we know that the need is far from exhausted. Maybe we have not yet achieved our targets in terms of the social innovation. We are still looking at improved outcomes in hemophilia by elimination of bleeding, improving joint health and by minimizing pain, increasing quality of life. In terms of safety, we are looking at reducing the thrombotic events and improving the tolerability of our proteins, and also how we can reduce the burden of disease. So today, when we talk about hemophilia, instead of one injection per week or one injection, in a fortnight, can we look at something which can be given once a month or once in 45 days so that we can reduce that burden of disease and burden of administration of any protein? Also, if we can have increased portability, so if these medicines can be carried easily and it does not stops the life of these patients. And that's why now we are holistically looking at 5D product strategy. Now, what I mean by 5D is that at Novo Nordisk, now when we are looking at development of products, we not only look at the drug, the protein or the peptide, but we are also looking at the device in which it can be administered. Also, if it is something which is very new in the pipeline, then can we also have diagnostic modalities available for this? Can this digital data be collated and this data be analyzed? So this is what I mean by 5D, and we are looking at holistic development of product through these lens of 5Ds. And I'm really happy to share that, we are already working in phase 3 for concizumab, where we are working on these 5D. Then we also have MIME 8, again, a breakthrough innovation that will see the light in a couple of years as well. Oral F8 mimetic, F8 gene editing, and oral TFPI inhibitors as well. Briefly about MIME8 before I hang up my boots today. So MIME8 is a novel, meticulously designed factor 8A mimetic. Now, what is breakthrough about this particular thing? Because it's not only there for indication of hemophilia A with and without inhibitors, but this is one peptide which is going to come as a therapy once in 45 days. Now, something which has been unheard of hemophilia. So today, when we are looking at injections, say thrice a week, and you can multiply that by the number of weeks in a year. Now we are looking at reducing this burden of therapy to say 7 or 8 injections in a year, and how it will ease the life of a hemophilia patient. It will improve access and improve the quality of life of these patients. Now this as you can see by the design of this protein, has two ends which will fit into factor 9 and factor 8a, factor 9 and factor 10, and this is the first fully human immunoglobulin G4 bispecific antibody. So that is what I wanted to share about Novo Nordisk's glorious past, what we are doing in present, and what are our future innovations which will ease the life of hemophilia patients. Thank you so much for giving this platform to highlight Novo Nordisk, how it is trying to drive change in hemophilia and rare diseases. Thank you so much.
Thank you, Dr. Maya, for your valuable talk. May I now request our VP Development, Mr. Ramo Gadkarji, to kindly facilitate Dr. Maya with a memento. Thank you. I now request Dr. Naresh Gupta to kindly deliver his talk on access for all, role of regular replacement in pediatrics.
Okay. Where do I direct it? Yeah, no, but where do I direct it? Ah. Again, next. Okay. Good evening. Thank you, ardent listeners. I must do justice to your presence here. Whether it is thin, it does not matter. It should be strong. Just like the HFI. HFI is a federation. Federation is collective for some common goal. But I was wondering, it also has a lot of diversity. Kitna 87 chapters hai? 91 chapters. So when I looked at it, I thought they are the ones who have so much of diversity, especially in terms of the languages. How do I do justice? I know only two official languages, English and Hindi. So मैं दोनों में आपसे वार्तालाप करना चाहूँगा और बाकियों से माफी मांगना चाहूँगा कि और लैंग्वेज में नहीं सीख पाया हूँ. और दूसरी चीज अभी जो शाम को और सवेरे प्रोग्राम हुए हैं, दे आर ब्यूटीफुल एकेडमिक टॉक्स delivered by beautiful persons, and they are really, now I'd like to come down to the ground level. One, because it is end of the day, and दूसरा मैं आपको कुछ practical points बताना चाहूँगा इसके बारे में जो हमारा इसमें हीमोफीलिया बच्चों के बारे में हम बात करना चाहते हैं. हीमोफीलिया की तादाद कितनी है? व्हाट इज द नंबर ऑफ हीमोफीलिया? ये डेटा है अभी 2022 के सितंबर अक्टूबर में 2021 का WFH का जो सर्वे होता है उससे आया था 4,29,232. सो अराउंड 4,30,000. It has just moved up. We used to be in 1999, we used to talk about 4,30,000. But this probably is not the true figure. There is a doctor who's an epidemiologist and is master in this data. और वो मैकमास्टर यूनिवर्सिटी गए हैं, एल्फोंसो लोरियो. उन्होंने 3 देश के जो अच्छे देश हैं, फ्रांस और यूके और जर्मनी के डेटा को देखा, एंड द एस्टिमेट इज ये जो है 4 लाख नहीं है, ये 11.5 लाख है. ये जो डेटा हम हार्डकोर मान के चलते हैं वो बड़ा डायनेमिक है. इट इज चेंजिंग विद टाइम. सो आई थिंक वन शुड कीप इन माइंड दैट द डेटा इज नॉट वेरी. नेक्स्ट प्लीज. द डेटा यू कैन नॉट टेक. ये डेटा आता है जो कि हर साल आता है और इसमें आप देखेंगे कि पिछले 20 साल में 2 गुना नंबर हो गए हैं हीमोफीलिया के. अगला नेक्स्ट. ये हमारा सेंटर का डेटा है, हीमोफीलिया सेंटर जो दिल्ली में मौलाना आजाद और लोकनायक हॉस्पिटल में है. आजकल प्रोफेसर सुनीता अग्रवाल देख रही है. जो लाल ग्राफ है ये बढ़ता ही जा रहा है और इसमें समा भी नहीं सका तो ऊपर चला गया है. नेक्स्ट. और आज हम आई बीन आस्क्ड टू स्पीक ऑन चिल्ड्रन. नाउ व्हेन वी गो बैक एंड लुक एट आवर चिल्ड्रन डेटा, आवर डेटा वाज ऑन इन इलेक्ट्रॉनिक फॉर्मेट शुरू से 2007-8 से. तो एक शुरू का ग्राफ है जिसमें हमने एक्स एक्सिस पे एज रखी है, वाई एक्सिस पे वेट रखा है. और उसका कारण ये था कि हमको लग रहा था कि हमारे जितने मरीज हैं सब बच्चे हैं, उनका वजन बढ़ता जाता है. And that becomes a issue because those days there was no treatment. So they were all bedridden. They used to eat. They used to feel. They used to suffer. Or depression is actually a cause for obesity also. So you'll see nearly 70% were यंग पर्सन्स। नेक्स्ट प्लीज। उसके बाद हमने 2011 में एक स्टडी करी थी 5 डेवलपिंग कंट्रीज में, इंडिया, साउथ अफ्रीका, मोरक्को, अल्जीरिया एंड ओमान। उसमें जो एवरेज एज थी, अब हम देश की नहीं बात कर रहे हैं, सबकी कर रहे हैं, वो 20 साल थी। एंड माइंड यू, आवर स्टडी हैड इंक्लूडेड ओनली अबाउ 6 ईयर्स। सो अगर आप 6 साल के नीचे वाले इंक्लूड करेंगे तो ये शायद 10-12 साल पे आ जाएगी। और उसके पहले का समय ये है जब इलाज नहीं मिलता था। अगर आप 50 साल पहले जाएं तो हीमोफीलिया, सीवर हीमोफीलिया का व्यक्ति हीमोफीलिया ए का 15 साल ही जीता था। So our patients used to die, and most of the patients that were coming to us, more than 70%, were young, and you could see that they are like that. But what is remarkable, ये जो हमारी study थी, इसकी international study, उसमें था कि 70% को disability थी और टारगेट जॉइंट्स 84% थे। लेकिन सबसे महत्वपूर्ण चीज ये थी कि अगर उन्हें ट्रीटमेंट के लिए कहीं जाना है, इंडिया में या बाहर, 80 किलोमीटर कम से कम जाना पड़ता था। तो ये बड़ी महत्वपूर्ण चीजें थी। नेक्स्ट प्लीज। एंड वन मोर थिंग दैट केम आउट वाज, वी इन दिस पॉपुलेशन ऑफ अबाउट 300, नेक्स्ट स्लाइड प्लीज, 4% हमारे जो है पेशेंट्स जो है रेगुलर रिप्लेसमेंट थेरेपी है जिसको प्रोफाइलेक्सिस कहते हैं उस पे थे, 4%। और ये क्यों प्रोफाइलेक्सिस मिलना चाहिए बच्चों को, उसके बहुत सारे कारण हैं। और सबसे बड़ा कारण तो मैं जो ये मानता हूँ, आप इसको छोड़ दीजिए ये जो हमारे लिखी हुई चीजें हैं, सबसे बड़ा कारण है कि बच्चे जो है ना, उनका अपना कोई नहीं होता है। ये डिजीज का जैसे कोई नहीं होता है, ऑर्फन डिजीज है, वैसे बच्चों को बड़ी दिक्कत होती है, बिकॉज ये एक बीमारी ऐसी है कि अच्छी खासी मिडिल क्लास फैमिली भी इसका ट्रीटमेंट नहीं अफोर्ड कर सकती है। तो फैमिली सपोर्ट चाहते हुए भी नहीं मिलता है, और कई जगह तो ऐसा वो चाहते भी नहीं है, सोशल सपोर्ट नहीं मिलता है। और इसके अलावा सबसे महत्वपूर्ण चीज ये है कि अगर आप इनको ट्रीट करें तो उसके बेनिफिट बहुत ज्यादा है। एक तो कम वेट में, कम कॉस्ट में ट्रीट हो जाता है, लॉन्ग टर्म में बहुत ठीक चलते रहते हैं, एंड देन दे कंट्रीब्यूट फॉर ए लॉन्ग वेरी लॉन्ग टाइम टू द सोसाइटी। आपने डॉक्टर अनुपम दत्ता को सुना, वो चार्ल्स बॉम्बार्डियर से लेके कितने लोगों को उन्होंने दिखाया कि माउंट एवरेस्ट तक जा चुके हैं। और ये है जब हमारे पास एक्सटेंडेड हाफ लाइफ फैक्टर नहीं थे उन दिनों। ये पॉसिबल है, और ये बच्चे से ज्यादा पॉसिबल है, क्योंकि बच्चे में जब आप रेगुलर रिप्लेसमेंट थेरेपी प्रोफाइलेक्सिस देते हैं उसके बेनिफिट्स ज्यादा आते हैं। नेक्स्ट स्लाइड प्लीज। नेक्स्ट नेक्स्ट नेक्स्ट। बच्चे में ज्यादा आते हैं। ये बहुत पुरानी स्लाइड है, 2007 की है, यू की। ये स्लाइड में जो दर्शाया गया है, इसके बेसिस पे आज की तारीख में जो कहते हैं कि प्राइमरी प्रोफाइलेक्सिस है, सेकेंडरी प्रोफाइलेक्सिस है, 1 ब्लीड के पहले, 2 ब्लीड से पहले देना चाहिए, वो इसके ऊपर डिपेंडेंट है। और ये स्लाइड जो है, ये जो डेटा है, ये पब्लिकेशन, ये डॉक्टर निल्सन की जिन्होंने स्टडी करी थी स्वीडन में हाई डोज पे, 12 साल का डेटा दिखाया था। उसमें आया था कि अगर आप प्रोफाइलेक्सिस देते हैं तो उसमें फायदा होता है, ब्लीडिंग कम हो जाती है। लेकिन उसके बाद जितनी स्टडीज आई हैं उसमें यह आया है कि जो फायदा ज्यादा होता है जॉइंट्स को, वो उनको ज्यादा होता है जो कि बचपन में जिसको ट्रीटमेंट शुरू करा जाए। नेक्स्ट 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 नेक्स्ट। ये डेटा है अक्टूबर 22 का। अगेन जो ऊपर के 2 चार्ट हैं लाल और नीले, वो दिखा रहे हैं कितने बच्चे जो हैं ये प्रोफाइलेक्सिस पे हैं, और ये 2 से 9 वाले लाल हैं और 10 से 19 वाले 18 वाले ये नीले हैं। और नीचे जो हरे वाला चार्ट दिखाए जा रहे हैं और उसके नीचे ये सब का ऐसे ऐसे कितना बढ़ रहा है। तो आप देखेंगे कि पीछे 20 साल से जो बच्चे हैं लोग हैं उनका रेगुलर रिप्लेसमेंट थेरेपी बहुत ज्यादा आगे बढ़ रहा है। नेक्स्ट प्लीज। दिस चार्ट इज वेरी इंटरेस्टिंग। इसमें लाल वाला दिखाया है कि जैसे जैसे आप उनकी रेगुलर रिप्लेसमेंट थेरेपी बढ़ाते हैं, और जो नीचे के चार्ट हैं हरे नीले, वो दिखाते हैं उनका ब्लीडिंग कितना कम होता जाता है। तो बिल्कुल उभर के आता है, और इसके बारे में किसी को दो राय नहीं होनी चाहिए। नेक्स्ट प्लीज। नेक्स्ट। नो नो, एक मिनट पुराना इसको ले आइए। इसमें देखिए ये है कि आपने रेगुलर रिप्लेसमेंट थेरेपी दिया बच्चों को, तो उसमें कितना कितना फायदा आया, ब्लीडिंग में कितना फायदा आया, जॉइंट आउटकम में कितना फायदा आया, जो मैंने सर्कल करा हुआ है ये डेटा दिखाता है कि बच्चों में ना के बराबर फिर वो टारगेट जॉइंट्स और जॉइंट डैमेज रह जाती हैं। तो जल्दी शुरू करना बहुत अच्छा रहता है। नेक्स्ट, अब ये HFI के लिए स्लाइड है, ये 22 की स्लाइड है जो ग्लोबल सर्वे की है। प्लीज आप देखिए, इसमें दो दिखाए हैं मैंने, एक ऊपर चार्ट है एक नीचे है। ऊपर वाला 1 साल पुराना है 2020 का, 2021 का जो है 2021 का वो अक्टूबर इसमें 22 में पब्लिश करा गया है। उसमें दिखाया है कि बच्चों में 2020 में जो इंडिया का डेटा गया था उसमें 9% और 4% जो है रेगुलर रिप्लेसमेंट थेरेपी पे थे। 22 में मिसिंग है, मतलब HFI के पास डेटा ही नहीं है, क्योंकि हम कितना करें लेकिन हमको दुनिया को जो हम कर रहे हैं और वो चीज उभर के आनी चाहिए। नेक्स्ट प्लीज। ये कारण क्या है कि रेगुलर रिप्लेसमेंट नहीं दे पाते, उसके बहुत सारे हैं। एक ये कि कोई अभी भी रिप्लेसमेंट थेरेपी इतना नहीं कारगर बना है जिससे कि आप जीरो ब्लीड हर मरीज में कर सकें। जीरो ब्लीड आप आधों में कर सकते हैं, आप 3/4 में कर सकते हैं, 100% में नहीं कर सकते हैं। So breakthrough bleed is a problem. There is a problem of inhibitor, which is a side effect of any clotting factor that you give. As you heard, it's a protein, and any protein that gets into the body will create an anti-protein, and some of which will become neutralizing. The injectable nature of this protein, as you also heard that most of the proteins have to be given injectable. प्रोटीन खाएंगे तो हमारे इंटेस्टाइन के एंजाइम्स उसको डाइजेस्ट कर जाएंगे, तो वो इंजेक्टेबल देने के लिए, एंड दैट टू फ्रीक्वेंटली 2 or 3 times in a week, is very very difficult, and that makes the adherence more difficult. And these kind of scenarios are more important for children. With children में न कोई देता है और न उनको कोई लेके आता है, अस्पताल में भी ला सकते हैं। और ऐसी चीज को ध्यान में रखते हुए when we wanted to start regular replacement therapy, हम लोगों ने सेल्फ इन्फ्यूजन प्रोग्राम करा था। पेरेंट्स को नहीं सिखाया था, 12 साल के ऊपर वाले बच्चों को सिखाया था। एंड 12 साल के ऊपर वाले बच्चे को अगर आप एम्पावर करेंगे, इमेजिन यू टीच देम IV infusion, they feel very empowered. They feel empowered not only in infusing their injections, they feel empowered otherwise. Like one of the mothers told us, this child would never come to our hemophilia center alone. He'll say, Ma, I want to go to the center, please take me. आप क्यों जाना चाहते हैं, आपको तो कोई तकलीफ भी नहीं है। इसे नो नो, देयर आर सो मेनी पेशेंट्स, सो मेनी डॉक्टर्स, सो मच स्टाफ, आई वांट टू गो देयर। एंड शी स्पोक ऑन दैट वर्ल्ड हीमोफीलिया डे एंड शी सेज, जिस दिन से उसको सेल्फ इन्फ्यूजन मिला है, ही सेज, माँ you don't need to come, I will go on my own. And that is the kind of empowerment which comes through and which cannot be measured through the real data. Next slide please. So next, इसको हम कैसे कर सकते हैं? इसको करने के कई तरीके हैं। एक तो है कि अवेयरनेस है, एक है कि इंफ्रास्ट्रक्चर डेवलप करना है, एक है कि उनको एम्पावर करना है। वी क्रिएटेड ए सेल्फ हेल्प ग्रुप फॉर हीमोफीलिया। वी यूज्ड टू हैव ए मीटिंग विद द फैमिली एंड पेशेंट्स. They all agree to what you want to do. Next, is there any innovations? Next, in the next, is there any way that we can improve the adherence? Because बच्चे को डर लगता है, बड़े को भी डर लगता है इंजेक्शन लगाने से. Next, then there is this new treatment. Hello, next. और इनहिबिटर का इशू आप सुन ही चुके हैं कितना मुश्किल है. नेक्स्ट, सो ये जो IV ट्रीटमेंट था, दैट चेंज्ड इनटू सबक्यूटेनियस ट्रीटमेंट रिसेंटली, एंड दैट इज द बाइस नेक्स्ट, दैट इज द बाइस स्पेसिफिक एंटीबॉडी, जिसके लिए, जिसकी इजाद के लिए 2018 में एक नोबेल प्राइज भी दिया गया. सो दिस बाइस स्पेसिफिक एंटीबॉडी काइंड ऑफ लुक्स आफ्टर मेनी ऑफ दीज प्रॉब्लम्स. पहली प्रॉब्लम, it doesn't need to be given IV. It can be given like insulin into the subcutaneous area. Then it doesn't need to be given 2 or 3 times in a week. It can be given once in 2, 3 or 4 weeks. Actually, it is conventionally given once in 4 weeks. And since it is a bispecific antibody, it is bypassing the factor 8, It does not produce any inhibitors to factor 8, nor do the existing inhibitors matter for its efficacy. ये जो है inhibitor का मरीज हो, बिना inhibitor का मरीज हो, सब में कारगर होती है. Next. Next. So they have done many studies over a period of 15 years. हेवन 2 स्टडी एक ऐसी है जो कि बच्चों में करी गई है. शुरू में कही थी बच्चे child age group who were with inhibitors, and subsequently it was done without inhibitors also, and you can see that the benefits were so many. There was of course a setback when it turned out that this might lead to thrombosis. Actually it led to thrombosis and it led to deaths also, and these studies were even stopped. The whole thing was put on hold, but it turned out that this drug can interact if some bypass agents, FIBA is given along with. So if you are giving this treatment and FIBA goes in, then the two works together. And the reason is very simple. जो हमारे क्लॉटिंग फैक्टर्स हैं, उनकी एक लिमिट है कि वो फैक्टर को किस लेवल तक ले जा सकते हैं. They cannot raise it to 50%, 100%. I am talking about hemophilia A, by the way. Hemophilia A में जो फैक्टर 8 है, उसका सबसे बड़ा फ्रेंड होता है फॉनोलेब्रेन फैक्टर. आप फैक्टर 8 को कितना भी मजबूत कर दीजिए, लेकिन अगर उसका फ्रेंड जो कि जिसके साथ वो टैग रहता है फॉनोलेब्रेन फैक्टर, if it goes away, the partner will die. So there was a limit to which you could escalate the half-life, and that is why you would never find zero bleed or excessive thrombosis also. But these other products that came in, they had bypassed that. Their technology was just revolutionary, and they were much too potent in producing a clot. And on top of that, you add FIBA, which contains another 4 thrombotic factors, then it became difficult. And ever since that FIBA was taken away from emicizumab treatment, there have been no deaths or serious events of thrombotic nature. Next, please. So if you look at it, for hemophilia A, which we are talking about, there is an alternative that has come in. And similar alternatives are in the pipeline. Next couple of years, you will hear about many of them. But it makes our job much easier, especially for the child, the pediatric patient, because when they have a small weight, per kg basis में जो treatment जाएगा, उसका cost भी उतना ही कम हो जाएगा. Benefit, I told you, is more in children when it comes to the long-term damage reduction. And the convenience is so much, they can do it themselves. And the overall benefit is large. And I also believe that there is a support program even by the industry, like they sometimes do, but this is official, that if you buy 1 vial of this, then they give you 2 free vials, which is officially accounted for. It's not that they give it. So that is just to support. And I think all the treatment that we need for hemophilia, especially for children who are actually not nobody's baby when it comes to treatment, but the whole society's baby, they need this support of money more. And this support must come from every nook and corner. It's not that government can do it. It's not that parents can do it. It's not that industry alone can do it. So we need to have many more ways of supporting this treatment. I can see that the 10 minutes are up, so I will stop here, but I would be happy to take any questions. किसी का कोई comment हो, कोई questions हो, कोई query हो, I'll be very happy to answer. Thank you for patient listening. कोई सवाल नहीं? थक गए ना? क्या है? कोई है? मैंने सुना. I saw one. Yes, sir. मेरे को मजा नहीं आता अगर सवाल नहीं आए. I would like to ask in the beginning कि क्या सवाल जवाब दें. Yes, you're right. Any other question? So he is right, but we don't want to confuse the issue. We don't want to confuse the issue. There were these deaths when the company, the producer of this product had to put up a website कि हम दिखा रहे हैं इतनी डेथ्स हुई हैं, हमने बंद कर दिया है। उसके बाद जब वो इसकी जांच करी गई तो पाया गया कि उसमें फीबा का रोल था, क्योंकि एमिसिजुमैब अपने आप में बड़ा स्ट्रॉन्ग पोटेंट थ्रोम्बोटिक एजेंट है और ये भी इसमें भी एक्टिवेटेड फैक्टर होते हैं फीबा में, तो दोनों मिलके ऐसा करते हैं। सो देन दे सेड नो नो व्हाट वी डू इज, जिनको हमने एक्टिवेटेड फैक्टर 7 दिया उनको ये इवेंट नहीं हुआ। नाउ रिमेंबर, जो पेशेंट्स इनहिबिटर के हैं उनकी ट्रीटमेंट एमिसिजुमैब अपने आप में इस तरह से नहीं है कि एमिसिजुमैब इज ओनली प्रिवेंटिव, लेकिन अगर कोई ब्रेक थ्रू ब्लीड हो जाती है ऑन एमिसिजुमैब, यू कैन नॉट गिव मोर एमिसिजुमैब, you have to give them bypass agent just like any other inhibitor patient, true, right? So when you give this bypass agent, आपके पास दो चॉइस हैं, या तो आप फीबा दीजिए या फैक्टर एक्टिवेटेड फैक्टर 7 दीजिए, पीसीसी दीजिए या फैक्टर 7 दीजिए। अब दोनों में से कौन सा देंगे इसके ऊपर बहुत डिबेट है, बहुत टेबल्स हैं और बहुत अपनी अपनी ओपिनियंस भी हैं, बट यू कैन मेक योर ओन थिंग। लेकिन एक उसमें चीज बड़ी अहम ये है कि सबको एक से फायदा आएगा जरूरी नहीं है। somebody might benefit from A, somebody might benefit from B, and that is why we say if you're treating a patient with inhibitor जिसको bleed हो गया है, आपको दोनों चीज अपने पास रखनी चाहिए, 7 भी रखना चाहिए और पीसीसी भी रखना चाहिए। अब सवाल ये होता है कि अगर एमिसिजुमैब है और ब्रेक थ्रू ब्लीड हो जाए, आपने सबको दे दिया कि हम एक्टिवेटेड 7A देंगे क्योंकि इट इज सेफर, देन मुश्किल हो सकती है कि वो शायद कारगर ना चले, या ये कि किसी की अपनी ओपिनियन और प्रोटोकॉल ऐसे बने हुए हैं वो कहे कि हम नहीं दे सकते हैं इसमें। तो आप कैन यू गिव देम फीबा और पीसीसी? द टेक्निकल आंसर इज what used to be the standard dose, they said you can give it in reduced dose. So I would support that it can be given, but when we say in a forum which is more generic forum, wide based, हम उसमें उस बात को लाते नहीं है, क्योंकि अगर किसी ने गलती से उसका रेगुलर डोज दे दिया 100 IU per kg में, तो उसमें वो पेशेंट को प्रॉब्लम हो सकती है। बट इन केस देयर इज ए नीड मीन्स एक्टिवेटेड फैक्टर 7A काम नहीं कर रहा है तब देना है, या और अदरवाइज एज ए पार्ट ऑफ योर पॉलिसी प्रोटोकॉल, देन यू can use, but be careful with the dose and watch the patient. Thank you for bringing it in. और कोई कमेंट सवाल? Thank you and have a nice evening. Thank you, Pawan.
Thank you, Dr. Gupta. It is always enriching to hear your views. And thank you so much for your valuable contributions to the Hemophilia Federation India, as always. Thank you, sir, so much. And sir, please stay back for a moment. I would request our Vice President Development, Mr. Ramu Gadkarji, to kindly facilitate sir with a memento. Thank you, sir. Our next presenter is Dr. Pawan Bhati from Takeda. I request him to please come up and deliver his talk on bleed impact model, burden of illness, and practice change impact in hemophilia A. Please, sir.
So, good evening, everyone. So, this is Dr. Pawan. So, what I would do now, the talk which I'm going to speak about is very different from all the scientific sessions which we have done till now, right? So, before I start, I just wanted to give you the few data points around hemophilia in India. At present, almost 160,000 patients are existing who are suffering people with hemophilia in India. And almost 29,000 are registered with the HFI chapters. Now, when I joined my MBA, so my professor used to say that everything has to be done. Whenever you do anything, it has to be sustainable and has to depend upon the three factors. One is that it has to be sociologically sustainable, economically sustainable, as well as ecologically. Now, so what we did, this is one of the major economical study which we did in India with the 30 HFI chapters across India and 30 states which we covered, and the major states which we covered was the Tamil Nadu, Gujarat, Kerala, Rajasthan, Punjab, and Delhi. Please let me emphasize on one point that this is not a study which we did. This is an economic model, right? There is an economic modeling which economic modelers do. So we did this study with the Vista Health. And what I'm going to do present is to present you one of the findings which we had it in the state of Punjab. So what we did in this model, we took two arms. There were two arms to the model. One arm was with the normal on-demand therapy was treated. The patients were treated with the on-demand therapy. And in the other arm, what we did, that over a span of 5 years, they were shifted to the prophylaxis. And we observed this study at a span of 5 years, and we looked into the economic points around it. Now, as I said, that there were two arms to it. So population was current standard of care, which was on demand, as well as versus which was compared with the in prophylaxis, right? The design of this whole economic study was to measure the burden of the illness. Now, when I say burden of the illness, it talks about that it has the direct cost as well as the indirect cost. Now, please understand, when we pay directly, it is tangible in nature, but you wanted to capture a cost which is intangible in nature, is indirect in nature. And few studies economically has shown that indirect cost is almost Herculean amount. I would say almost 10 times greater than the direct cost, right? And in this study, we put the inputs around with the severity, age, and management of people with hemophilia. We were measuring the annual bleed rates. We wanted to capture the healthcare resource utilization, right? Lost productivity, and the unit cost surrounding the same. The output which we measured in this study was on the total beads, right? How much of the healthcare resource utilization was reduced, and how much of the days based on the productivity loss was decreased around the same. I don't know yeah. Now, yeah. So what we did in the state of Punjab, we saw that almost 425 patients were there. Severe hemophilic patients were almost 356, and the children who were suffering from severe hemophilia was 193. What we saw that over a span of 5 years, on-demand management, right? On demand, it was seen that almost the bleeding events which happened was 39,546. Now, this bleeding was divided into three parts. Please understand that there was a bleeding on the total bleeding, major bleeds, and the non-minor bleeds were there, right? Now, the cost associated with these events was almost 6 crores rupees. 6.8 crore was invested due to these for the management of this bleeding or the management of hemophilic patients, right? Which went into this almost the 39,941 clinical visits were there, almost 395 hospitalizations, and please mark up that the 2 severe deaths which happened due to in this population also. Now, to measure the indirect cost, you can see that the 91 potential disability was also seen in these cases. Now, when this is scenario 1, on-demand management of hemophilia A. Now, when there is a shift from on-demand to the intermediate low, ideal, intermediate. Only 20% of the patients on demand were shifted from on demand to the intermediate dose. It was seen that the total bleeding events was reduced, which was 13,181. And the amount accountable to this bleeding events was almost 1.9 crores, which was seen into this. It was also seen that the 68.7 thousand hospitalization or the clinical visits was reduced, right? Missed days which was avoided was 42,000, right? And the death which was avoided due to this shifting from on demand to the intermediate low dose, it was seen that the one death was avoided, which was significant. Now, I would also like to bring your attention to this major part of this study was that when I was showing you that how many patients in the Punjab existed, it was seen that the almost 193 patients were all pediatric population. Only in that pediatric population, when we did a practice change, a scenario change from on demand, only in 20% of patients was shifted to low dose standard half life, right? And it was seen that the bleeding events which was reduced was 6,672, and the money which was saved, right, from this was 97 lakhs of the money was saved from this, right? And even it was seen that the 20,000 missed days was avoided, right, and 3.4 thousand additional clinic which was avoided by this. Third part, which was majorly into this, we were talking about IDL and the SHL. Now, one of the things which happened was that on demand, 20% of the patients were even shifted to the extended half-life. And we saw in this economic model, in these number of patients, that the significant changes were seen. Almost 16,058 bleeding events were which was avoided. 51,000 of the missed days was avoided, and 65,000 almost additional clinic visits was avoided, and which led to the significant reduction in the hospitalization visits also, right? And one death was also avoided. So what I would like to summarize, that in this economic model, which can help payers as well as policy people and the HCP who are making a lot of taking a lot of decisions for the patients, what they can see by looking at this slide, you can see that there is on the left hand side, the 5-year cost has been calculated, and on the right hand side, only when the 20% of the patients who have been shifted from on demand to the prophylaxis mode only, either in the pediatric or in the major adult population, you can see a lot of thing was avoided. We can see that the expected cost was significantly reduced. We can see also the potential disability, which comes under the intangible part of the cost, because we can never understand what patients undergoes through. So there was significant reduction in the potential disability. Even the hospitalization from the policy point of view as well as the payer point of view was significantly reduced. So what I wanted to say over how we can use this study. So as I have explained, that this study, which can be used by the payers, policy, and the healthcare professional to take the decision in a very sustainable way, so that they can actually assign the value of their own fund to the proper patient management. And if they wanted to do a technological displacement in their treatment of the patients, in this case from where it was done from on demand to the prophylaxis, then what decisions need to go through this. So this is a finding which we had from this economic model. Hope this will help you. I'm open to any questions if you wanted to ask. Thank you.
Thanks, Dr. Bhati, for your talk. Please accept a token of appreciation from our president, Mr. Premru Palwa. Thank you, sir. Now with this, we have come to the last topic of the day, which will be delivered by Mr. Tutan Nayak from Pfizer. I request Tutan to kindly deliver his talk on bringing breakthroughs that change patient lives.
Hi everyone, many thanks for the opportunity today where I am going to present about Pfizer rare disease and the current progress and how we are delivering breakthroughs that can change patient lives in the rare disease space. And I know, I think from the audience that this is the last session before we wrap up. So I'll try to make this very quick and focus on the key information that is there without repeating myself in few of the additional information. slides are not changing. Yeah, no, nothing. So, yeah, next slide, please. Yes. So when you look at rare disease, there are a lot of rare disease in the whole world at this point, and currently less than 5% of the rare disease have any kind of treatment. And when you look at the rare disease, then it takes on an average around 6 to 8 years to even receive the diagnosis. That's the kind of situation that is there. And majority of the rare disease is diagnosed with children, which are genetic in nature. While what happens is only a very few of them actually continue more than 5 years, and that's the kind of challenge when we look at rare disease. Number of patients might be really low, but the challenges is that the survival becomes extremely difficult. Can we move to the next slide, please? Yeah. So currently, when you look at Pfizer, Pfizer has a very strong focus in rare disease. This slide actually summarizes. Here you can see a lot of products that are across various stages of development in the pipeline. And there are few which are specifically for hemophilia that I'll cover in the next few slides. But you can see a range of products in the phase 3, while there are some products in the phase 1 and phase 2 level of development as well. Next slide, please. Yeah. So overall, Pfizer rare disease can be, the product development can be broken into three different categories. First is rare hematology, rare blood disorders, and rare endocrine and metabolic disorders. Second is rare cardiology and neurology. And third is a completely new spectrum of therapy, which is called end-to-end gene therapy. In gene therapy also, there are multiple diseases which are across development, and one of the disease being focused is the hemophilia A and B. Next slide, please. Next. Yeah. So this is a very, I think we have discussed about this slide multiple times since morning, and multiple speakers have actually covered this. So I'll not take a much time here, but overall, if you see in India, currently hemophilia diagnosis rate stands at a much lower. In the red bar, you can see only around 12%, while worldwide the level actually increases when you look at the developed countries. And that shows that there is a tremendous gap in the patients which are currently identified and diagnosed, from the number of patients that are there who are currently not getting diagnosed or not getting any treatments available. So overall, there is a lot of actions going from here, from HFI, from the government, to ensure that the patients that are diagnosed should get therapy free of cost for lifetime. But there is a lot of gap when we look at the overall diagnosis space. And that's where I think, as a company, we want to focus, and we want to partner with all the people that are here. Next slide. Yeah. So overall, I think, like I highlighted, hemophilia remains a key focus for Pfizer. Significant progress is being made now, but there is currently no curative intent therapy. And that's where Pfizer is looking at therapy that can be benefiting across various types of hemophilia, be it hemophilia A or B, and also curative intent therapies like gene therapy. Next slide. So on this slide, I want to kind of focus my attention, and then this is my last slide as well for the audience. So overall, if you see, the hemophilia treatment has started from mid 1960s, and a lot of things have happened. But currently, there is still the therapies which are prophylaxis or on demand. But the last bit, which are highlighted in red, are the therapies that Pfizer is currently innovating and trying to bring to the market. Gene therapy and anti-TFPI therapy are two therapies that are currently in phase 3, and pretty soon we are looking at positive results coming out of it. Gene therapy will be a one-time curative treatment for hemophilia patients, and if we get through and we bring this to India, I think that will change the scenario of hemophilia patients in India, and help them lead a completely normal life without any need for any future treatments. So that's why we want to collaborate and ensure that we get these therapies to India. And anti-TFPI is a therapy which is applicable for patients whether they are hemophilia A or hemophilia B, that is called mastacimab. That's also one innovative therapy that is currently in the final stages of development, and hopefully we can bring it to India pretty soon. So that's what I wanted to highlight from overall Pfizer's perspective in rare disease. And thank you very much for giving this opportunity to us to present today.
Thank you, Tutan, for doing a very informative presentation. And now I request our President, Mr. Prem Roop, to facilitate with you a memento. Thank you. So, dear valued guest of the Hemophilia Conference, it is my privilege to express my gratitude to all of you present here and all our supporters and members who are watching and listening us live on the social media as well. The gathering has been a wonderful opportunity for us to come together and share our knowledge, experiences, and insights related to hemophilia. I would like to extend my deepest appreciation to our keynote speakers who have shared their expertise and helped us broaden our understanding of the latest advances in treatment options. The contributions have been invaluable to this conference, and I am grateful for their presence. I would also like to thank all of the presenters, panelists, and moderators who shared their time, research, and expertise with us. Your insightful presentations and lively discussions with Dr. Apte and other officers of the states have enriched our understanding of the hemophilia. I would be remiss if I did not express my appreciation for our sponsors, Novo, Roche, Takeda, and Pfizer, whose generosity and support have made this conference possible. Their contribution to the field of hemophilia are essential and really very much greatly appreciated. Finally, I want to thank our volunteers and our staff for their tireless efforts in planning and executing this event. Their attention to detail and commitment to making this conference a success have not gone unnoticed. And I look forward to continue our work together to improve the lives of those affected by hemophilia. Thank you so very much. Sir, it was the last vote of thanks. So, tea is being served outside, so please help yourselves.